Good morning, Satish. Good morning to Dr. Bafna.
Good morning. Sir is here with us.
Yes, we can see him.
Pachauri boss,
Yes,
please.
just let me give one or two slides for the introduction. Then it will be to you. And once, is it live or no?
Yes, sir. If we are live, you can start.
Give a countdown, please. Countdown.
5, 4, 3, 2, 1, start.
Yeah.
Again, good morning,
Good morning.
all
Good
dear
morning.
friends.
Good morning.
Good morning.
Good morning to all.
Yeah.
Good morning to all.
Yeah.
And on behalf of Sun Pharma, this is D. Mahendra Varman, Deputy General Manager, welcoming you all for this webinar. This is the 5th webinar series on Explore ENT with the Legends. This is the 5th one, and this is the 4th one with Dr. Satish Jain and team. Yeah. Today we have in the webinar Dr. Satish Jain, Dr. Rajeev Pachauri, which is this Explore ENT with the Legends is the brainchild of Dr. Rajeev Pachauri, which I would like to make a special mention here. And we have moderators today, Dr. Parmita Saha and Dr. Pawan Singh. We have today a very, very special guest, Professor Dr. K.P. Morwani, who's attached to Mumbai Hospital Hiranandani. And welcome to you, sir. So once again, my heartiest welcome to all of you and all the viewers today. And Sun Pharma, as a company, which is the largest pharmaceutical company in India, we are committed to academic activities, especially for the ENT fraternity. And we vouch and we assure you that this type of commitment on CME activities and educational activities will continue forever, especially for ENT faculty. And with these small words of introduction, then I would like to hand over this session to Mr. Amrit Sahai, our Senior General Manager.
Yes, thank you, Mr. Mahendra Varman. So a warm welcome to our eminent speakers. Very special thanks to Dr. Pawan and of course Dr. Morwani and Dr. Jain, who is always a torchbearer. Thanks a lot, Dr. Rajeev Pachauri, for being a torchbearer for organizing this event. On behalf of our speakers, I think I can commit all our viewers that this series of our webinar, and very especially today's webinar, is going to be really unmatched, and all of you are going to get a tremendous benefit out of this webinar. As you know, Sun Pharma always promoted scientific contents, whether related to ENT or any other disease. Being the #1 domestic and 4th largest globally largest company, we understand fully the need of our patient welfare and maintain an uninterrupted supply chain to really ensure that our medicines are available in every nook and corner of the country and many parts of the world. So with this small introduction about Sun Pharma, I welcome all the viewers once again. And without further ado, I would like to hand over the session to Dr. Pachauri. Over to you, Dr. Pachauri, sir.
Thank you. Good morning, all my friends from my state, my country, abroad, to this 5th expert committee, or you say Explore the Legends show, and 4th with our famous Dr. Satish Jain. And I think last, all of you know that we finished our rhinology part, and this is the starting of otology, and we have started with the cadaver dissection. And today, starting from pinna till inner ear, you will go the journey along with the Satish Jain, and it will take 4 hours, 4.5 hours, I think, and all will enjoy this part. And I would like for this dissection, this starting of the otology, again, I would like to thank Sun Pharma for conducting this thing. Actually, why we need this thing? Because hello.
Sir, audio. Your audio is missing.
Yeah, it's okay now.
Yeah. Okay.
So hello.
Yeah, now we can hear.
So just see, just see this instrument. It is, I think, any ENT surgeon, any otology surgeon, otologist we should respect this instrument because it is just like a stand which we keep it for our holy books. Like,
ये कौन सी पिक्चर
and
जा
this
रही
is,
है?
this is just like a holy book, which like for us, Ramayana, Quran, Bible, whatever.
उसको हटाओ.
Just respect this instrument and use this temporal bone and read it. Do it as much as temporal bone dissection just to get the best of your knowledge. And whether you're starting a practice, whether you're working 5 years, 10 years, 20 years, 30 years, but I think we should all should go for the temporal bone dissection courses, which are occurring in our part of this part every month, every alternate day. And I think we have our legend, Professor Morvani, who is the father of temporal bone dissection courses in India. And we have our Pawan Singhal from Jaipur, our team, Dr. Satish Jain. I think that I will not take more time. I think this is to go to Dr. Satish Jain and Professor Vapna is standing there. So over to Dr. Satish Jain, and please take the mic and start the show. Thank you.
Thank you, boss. So, good morning, everyone. It's a
Morning,
pleasure having you all again with us. And before I start, I would like to acknowledge my thanks and regards to the team Sun Pharma again for making this happen. Thank you so much once again.
Thank you, sir.
And big thanks to the Dr. Pachauri, who is the mastermind behind organizing all these webinars. Big thanks to Paramita, who has been outstanding in coordinating everything and putting up all the questions for everyone. Today is a special day for us to have our own, who is considered as a father figure in our otolaryngology specialty in our country, Professor K.P. Morvani. You know, when we talk of temporal bone dissection, he is amongst the few pioneers who started this series of temporal bone dissections in our country. And for everyone information, he has organized more than 100 courses, temporal bone dissection courses in our country. And those courses are different from other courses. I have been part of the course, which that's how my learning in temporal bone started. Pawan has been part of it, and many more. He has trained thousands and thousands of ENT surgeons across the globe. And in those dissections, the beauty was the dissection was not given for 3 hours, 4 hours. Those were the times when the students were given temporal bone to dissect for 3 days, each and every part in detail. That is something special, which is never happening anywhere. So thank you very much, sir, for being with us. And I'm sure everyone will be benefited with his experience, his comments, his suggestions today. Besides that, we have our own Professor Pawan Singhal with us, who is, you can see on the screen, very dynamic, ever energetic, who is a professor in our esteemed medical college in Jaipur here, the SMS Medical College. And you can see his level of energy being organizing so many courses during last 3 months, you can see, and being part as a faculty of many of such courses. Thank you, Pawan. Pawan has a deep interest in otology. He is now handling the cochlear implant program in our state, sponsored by government of Rajasthan. Earlier, Monish was doing it, and Monish and Pawan has raised the name of SMS in Jaipur to every level. Thank you for being with us. Before we start, I would like here is an emotional moment for me to introduce someone who is everything for me. And believe me, whatever I am today, I owe to this simple man, one and only, my teacher, Professor A.S. Bafna sir, who has always been encouraging, supporting, teaching. Each and every walk of life, he has been with me. In all ups and downs, he has always supported me. You know, in my PG days, when I was looking for the temporal bone dissection, how to learn, he gave me his personal so that you go and bring the temporal bone, cut from the dead body and dissect. You organize your instrument. I don't know how to do. You buy, borrow, or steal. You have to do it to learn this. And this has been my backbone of my learning the cadaveric dissection. And more than that, I was so fortunate to have one more person, Madam Bafna, who has been a professor of anatomy in the SMS Medical College for more than 30 years. and now she is serving as a emeritus professor in this medical college where we are today. This is a prestigious state-of-the-art medical college where we are dissecting today. It's a Jaipur National University. So here we have Madam Bafna, and I remember we have organized more than 30 dissection courses earlier, and only because of Madam, she would do everything to provide every backup of cadaver, temporal bones, everything we wanted for dissections, organizing seminars, organizing hands-on temporal bone and skull-based courses many a times in Jaipur, in the SMS Medical College. And this is simply because of Madam. Thank you, Madam, so much. And today, once again, you have done the same thing. And today we have professor in this college, Professor of Anatomy, and our principals are here. And they have always been supporting us in all these courses. This particular prestigious college I am associated with is one of the, I would say, prestigious center in our country for medical teaching. And they have recently had a huge MOU and tie-up with the Harvard University for propagation of or exchange of knowledge of students from here and there. So thank you so much. And before now, after this, before we start, I would request Professor Bafna Sahab to say a few words and bless our seminar so that we go ahead.
Very few of you would know me. I retired long back from SMS Medical College, and I would say I was lucky to have Satish as my one of the very good students, and he has put in very hard work and is full of knowledge. Like my wife says that he speaks Gray's Anatomy, and Satish is one of those persons who has put his soul into ENT. And I'm very happy today. The level of teaching and training in our country has come up to this level, and a lot of credit to this goes to some of my friends of the same age, like Dr. Morwani, Dr. Kirtane, and many more. And I'm so happy today that Dr. Grover, Pawan Singhal, Satish, they are doing so well. And I must compliment that this kind of a workshop is being held, which is being watched all over the globe. So wish you all the best, and I'm very sure that Satish would be taking you to a really whirlwind kind of a dissection of the inner ear. So I hand over now to Satish. Thank you.
I have a few words for Dr. Bafna. Hello, friends. All teachers did not promote their students. All teachers do not promote their students. Bafna is one of the teachers who promoted Satish Jain. He sent Satish Jain to Dr. A.B.R. Desai. He sent it to Dr. Morwan. He sent it to Kirtani. Bafna is just a good relation with so many teachers. He could help him to train. And teachers like Bafna are people who promote the boys like Satish, like Singhal, and I think it's good to have a teachers like that.
Now I think we are starting with the dissection. Dr. Satish?
Yes, boss.
Okay. I think Dr. Paramita, any question left last time? Dr. Paramita is here. And any comments from you, and any questions, any good questions left out last time?
There must be so many questions. You know, when you do a rhinology session, there must be 60, 70, 80 questions. Paramita, kitne question hai?
Today we have received almost 150 questions regarding today's discussion.
Hello.
Hello.
Yes, boss.
Yes.
More and more questions will make it more and more interactive. So I would request you to
login.
Feel free to interrupt me any point of time, again and again, to discuss more and more questions that will be beneficial for everyone, including us. So I would request Paramita to keep interrupting me, kill me with questions today.
Yes,
This
sir.
is the most important session when it comes to learning the anatomy.
Yes, yes.
Today's
That's true.
session is solely dedicated to anatomy of the temporal bone, which we all know is considered to be the most difficult, most complex structure in the body, which we are going to discuss today. We'll have more webinars coming up with more extensive dissections, more surgical procedures. Each and every surgical approach we'll discuss in detail in the coming up time. So today will be more and more focus on anatomy, because that is the backbone of your surgical approach, surgical planning and execution of the particular surgical step. So like temporal bone, embryologically, it is made up of 4 parts. What we have done today, before we have started, let me tell you with what I have done today. On the right side of this cadaver, this is a formalized cadaver I am using. We have a fresh temporal bone also standby in case we need. So this is the right side. What we have done, we raised the post-auricular incision flap, and what I have done, I have already raised. This we always do in our live surgery also. We raise this inferior based flap. This inferior based flap is a flap based on the occipital artery to expose the mastoid cortex. So in case you need this flap to line the mastoid cavity later on, you can use it, otherwise you can replace it back. So that's something which doesn't give any harm, but once it is used, required, this is something amazing based on a very, very reliable vessel, that is occipital artery inferiorly, and the vessel comes from the deep, so it is very, very important to preserve the vessel, and it is simple to preserve at the same time. Number 2, before moving on to the surgical part, deep into the temporal bone, here I would like to focus on certain other issues also on the superficial part. And that is again very important. In the temporoparietal region, see above the ear, above the temporal bone and around the temporal bone, there is a lot of tissue available. And this is important from the reconstruction point of view. Nowadays, with the more and more advancement in the lateral skull-base surgery, we need more and more vascularized tissue for the reconstruction. And the ear is surrounded by ample of such tissues. So every otologist and the lateral base skull-base surgeon must be well versed with all these flaps along with their vascularity surrounding the ear. Before I go to the temporal bone, quickly I'll take 5 to 10 minutes to describe what all common flaps one can use around the ear to reconstruct this region. So like I made this incision. See in layers, if you go from superficial to deep, this is the scalp, and just underneath the skin of the scalp, the most superficial layer is one of the most reliable flap that consists of, that is superficial temporoparietal fascia. And that region of the superficial temporoparietal fascia is a richly vascularized area with the branches of superficial temporal artery. With its 2 branches, frontal and parietal, you can raise a flap around 20 centimeter in dimension all around based on the superficial temporal artery. The only thing you have to be very cautious is not to damage the vessel, which is very superficial. When you raise the flap, you have to be just underneath the skin. You can keep even the hair follicle, the basis of the hair follicle into the flap, rather than damaging the artery. So that is too superficial. And that entire flap can be used for lining the temporal bone defects, even for obliteration. It is quite thick, as well as sometimes people are using it even for the endoscopic skull-base reconstruction when no other flap is available in the nose. It can be used for other oral and nasal defects. It's an amazing flap, that is temporoparietal fascia flap. Deep to this is a pure temporalis fascia, which we commonly use for our tympanoplasty procedure. This temporalis fascia again is completely occupying the entire temporoparietal region. See this? This is temporalis fascia, which we use for our tympanic membrane grafting. It is covering the temporalis muscle in the depth. This entire temporalis fascia can be utilized as a vascular flap based on the middle temporal artery. See, this superficial temporal artery, as it ascends over the zygoma, before ascending on the zygoma, it gives a posterior branch here. This is, see, look at this. That is the region of the axonotary canal. Above is the zygomatic base. Here, just before ascending, this artery is anteriorly here. Just before ascending on the zygomatic arch, it gives a branch which goes posteriorly, that is middle temporal artery. And it ascends on the periosteum right up to the superior temporal line, and it gives arcade of branches through the muscle to the temporalis fascia. So this temporalis fascia is richly vascularized again by the middle temporal vessels, and based on this vessel, you can use a vascularized flap which can be used to line. Since this is a thin fascia, it can't be used for obliteration, it can be used for lining the defects, lining the temporal bone defects, lining after huge mastectomy defects, you can use this fascia. Deep to this fascia is another thick layer that we all know is the thickest of structure in this region is the temporalis muscle. This temporalis muscle is the thickest of structure in the temporoparietal region. And you know, this is the big source of vascularized flap for the surgeons. Earlier, when this temporalis muscle flap was described by the Rambo as a single flap, huge single flap could be used for temporal bone defects reconstruction. It's a vascularized flap based on different vessels. Now, after having understood the vascular and the nerve supply of this temporalis flap, this is so beautiful, amazing, and unique as compared to other muscles in the body. It has a segmental nerve and vascular supply, which enables us to use variety of temporalis muscle flaps now in the practice. More than 15 kinds of temporalis muscle flaps can be used now for reconstruction of defects. So, in brief, how the vascular supply makes it happen? See this temporalis muscle right from anterior to posterior. Right from anterior to posterior, from the posterior aspect of the orbit to the occipital region. This entire muscle is supplied from the deep aspect with the vessels. By and large, the anterior 25% of the muscle is supplied by the anterior deep temporal arteries, which are branches of maxillary arteries. The middle 40 to 60% is supplied by the posterior deep temporal arteries, and the posterior 25% or so is supplied by a combination of posterior deep temporal and the middle temporal vessels. Now, the beauty is all these vessels enter the muscle from its deeper surface, and they form the arcade of vessel throughout the thickness of the muscle to come on the superficial surface of the muscle. Add on to this, on the superficial surface, there are a lot of anastomosis with the superficial temporal artery. So, owing to this kind of anastomosis and the arcade of vessel, this muscle is richly vascularized. Segmentally, you can use the anterior flap separately based on the anterior deep temporal, middle flap separately, combination of middle and posterior flap separately according to the size and site of the defect. Accordingly, the nerve supply, you can use the innervated muscle so that the muscle doesn't get atrophied too much. So that's how the beauty of the muscle. We must be able to utilize this muscle appropriately, optimally for the required site of the defect wherever we need. So that is the huge muscle, and we can use it differently with single pedal, bipedal, tripedal, quadrupedal, whatever. Deep to this muscle is the periosteum. Periosteum or the pericranial layer, which is richly supplied by the middle temporal vessels. And those vessels run underneath the muscle through the periosteum like a railway track. The artery and the vein, the middle temporal artery and vein, right to the superior temporal line. And that periosteal flap, we have number of indications now in our practice. We are using it for various reconstruction. Lining, covering the cochlear implant array sometime. We have used in certain cases as a pedicle flap for tympanic membrane reconstruction. See what we are using presently, or we have been using, is a free graft for the tympanic membrane reconstruction, mostly temporalis fascia, sometimes perichondrium or something. That is a free graft which can get necrosed because it has to acquire blood supply, and it has a success rate from 90% or so or above. With this introduction of a pedicle flap with a vessel along, there is no question of necrosis, and you can almost reach to 100% in terms of success, in terms of avoiding the necrosis of the graft. We use it for supplementing our material, what we use for the temporal bone CSF leak closure. So that middle temporal artery based periosteum flap is a wonder flap. We can use it for various indications, and we have certain procedures we have used and uploaded on YouTube. You can go and watch how this middle temporal artery flap is so useful. So this is about surroundings before you move on to the temporal bone. Paramita, any questions before we move ahead? Hello?
Yes, right now, as such, many questions are there.
Boss, your volume is so low.
Hello?
Yes, boss.
Now it's, yeah. It's relation with the frontal branch of the facial nerve, facial artery, the relation of the temporalis fascia with that artery. Was some
Frontal branch of the facial artery.
frontal branch of facial artery. Any relation? Because
There is no frontal branch of the facial artery, boss. Can you repeat the
relation
question?
of the facial artery? Yeah, because
The facial artery, yes, is an important branch of the external carotid to supply the face, but it doesn't have as such any frontal branch. It has an angular branch, goes along the angle of the mouth and the side of the nose towards the angle of eye and supply the entire face, buccal mucosa and all those regions. It has nothing to do with the frontal area, which is supplied differently by the superficial temporal and the deep temporal vessels.
And okay. And one people want more comments about that rail track system, that vascularity, and that use of that flap for different indications like the temporal fascium as the obliteration or as a graft. So I think it is not possible in cadaver, but I think live we will try that we can show them how we can use it for different purposes.
Yes. So in the coming live webinars, we'll be showing in the live procedures accordingly wherever the particular flap suits. Okay?
Yeah.
Hello. So now coming to the temporal bone proper. Movani sir, feel free to comment anytime. Pawan, anytime, feel free to interrupt me or anything. Your input and suggestions are valuable.
Yes.
So coming to the temporal bone now per se, what you see is the outer surface of the temporal bone. Temporal bone embryologically, this is now the topic of interest. And today, after the basic dissection, we'll move on, which is the emphasis today, is on the anatomy of the inner ear in detail, which is very important for the cochlear implant surgeon to understand the in-depth anatomy of the inner ear. So now, the temporal bone embryologically is made up of 4 parts. The most superficial, what you see in your picture, whatever temporal bone you are seeing is only one part, that is squamous part of the temporal bone. That is the most superficial one. The deeper parts are the petrous bone, petrous part of the temporal bone, then the tympanic bone, which is making the circumference of the canal, and the 4th part is the styloid complex, which I am going to show as I go deeper. The styloid process is the outside process extending from the temporal bone, and the styloid prominence goes inside, covering the facial nerve up to the 2nd genu, forming the posterior wall of the mesotympanum, having number of prominences, caudal eminence, pyramidal eminence, styloid eminence, forming ponticulus, subiculum, all are part of styloid complex. So there are 4 parts of temporal bone: the squamous, most superficial, the petrous, the deeper one, the styloid complex, and the tympanic. And they join each other at various places, superficial, deep, anterior, posterior, and form almost 34 suture lines in the temporal bone. And that's how the ossification of the temporal bone finally leads to one bone. And these have a value. I'll show as I go deeper the value of these suture lines. If any of these remain patent, which may be a communication of spreading an infection to the cranial cavity. So all these suture lines, temporal bone makes the temporal bone a very, very complex structures. Now, on the surface, whatever landmark you are seeing are very important. See this? This is the axon artery canal. Here is a prominent part that is known as spine of Henle, is a part of squamous part of the temporal bone. Here is the spine of Henle. Then above that is a prominent line which is fading out posteriorly and prominent anteriorly. This is the root of zygoma. That is the root of zygoma. And below is the prominent process that is known as a mastoid process. Mind it, mastoid is not a developmental part of the temporal bone. Mastoid develops after the birth with the fusion of squamous and petrous part of the temporal bone. All lateral part surface of the mastoid is formed by the squamous part of the temporal bone, and the entire deeper surface is formed by the petrous part of the temporal bone, and they merge together to form this process. Sometimes they don't merge completely and leave a septum in between, joining both the parts together, and that persistent septum is known as petrosquamous suture line, petrosquamous septum, or the corner septum. And that is important when you drill out to look for the antrum, and you may be lost if you don't pick up this anomaly. So, coming on the surface.
Satish boss.
Yes.
Satish boss, when you encounter corner septum,
Yeah.
then what your advice would be the juniors to approach for the antrum?
Okay, that's a very important question, Pawan. So like if I am drilling the mastoid, I will show when I drill. If what you look for it at the McEwan's triangle in the depth is the mastoid antrum. Now, if you find a thick septum above, you may be confused, either you have gone through the antrum or you are lost to some other place. So now the best way is take the reference of the canal wall, the depth of the canal wall from inside, and if you are lateral to it, that means you have not reached the antrum, and you can further go through the septum to look for the antrum. So keep an eye anteriorly on the medial aspect of the canal wall, the tympanic annulus. That will guide you whether are laterally on the septum or you have gone through in the depth. Okay? Now, these prominences
I just want to
are...
emphasize the point which Pawan was trying to make. Because Pawan was trying to ask you, as inform the boys, that if you think you're antrum, when you're lateral to the corner septum, people go anteriorly and go and damage the facial nerve. This is what point you want to bring it out, right, Pawan?
Yes, yes. If you are lost, you can go deeper and damage the facial nerve as well. Once you are lost, you are likely to give complications, right?
Boss. So boss, in that condition, I think we can advise them to go ahead with the dural plate.
Yes.
They can follow the dura and then they can reach to the antrum. And
all around. See, this is the surgery of landmarks. As we go proceed, I will tell you. So when you go deeper, you have to take into consideration certain landmarks to facilitate safe surgery. So now, on the surface, we saw this, the zygoma, which is fading as a line here, known as the inferior temporal line. This is a useful landmark for what? And that as a safety guide with it. This is a landmark coinciding with the roof of the mastoid, coinciding with the tegmen antri. The reason is, why it is safe? If you follow this, drilling along this line, your tegmen is still few millimeters above. So if you take into consideration this line as a landmark, your tegmen stands still few millimeters up to save you from injuring the skull base and getting a CSF leak. So this is a very, very important landmark for us. Inferiorly, this is the mastoid process, which is ending inferiorly towards the neck with a lot of muscles attached on the surface of the mastoid process. The superficial, the most superficial one is the sternomastoid muscle. Deeper to that is the splenius capitis muscle. Deeper to that is the digastric, which is a very, very useful landmark. I will show you when I come to the dissection here how digastric can be used as one of the most reliable landmarks for locating the facial nerve in the lower vertical segment, close to the stylomastoid foramen. So these are natural landmarks given by the God, and taking the advantage of these landmarks is always useful to prevent complications, to find out the normal structures in an easier way. Now, so,
Satish,
yes.
Satish, Dr. Amit Kesri from Lucknow, tips for the junior, how they can prevent injury to the low-lying dura or forward-lying sigmoid sinus.
Yes. Yes. That's what I'm coming to, boss. I've already mentioned one point. This is the zygomatic base forming the inferior temporal line. See, I'm drawing a line here, right on the inferior temporal line. I have told you it is a safeguard, because if you take this line as a landmark, your tegmen is still few millimeters up. Now I am telling you how how it is related to the tegment. How above the tegment to this line, how above is the tegment? See this. See this, I am going up just to show you that tegment plate. Can you see the change in colors? This is the tegment. Can you see? What happened? The video is not going? क्या हुआ?
Theoretical presumption that when you're going to use a vascularized flap, your results are going to be better. Okay? This is what Hong Kong flap is. And always flap, you take a small muscle flap, posterior, Satish Jain and I, we lift the posterior flap posterior inferiorly.
Okay.
What's क्या हुआ?
Muscle just posterior to the posterior canal wall. You take a rectangular piece of muscle and which is stuck to the anterior canal wall. Okay? So that also serves the same purpose of reducing the size of partly obliterating or reducing the cavity partly, not obliterating the cavity, partly reducing the size of the cavity. That's a Palva's flap. Palva was a person who was part of the Hauser Institute for your information, and he left them in late 70s.
Guru, क्या हुआ?
Okay.
Then she was asking me question on Palva's flap, you know.
No, I think we are still not getting sir. Sir, by then you can also tell us, as a question from Sambalpur, the doctor wants to know how the action of temporalis muscle gets rehabilitated for mastication after taking any flap.
See, most often we are not using a total temporal muscle flap. Okay. Now, you do a hemimandibulectomy, for example, still you can masticate. When you're doing a hemimandibulectomy, you are taking mandible and all the muscles. I know that. So the God is a better person to help individual to get used to it. So if you sacrifice one muscle, a part of the muscle, your mastication doesn't get up to total.
Okay.
Okay, sir. Okay.
Romita, in that kind of flaps, an important thing which I learned from Satish Boss and Morwani sir, and when you are doing a metoplasty, you are going to sacrifice that flap because it is actively based. And there is one more flap known as Portman's flap, that is posteriorly based flap that you can just roll in the mastoid cavity sometimes.
I know.
So I think the inferior based flap in mastoid is a better alternate.
Because it has good blood supply as well.
And the most important about the inferior based flap is, see, for master we elevate about 2 centimeter width of it. For example, I can elevate 3, 4, 5, 6, 7 centimeter backward. This is and then we split it to convert the width of the posterior flap into length of it.
Yes, yes.
You can take a 6 centimeter, 5 centimeter flap going posterior, posterior, posterior. Okay, when you're taking this big flap, remember, when you're doing a mastoid dressing, those patients occasionally may require drainage unless you've done a good. Normally, we don't do a drainage, you know, and especially when there's CSF leakage, you never do a drainage. So you may require drainage. And most important, here I'm going to give mastoid dressing for longer time because when you do a mastectomy, there's a muscle under it. Your flap heals within 7 days so beautifully. But if I take too much of muscle, I'm taking longer one, then I would have dress it for 10 days. Not only dress it for 10 days, I may give better suture. You know what I mean?
Yes.
I must give better suture so there's enough.
Join करना उसको तो क्या करता है?
Let's network suture. Okay.
Yes.
So will you also advise that using too much of bipolar cautery can hamper the blood supply? Is that the thing that happens?
No.
While you're using the flaps?
See, whether you use bipolar, you use unipolar, you use a bone wax, or use a surgery. Where are you going to use it when the bleeding is giving you problem? Nobody cauterize something which is not bothering you. See, if the blood is bleeding is bothering you, you go and coagulate that whatever method. See, a lot of people still don't have bipolar cautery, for example. So at times we can use a unipolar cautery with minimal negligible current. You know what I mean? Outside, you know, if you're 30, you come down to 10, for example, you know. And so you can unipolar. And sometimes I say, let's say I'm Dura. Don't use directly, indirectly. Put a probe, you know, round body probe on it and touch it indirectly. So you can use a unipolar, minimum current, not directly. This is on Dura or Sigma channel. On the bone, you're not worried about. Bone, the bone wax is also a very good thing. Only problem is a lot of people don't have bone wax. And people don't know. Johnson & Johnson company makes a bone wax. I tell people, and it's very cheap. Even if you buy it and don't use for bloody 5 years, if you throw it, doesn't make a difference. You know what I mean?
Yes.
Have a bone wax. Sometimes there's no alternative bone wax. Not very often. Of course, you can have surgery. Surgery, most of the ENT surgeons do not have. Of course, most of the ENT surgeons have their form only. They don't have surgery, they don't have bone wax. And some people don't have bipolar cautery also. Unipolar cautery can do the work if you are using minimal current and on the soft tissue, go indirectly, not directly with the cautery. Pawan was Pawan, just tell you about Pawan. He came to me twice for dissection. Both the time he was the best dissector. Pawan, 15, 20 years back, you were the best dissector.
2003, then 2004, then 2009.
Yes, he has come few times. Every time he was the best dissector. Right? वो सर्टिफिकेट तो मुझे नहीं पीछे मेरे को तेरे पीछे का सर्टिफिकेट वो सर्टिफिकेट नहीं दिख रहा है.
How often you remove the mastoid tip in your obliteration after taking the entry flap? Means how often you remove the mastoid tip to get a better obliteration?
Let's say not very often. Let me tell you, I'm working in city of Bombay. Let's say about 30 years back, the disease was very extensive. For example, why colostoma surgery we do post outside in? Why do we do outside in technique? 40, 50 years back, when we used to get a colostoma, we used to get an extensive colostoma. You know, it was the whole cortex was gone. Mastoid abscess was such a common entity. How often you see? I'll ask a person like Pawan who's in a medical college. How often you see mastoid abscess nowadays?
No, rarely.
In let's say 40 years back,
not very common.
40 years back, if I saw 2 cases in a week in a municipal hospital mastoid abscess, today you are seeing 2 cases in a year. You know what I mean? So when there was an extensive disease, when you went outside it, there was no problem. Now we are disease where the colostoma starts, almost genetic. See, when you are taught surface anatomy, what we are taught appendix, you know surface anatomy, so you give McBurney's incision. Why we emphasize on inside out mastectomy? Disease jidhar hai wahan se jao. Okay. On the other hand, I am a patient with a mastoid fistula. Of course, I am going to go for mastoid fistula because I want to follow the disease. Today, I am very thankful to the endoscopic ENT surgeon because they are popularizing inside-out technique. I'm not an endoscopic otologist, but what they are popularizing is the right technique, but that's the only way they can do it. There's no way they can come from mastoid backwards. So, colostoma has to be done inside-out. Our simple principle, follow disease. If you have mastoid fistula, na, go for fistula, okay? You have mastoid abscess. You're going to follow the track. So this is important. What Satish was trying to show you, that's very important. And what Pawan pointed out, this coronal septum. To avoid damage to the, people think that temporal line is a line where the tegmen is or dura is. They don't go above that. What Pawan was trying to point out, go more posterior superiorly. There's no harm exposing the tegmen or even occasionally dura, exposing the dura is not going to do any harm than going into the fashion of when your coronal septum is. Right, Pawan, you want to put anything in that area?
That was important. That's what I wanted to convey there.
Yeah. So this, when people ask you question, you should know what answer is expecting. Then you become a good orator. You know what I mean?
Yes.
To get an orator, सवाल वही पूछता है, जवाब दूसरा देगा तो मजा नहीं आता. Yeah, Pramita, you have some question.
No, I'm saying this is for the audiences. I'm getting quite a few requests for restarting the dissection. There is some issue with the.
बोलो भाई.
To the flap we were talking about, like the question of using the cautery. I think if you are in the right plane raising the flap, you can use monopolar also, but you have to be cautious at one point only, at the posterior margin of your flap. That is where the mastoid administrative veins comes.
Hello.
That complete, and there comes the use of bone wax or
bone wax.
Hello.
So we are back.
Yes, sir. We are back.
Yes, Paramita. There was some technical issue which is sorted out. Okay. Are you getting the picture now?
But lots of echo is there.
Could be because of this hall. Are you getting the picture?
Yeah, we are getting the picture. Good picture.
Okay. The picture good? Okay. So now, moving to this cortical dissection, as we discussed, we need to take into consideration certain landmarks to add on to our safety.
Sir, 1 minute, sir, 1 minute. I think there is some other one who's connected next to you, I mean the same connection.
Yes.
There's an echo is coming, sir.
And there might be something else.
Two PCs are connected. Two computers are connected to
Hello,
them.
as Pawan is saying, if the speaker is pointing towards Satish, there'll be echo. Turn the speaker in that room. Turn the speaker away from the speaker, from Satish.
Yes.
Dinesh, tell your boys to turn the speaker
No.
because echo jo
Yes,
aa raha hai na
yes,
Satish,
already, sir, already
now
done.
is
There's
it
no
okay
echo.
now?
I will, the hall is little small now, so that's something kind of a thing is coming. So don't worry, I reduce the volume of speaker.
Sir,
Okay,
is
sir.
it better
Thanks,
now?
Dinesh.
Is it better now?
Yeah, it's
It's
better.
okay. It's okay now.
Okay, so what we were doing as a superior limit, we took into consideration this inferior temporal line, which was demarcated by the zygomatic base. And what I am trying to show, if you follow this above, see how far is the Tegman plate. It is almost
Sir,
4 to 5
1 second.
millimeters above. You will
Yeah.
find the Tegman
Satish,
plate.
we missed to tell them about the McEwan's triangle.
Yes. So McEwan's triangle was initially described as a triangle posterior superior to the spine of Henle. But now since the approaches are expanding, we'll use the terminology as a triangle of attack.
Yes.
Triangle of attack is what? In between the critical structures, above is the tegmen, above is the tegmen, and posteriorly is the sigmoid sinus, which is a continuation of transverse sinus. In between these two, along with this exomotory canal as your anterior limit, this entire triangular area can be considered as a triangle of attack, wherein we need to accentuate all these cells to go deeper. Can you see this?
Yes, sir.
Hello?
Yes, sir.
Now in this, still your posterior limit is not seen. The reason is this sinus is little deeper and surrounded by lot of cells known as perisinus cells. This sinus could be, sometimes we find it very, very superficial. During live surgical situation, you have to be very, very cautious. Second is the variance in the pneumatization of the temporal bone. Temporal bone of every individual has a different pneumatization process that depends upon several factors, and all these cellular tracts leading toward the petrous apex we need to understand. Chandira. So now as you go in the depth, I will show you the change in color again here posteriorly. That is going to be my posterior limit. This is going to be my superior limit, and anteriorly is going to be the canal. So that would be sort of triangle of attack if you consider, wherein you can accentuate all these cellularities to go deeper. Conical burr dena. Give me conical burr. So I am quickly accentuating these cells to go to the important areas. And as I go deeper, I will tell you certain important areas, again certain landmarks to be taken into consideration. So quickly, this is, I am using a bigger burr. This used to be the standard teaching. If you ask Morwani sir, use the biggest possible burr for that particular region you are working. It's not that what size burr do I use. Whatever biggest possible you can use for that region. Can you see the change in color in the deeper part?
Yes, sir.
That is your sigmoid sinus or the lateral sinus. Can you see all this very clear?
Yes, sir.
Is it clear or not?
Yes, sir. Very clear.
And what I am accentuating are the perisinus cells. And when you accentuate this and go beyond, keep on saucerizing. This is very important in a live surgical situation, to keep on saucerizing. This saucerization doesn't allow ultimately to give you a bigger cavity. Otherwise, on the other way, it will allow the surrounding tissue to fall inside to ultimately give you a smaller cavity if you are doing a canal down cavity. Now, we have our posterior limit here, sinus. We have our superior limit, that is the tegmen here. And we have, see this curvatures of the tegmen. Now with the advancement in the radiology, in the live surgical situation, very often we get the CT scan done, and with a multiplanar CT scan, you can have a fairly good idea of the curvatures of the tegmen in the particular patient. And these are sometimes very, very important to prevent complications. I give an example. See this curvature, the tegmen curvature, it is inferiorly as I am going anteriorly. Can you see this? And it is superior as I am behind. We have seen such complications where this tegment curvature is not constant for that matter. As I go deeper, it may go further up superiorly. And if we don't take into consideration these facts, we may injure the important structure deeper down. And we have seen, we have got certain cases when the surgeon has damaged the facial nerve, ignoring or without knowing the fact that the tegment has a different curvature which were overlooked. So now, if I am working here, see above my tegment plate, here behind my sigmoid sinus, I am working in between to excentrate all these cells. In a mastoid surgery, in subtotal petrosectomy, all these are important to excentrate each and every cell tract, possible cell tract from the temporal bone. And see this area between the sinus and the dura, which people call it as a sinodural angle. To be practically speaking, from the definition point of view, this is not the sinodural angle. Sinodural angle is considered as a landmark owing to the vessels. So, what I mean to say, this is sigmoid sinus which is continuing or a continuation of the transverse sinus from above. See this, what I am exposing more and more. And at this point, at this juncture, here a vein joins the sigmoid, the transverse sinus to make it as a sigmoid sinus further, and that vein is on the superior surface of the petrous bone. This is petrous bone on the superior surface. If you see from above, that vein is known as the superior petrosal sinus. So that joins the transverse sinus. So this area between the sigmoid sinus below and the superior petrosal sinus above in the depth, and this triangular bone with lot of cells is known as the sinodural angle. It doesn't mean that a tegment plate and the sigmoid sinus forming that sinodural angle. So angle is in the depth between the superior petrosal sinus. See, the superior petrosal sinus will come in the depth, going parallel to the tegment plate, which is coming from the cavernous sinus joining the sigmoido transverse sinus junction, and this triangular region, many times if we don't clear this region, if you are dealing with extensive cholesteatoma, and if cholesteatoma is there, if this area is not completely uncovered, you may leave the disease behind.
Satish, 1 minute, can I come in for a second?
Yes, please, sir.
Satish, average ENT surgeon, this is for boys who are going to operate for MS or DNB. Sinodural angle to that ENT surgeon is a sinodural angle. You know what I mean? There's a tegment plate and a sinus plate exist.
Yes.
Our Pawan is sitting there as a professor. Ask him. From professor's point of view, that is a sinodural angle. So don't confuse the junior boys. So you are a skull-based surgeon. Your anatomy description is far superior than the most of our common ENT surgeons. Sinodural angle, as far as MS boy is concerned, DNB boy is concerned, is where the sigmoid sinus is the dural plate. Right, Pawan?
Yes, sir. Sir, one
Yes.
more.
See, this question was asked here to me by Dr. Halpesh Suthar from Gujarat.
Okay.
What is exact sinodural angle? To answer him, Dr. Halpesh Suthar, wherever you are, to answer this question,
Yeah.
this is sinodural angle.
See, superior petrosal sinus is a big sinus, like inferior petrosal sinus, superior petrosal vein, or sinus we call it. Some people call it inferior petrosal vein and superior petrosal vein also. Okay? So this is an important landmark when you're doing a CP angle surgery, you know. This extends from the top to the depth of the petrous bone.
Yes. So there is one comment I would like to make there, that all PG junior consultants should always regard human body, a cadaver and temporal bone, like a live one. Whenever you are dissecting, you should treat or respect it just like you are operating on the live patient or something
This
like
is what I say in workshop. When you're doing a temporal bone dissection, you think you're operating VVIP patient.
Yes, sir.
You don't damage the temporal bone. I tell them in workshop, you damage the temporal bone, I demolish you. This is what I tell them.
I've seen your anger.
You must respect your temporal bone, your temple, your dwara, your masjid, your minar, you know. It has to be respected like that and done a dissection like that.
So now, moving on further. See this, there are number of cells in the vicinity. We need to understand all these cell tracts and their pathways, the way they are leading to the petrous apex. So there are variety of cells around the tegment, sinodural region, around the sinus, around the tip, and there are principally three pathways through which they drain to the petrous apex. The one is supralabyrinthine, one is infralabyrinthine, going from here deep to the facial nerve, to the hypotympanic cells, and then to the petrous apex, and then other one is the infracochlear. We'll go, I will keep telling you as I go there. Now, one of the most important landmark, as I mentioned in the beginning, a very, very important solid landmark for the facial nerve is the digastric ridge. Now, what is digastric ridge? It's a God's given natural landmark. We all know how the facial nerve exits the temporal bone from the stylomastoid foramen. And that stylomastoid foramen is bounded by the mastoid process laterally and styloid process medially. On that mastoid process which is bounding laterally, on the medial surface of the mastoid process is a muscle inserted digastric. So if you follow the digastric, it will lead you to the facial nerve, medial to it, as simple as that. Now see, I am drilling away this mastoid tip. See this? I am hollowing out this mastoid tip to see from inside the insertion of the digastric muscle in the depth. See, you will see a horizontal line showing the insertion of the digastric muscle. Can you see this muscle?
Yes, sir.
This is the glimpse of the muscle, which is
you'll see a periosteum first, then you see the muscle.
Yeah, this is the glimpse. This change in color. See this? Very thin bone I have left over it. And if you follow it anteriorly, this will lead to the facial nerve just at the level of the, just above the stylomastoid foramen. See this? Yes. And that is the landmark I am keeping so that I will give you a reference later on when we reach to that part of the nerve.
For junior boys' point of view, I won't call it facial nerve, I'll call it fallopian canal. You're going to reach a fallopian canal, not facial nerve. Okay?
Okay, fallopian canal.
Yeah, from junior boys, you know, the boys are doing MS and DNB, they should know the right terminology in the exam. Right, Pawan?
Yes, sir. And sir, Satish was told a very beautiful thing, the change of color. It is all about play of color or change of color in mastoid surgery.
So this, in fact, I've been trying to emphasize it for so long, till like exposing the sigmoid sinus. Before you expose the sigmoid sinus, you see the change of color. Before you go to the tegment plate, you see the change of. This has been emphasized in depth by Dr. Yogopit, okay? Change of color, and sometimes the change of color is very, very gentle change of color.
See, it is hugely pneumatized temporal bone. See, all these cells all over, pneumatizing everywhere, and that is amazing. See this digastric ridge? This is digastric ridge as a landmark. We'll take into consideration later. Okay? Now, at this point of time, while excentrating all these cells, the landmark which we see or intend to see here, which is most important, again you can appreciate with the change of color. See, this is the big cell that is mastoid antrum, and what is there underneath is a huge impression of a solid bone. That is the impression of the lateral semicircular canal. Can you see the color change?
Yeah.
So this temporal bone, again, when we talk of the cochlear implantation in children, believe me, this entire inner ear and the middle ear is developed at the time of birth of the same configuration what we have in the adult life. It doesn't change at all in any morphology and configuration. Whatever my middle ear size, inner ear size configuration I had at the time of birth is today the same. There is no change. What all changes is the mastoid and the pneumatization of the mastoid process and the cells, pneumatization of cellular tracts, the curvature and the length of the extra-aortic canal, which can sometimes make your life difficult by making inaccessible the deeper areas. So, this extra-aortic canal curvature, the mastoid dimension and the cellularity, changes with the time, not the inner ear and middle ear. That remains of the same dimension what we have at the time of birth. So here,
I want to give information to the boys. People who want to do a cochlear implant surgery in pediatric age group, please go and do dissection of pig or goat temporal bone. Goat and pig temporal bone are equivalent to your pediatric bone.
Yes, yes. Yes, that's a very important thing you can get easily. So now, at this point of time, we have certain landmarks in view. Below is the digastric ridge you can see. Behind is the sigmoid sinus. Superiorly is the distinct curvature of the tegmen where it is quite inferior laterally. And see, as we go down, it is becoming more and more superior again. Now, I give an example of a surgeon, a junior colleague, who was taking into consideration this curvature of the tegmen and kept on doing drilling little below to it to save it and end up injuring the facial nerve. So always when you look for the antrum, keep hugging the curvature of the temporal bone. As it goes superior, you have to follow it to keep the important structures below. And if you have a pre-op CT scan, you can certainly have a full idea of each and every curvature of the temporal bone. That is the beauty of the radiology that can apprise you and prevent you from all these possible complications. Now, this is posterior canal wall. See, I am thinning the posterior canal wall to do some procedure. We will do all possible exercises on the temporal bone at this point of time. And the next exercise what I am going to do is the posterior tympanotomy, which is one of the very common approach for the cochlear implantation. This approach was described very early in 70s, but gone to disrepute and was not very popular. Later on, with the advancement in the cochlear implant science, this is again rejuvenated, you can say. And now the posterior tympanotomy is one of the most standard approach for a cochlear implantation.
Satish, it was described by House Ear Institute as part of intake canal wall technique.
Yes,
intake
for the aeration
canal wall technique, where posterior tympanotomy was performed.
For the additional aeration.
Yeah.
Yeah. Now, to carry out a safe posterior tympanotomy, posterior tympanotomy is a safe access to the middle ear from behind, from mastoid, through a triangular space lateral to facial nerve. And that is a safe region if you carry out within the limits. Limits means lateral limit is your tympanic annulus, so you don't damage them and enter into the exoneratory canal. Your medial limit is your facial nerve. Superiorly, I will show you as you come up to the fossa incudis, and inferiorly this triangle is enclosed by the chorda tympani when it arises from the facial nerve. So generally, as the chorda ascends laterally to enter into the middle ear, we take the chorda as a landmark rather than the tympanic annulus, as the chorda hugs the annulus immediately medial to it. So, in order to expose this, if I go into this triangular space, I would be approaching the middle ear, the posterior part of the middle ear, or what you call it as a retrotympanum from behind. And that will be a very good access without violating the exoneratory canal, without communicating to the exoneratory canal, to the round window, and is a useful approach for cochlear implantation. I would say the most popular approach for cochlear implantation. That is one of the indications. This is a versatile approach. So,
Satish, I just want to emphasize one point here.
Yes, yes, sir.
Before incus come, you can see the incus shadow.
Yeah, that's what I'm coming to.
Simple mastectomy. Now you can see the incus in your dissection, okay?
Yes.
You can see the short process. But before the incus come, people are doing a simple mastectomy in case of central perforation. This is a very good landmark. Look for incus shadow so that you do not, ball point doesn't touch your incus.
Yes, that's an important message. So, what I mean to say, how to carry out this posterior tympanotomy for junior colleagues who are aspiring to be cochlear implant surgeon in the simplest manner, to shatter your fear about the facial nerve, to shatter your fear about entering into the canal, you need to take into consideration certain landmarks. So my landmark number one is the dome of the lateral semicircular canal. Number one, the facial nerve as a horizontal segment come here in the circumference of the lateral canal, staying immediately medial and inferior to it, to come here as a second genu and then vertically going downwards. Until the level of the annulus below, lower part of the annulus, the facial nerve never comes above the level of the lateral semicircular canal. So, while creating this posterior tympanotomy, if you stay above the level of the lateral semicircular canal, you are unlikely to injure the facial nerve. And here now we welcome One of our
Hi,
dear
Satish.
friend, who is actually brother to me, Dr. Ashish Bhumkar, joining us
Continue.
to
Hello.
illuminate us with more knowledge. Ashish, you'll all know, is a dedicated otologist. He is world famous for his pinna reconstruction work and giving his services to many countries. He's been invited as a faculty to demonstrate pinna not only to ENT but plastic surgeons.
Continue dissection, please.
Yes, my dear. I know if I talk about you is endless, but in brief, his passion for otology is different from others. He is like a master craftsman. He believes in small things, creativity, and he has created many of the surgical techniques for stapes. With his special interest on the stapes, he is here with us to illuminate more today. Thank you, Ashish, for joining.
Yeah. Thanks, Satish. Thanks, man.
So, for the posterior tympanotomy, my first landmark is this lateral semicircular canal. The second landmark, like Mohan sir said, this is very useful, the incus. Incus protects the facial nerve like mother's lap. You know, this horizontal part of the facial nerve is medial to the incus. Then this incus has a short process here, housing in a bony fossa here with a ligament, that is fossa incudis. And this fossa incudis is immediately lateral to the facial nerve. So now, if we take into consideration this incus as a line, your facial nerve is always below it. That is the beauty, that is a safeguard when you are doing posterior tympanotomy. See now, still I am using the cutting burr, still I am using the large burr.
You are using it because you are seeing the cells. Moment the cells disappear, then you will be going to diamond burr. Are you right?
Yes.
So far you can see the cells in any part of temporal bone. You can use proper size of cutting burr.
And one other thing which has been inculcated into me by Movani sir since beginning, not to use pressure on the burr point at all.
Correct.
Never ever use any pressure on the burr point. That is important to prevent complications. That is the biggest source of problem, complications one can give.
Use it like an artist.
He is on a cutting bar, he is feather touch. Look at his movement. He's not going deep, he's not only pressuring, he's almost a feather touch.
The important thing is look at how evenly he is thinning the posterior canal wall. Evenly. I think that is where people tend to go wrong.
Yes, Satish, you notice the important thing. At the same time, I am just keep on thinning the posterior canal wall.
Evenly.
See now what I am trying to show you.
Yeah.
For everyone where the facial nerve is. Pani dal jo. See, when you are using the diamond burr, again a very important point.
And
use copious irrigation.
Approaching it more distally.
Use copious irrigation while using the diamond burr. Diamond burr is more traumatic.
Let me just say that. Diamond burr, width of the diamond burr wider than the width of fallopian canal. Okay?
Yes, that is important. Can you see the glimpse of the facial now? The fallopian canal?
Yes.
Again the change of color.
Little change of color, yeah.
This is a formalized cadaver. In the live surgical situation, you will find more pinkish.
Yes.
Now what I am trying to show here, see my landmark, which I am trying, why I could recover it.
Bone superiorly, so that you are protecting incus from.
Yes. I am leaving this bone here to protect the incus from vibration injury. Second, I am taking the landmark into consideration is short process of the incus and stay in the line. See that?
Yes.
As long as you stay in the line, your facial nerve is automatically medial to it. You can never injure it. That is the bottom line behind creating a safe posterior tympanotomy. Now,
and if you thin the bone more of canal, you may be able to see a chorda tympani also.
yes, yes, you can see the pani dalna yaar. You can see the glimpse of chorda tympani now.
Yes.
Not yet.
See now. See the chorda tympani,
Yes,
which is
now
arising from the lower part of the facial, just above the stylomastoid foramen. Pani dalna jor se. That is, see this?
Yes.
Immediately above the stylomastoid. Now I am showing you the reference of the previous landmark. That is digastric ridge. See this? The periosteum of the digastric ridge joins the periosteum of the fallopian canal at the level of the stylomastoid foramen and just above it. Can you see that?
Yeah, I think you should show it
They
in more
are
detail.
cells lateral to digastric ridge. They are cells deeper to digastric ridge.
See this digastric ridge curving anteriorly, and see the facial nerve coming.
Satish,
Yes?
there is feedback from all around. I think you should continue your dissection for half an hour. Then we will have a discussion after 5 or 10 minutes. Because there is so much of sound coming from all around. People are getting confused. Right? There is feedback from all around. Just continue dissection.
Okay.
20 minutes, and then after we can take.
Sir.
Okay.
Satish,
Yes.
sir. Can you hear me, sir?
Yes, yes, very well.
Sir, there are many questions which I cannot answer, and because no one is, they want you to talk for some while, and then we will come back to the question answer and the discussion session.
Okay. Okay, let me finish this step and then we'll take on all question answers together. Okay? So now, at this point of time, look at this landmark, the digastric ridge, which is curving, see the attachment of the digastric, which is curving anteriorly towards the stylomastoid foramen. See this, saaf karna hai, kaat isko. See now, this area, the digastric ridge anteriorly, the facial nerve at the level of the stylomastoid foramen. Here you can see very clear. I hope it is clear.
Yes, yes.
And see the origin of the chorda tympani and enclosing this triangular space. Now, if you go to the literature, there is another very small branch from the facial nerve which emerges here. That is the auricular branch of the facial nerve, the sensory nerve to the posterior part of the canal wall, emerging just above the digastric. Could be this one. That is auricular branch of the facial nerve, not very constant but sometimes, and that is a sensory branch again. Now following this chorda tympani, see this, see how big the burr, how large the diamond burr I am using, bigger than any structure, critical structures below, like Movani sir said, bigger than the size of the facial nerve.
In any part of temporal bone, use the biggest size of burr in that area. It can be biggest, can be 7 millimeter, it can be 1.4 millimeter. For that area, biggest burr.
Yes. So this is my facial recess now, which is very, very clear in between the chorda tympani and the facial nerve, and this recess is elongated than the usual one because it is variable. Sometimes the chorda, usually chorda arises 5 to 6 millimeters above the stylomastoid foramen, but in this case particularly the chorda is arising right from the stylomastoid foramen level. There are reports, even the chorda arising extratemporally, outside the temporal bone and then again entering into the temporal bone. So there could be individual variations, and the cell which I have opened up here is the facial recess cell. This dimension of the facial recess is same in a child who is just born or an adult like us. The dimension doesn't change. The facial recess dimensions never change. So this, I am changing to a smaller burr now. Now as I go deeper, I will keep changing to the smaller burr.
But it is largest for that area. It is the largest for that area. Small
Yes.
burr, but largest for that area.
Yes, for that area still it is the biggest one. See now, this way I am entering into the retrotympanum. Middle ear, the posterior part of the middle ear. See this? Lateral to the facial nerve and medial to the chorda tympani. And this is how you can leave, like Pawan mentioned, he leaves a small ridge of bone here intact to prevent your vibration injury to the incus, which can lead to sensorineural hearing loss. See this. And you can see certain structures coming into the view from the middle ear. Ek side chota de, suction bhi chota. Now the most important structure we'll look for here. From cochlear implant point of view, let me increase the magnification to 1 step and show you. And that is the chota de, micro. Can you see the part of the promontory? The overhang of the promontory and the area of the round window?
You could see round window, you can see pyramid, you can see tendon, you can see
Yes,
head of the stapes.
I will show the entire structures of the retrotympanum from here through this opening, that is facial recess And this approach is known as the posterior tympanotomy or facial recess approach. Section there.
Because there
Yes.
comes the importance of your much emphasis on thinning of the posterior canal wall. You are going head on towards the promontory. You are
Yes.
not, your shaft is not coming on the facial nerve. If
See,
you would not have thinned it properly.
yeah, that is important to give a widest possible opening. Now see
And
the
that is
another thing.
possible by thinning the canal wall. Thin the canal wall.
We are thinning two things. One is the canal wall, obviously, and secondly, see what I am doing? Anterior thinning of the facial nerve.
That is anterior inferior. You are inferior.
Anterior-inferior thinning of the facial nerve to enlarge my access to the middle ear. See
This
this?
is what I coined as thinning of the facial ridge.
Yes.
Thinning of
Now
the facial
at this
ridge.
point, I will apprise you with certain landmarks. This is the time to show you. And this is important. Give me a ball pick. Yes. Now see, this is the promontory which is formed by the basal turn of the cochlea. Today we will dissect the cochlea and from inside completely to see the three-dimensional anatomy. And this bulge is formed by the basal turn of the cochlea. Now this cochlea is closed by two windows on different sides. Posteriorly, see this bluish window? Can you see this?
Yeah.
This is round window and this is covered by a overhang of the promontory. This tegmen of the promontory, the tegmen of the round window covering this partially. So I will uncover the round window completely. Now, another landmark.
Give me 1 second here. I just want to emphasize what is the role of inside-out mastectomy. A lot of people, when they're doing inside-out mastectomy, they're worried about damaging the facial nerve. Look how far the facial nerve is from the bony annulus. It's almost 2 millimeters away. So when you're doing inside-out mastectomy, the first part is thinning of the canal.
Not only away, it is behind as well.
Yeah. So Satish has done thinning from behind. When you're doing inside-out, you're doing thinning from inside-out. So don't get terrified, okay? And when you think you're gone close to fallopian canal, as Satish did, instead of cutting burr, come down to diamond burr of biggest size.
Yeah, that's important. And sir, we'll have a dedicated session on the cholesteatoma surgery where we'll discuss this thing, the inside-out technique, a useful technique in detail. Now, the other landmarks seen through this tympanotomy. So this approach, posterior tympanotomy, believe me, you don't have to terrify with it. You aspire to be a cochlear implant surgeon, you can easily do it. Taking into consideration the landmarks, the incus, the lateral semicircular canal, and then you work in this region to find the facial nerve, chorda tympani, open this space in between, and then you look into the middle ear. Now the other landmark is this is the pyramidal eminence through which a muscle is projecting and going to the neck of the stapes. This is stapedius muscle. Okay? Can you see very clear?
So can you show us nerve to stapedius as well?
Yeah, nerve to stapedius passes through it. It is such a slender nerve, you can't see it so clearly. But yes, it passes through it, through the same cone. Now, above this is the dome of the facial nerve. Can you see this facial nerve? The horizontal segment?
Fallopian canal. I correct you. Fallopian canal.
Yeah. Fallopian canal, the horizontal part of the fallopian canal, then here is the genu, and this is the vertical descending part of the canal. And this is the fossa incudis, where the short process of the incus is lodged. See this? Which I have kept intact. So this big opening is giving you the huge access to the posterior part of the tympanum. That is retrotympanum, chota, bilkul chota, those side chota. Now, to access this area of the round window, as I told, yeah.
Sir, before you move ahead, just till here, can we get few concepts clear? Can you tell us about the burr? First, initially you use the conical burr and then the circular burr. So when do you prefer which burr? First question. Second is, while doing posterior tympanotomy, which size burr will you prefer?
Largest, I have told you earlier, largest for that particular size, particular area. It is not that in millimeters you have to count. largest for that particular area.
Sumit, for answer's sake, when he was doing a posterior tympanotomy after he started the cell, the burr point was about 1.4 millimeter. Okay, largest for that area.
Yeah, इसको clean कर. Wet gauge.
So
Wet gauge.
Juniors want to know that which burr do you prefer?
Yes, Paramita, I am
Whenever
coming.
there are cells, you use a cutting burr. When there are no cells, diamond burr.
Yes.
Anywhere in the
Paramita, I am coming to this question. Gila dena yaar. I am coming to this question, and I will show you my set of burrs for that matter. For this, you need to have number of different size, different length, and different morphologically different burrs. So the burrs which I use as I go deeper, now I will show you. As I go deeper, I use long tapering burrs. See the next burr I am using. See this? The particular configuration of the burr. Can you see this? This is long tapering burr. Can you see this? The reason I am using is long tapering burr is so that the shaft.
What is tapering? Explain them what is tapering.
See, this is tapering of the shaft.
Yes.
This is long tapering burr. It is different in the sense the shaft doesn't come in the way as you drill in the depth. Can you see this? And this shaft doesn't damage the structure which you don't want to touch, the facial nerve underneath. So this is a long tapering burr for such deeper areas where you go. As I go deeper, I'll use different size, smaller and smaller, long tapering burrs. See what I'm removing? The overhang of the round window. See that?
Yes, sir.
Round window membrane.
A round window overhang, this promontory overhang over the round window membrane. And pre-operatively, if you are good at CT scan, if you have a DVD of that, you can pick up this, how much overhang you are going to have. At the same time, in the live surgical sessions, we'll see in the radiological sessions, through radiology, you can predict how feasible is to find the round window so easily. See, through our tympanotomy in the center is the round window. It is so favorable. It is not always. It is not always so favorable. Looking at the various curvatures of the cochlea, various morphological dimensions of the cochlea, this round window as many a time becomes inaccessible through the posterior tympanotomy. And by means of certain parameters on CT scan, you can predict by means of radiology CT scan that how feasible, how favorable your round window visualization is going to be through the posterior tympanotomy. That will cover up during the live session. Okay? So what I have done, I have removed the round window niche, and there are lots of conglomerate areas of various cells and all this in this region. The best anatomy of the retrotympanum can be seen through the endoscope. If you put a wide angle 0 degree or 45 degree endoscope in this region, you can see the entire anatomy of the retrotympanum much better. We'll show later on this area. So here, when we come to the cochlear implant, see, cochlear implant science is not just open the round window or push your implant into it. It is not like that. We need to understand the science behind it to optimize our results, where our implant should go. Why our implant should go preferentially in the scala tympani, why it should not damage any intracochlear structures, why it should not go anywhere else in scala tympani. All those things are important to optimize your results, and that can be learnt and understood best by means of understanding the anatomy thoroughly three-dimensionally. I have brought today the endoscope with me to show the interior of the scala. When I drill the cochlea, I will show you the interior of the scala tympani and the scala vestibuli and the scala media, where exactly it is, how your implant going inside the cochlea can damage all these structures, how you can prevent damaging all those structures. I have a dummy implant here with me, which I am going to insert and show you what is the best way of preventing or minimizing the intracochlear damage. So that is going to be the whole game today. Now,
Satish boss.
Yes.
Can we know if you are not seeing, you are not able to see the round window, what are the various measures you do to see that?
Yes, Pawan, that's a very important question. In the difficult situation when you are not able to see the round window, what all you can do? Number one, first of all, you should be prepared with this condition looking at the pre-operative radiology information. Number one. Number two, if you are going by this approach, what I can do simply here, using my diamond drill, I can give a fracture on the posterior canal wall here, one vertical fracture here, and one vertical fracture here, keeping the tympanomeatal flap intact, and push it anteriorly to acquire more space to see the unfavorable round window, which is almost always posterior-medial. See, when it becomes unfavorable, when this round window, which is here, had this round window been here deep to the facial now, it would have been difficult to visualize.
Yes.
And that what information you can pick up by the radiology by various means, and the simplest is the distance between the vertical part of the facial and the round window. If it is decreasing, if it is less than 4 millimeter, you are certainly going to face a difficult round window. So in that situation, you can mobilize the canal wall in the simplest way. And for that matter, beyond that answer, in any given difficult anatomical situation of the temporal bone, if you are doing a cochlear implant, the technique of choice for us is a subtotal petrovectomy and obliteration, blind sac closure and implantation. And we are going to show in the coming live workshop a live case of which has a different indication, subtotal petrovectomy, of a patient with a bilateral CSOM with bilateral profound sensorineural hearing loss, and that will keep for subtotal petrovectomy and implantation at the same stage. So
some of these patients have had bilateral mastectomy done. And
yes,
sometimes
operated earlier.
Yes,
we did sir, if you remember, we did the same case.
You did it for Halale's case, Dr.
Yes,
Halale's
in
case,
your workshop.
in last workshop, you know.
Yeah.
And that patient is doing well.
Yes, I remember that.
Satish boss,
yes,
I just wanted to make a few points over here. If you are not able to see that because of maybe of the cochlear rotation or something like that, there is something like a consistent distance between the inferior border of the oval window and the round window.
Yep.
That is 2 mm. And round window, the midpoint of round window will always be anterior to the posterior crest of the stapes. So we can just drop a line from anterior to posterior crest and we'll find the round window down there. This is something which Roland says in study by Roland. The other way around, you are not a proponent for varia and something like a transcanal. Otherwise, what we could do is we can elevate the posterior canal wall still intact, and we can see the round window transcanal, and then we can orient ourselves where is the round window, and from the posterior impedotomy also we can approach that area accordingly. This is something an advantageous thing.
As Satish is not talking now, you know, there's surgery for CA external canal. What is in a posterior tympanotomy? Keep on doing tympanotomy inferiorly. We can take away the whole canal bone along with the skin for CA external canal. It's also known as subtotal. It's not a conventional subtotal. After that, so you can take away the whole canal bone along with the skin for CA external canal. What has happened to Satish? Pramita, you can ask some questions. Pramita, you can ask some questions till then.
Satish sir, are you there?
You ask Dr. Mormani also, no problem.
Satish sir?
You asked Dr. Mormani and Pawan.
Yeah. Paromita, you can ask Mormani sir or me or maybe Rajiv's boss.
So there's a question that from Bhubaneswar, he wants to know, or Dr. Krishna wants to know, that is the cordofacial angle constant?
Never.
Facial angle at the
cordofacial angle, it is never constant. See, I have already answered this. The chorda tympani generally arises few millimeter above the stylomastoid foramen. In this particular case, it is arising far below. It may arise even extratemporal. How the angle can be constant?
From exam point of view, it arises from lower 1/3 of the vertical course of the fallopian canal.
Yes.
Yes, Dr. Singhal? I'm
Yes.
telling you the exam point of view. What people talk from exam point of view.
Distal to the 6 mm from the styloid mustard foramen.
Yes.
You must know
So-
that talk with professors are willing to listen in the exam.
Hello.
Sir, Satish sir, will you also show us the sinus tympani?
Sinus tympani I will show as I go to the dissection part later, deeper part. But here for your information, sinus tympani is an anatomy in the retrotympanic region, here where my instrument is pointing deep to the facial now. There are a lot of recesses in the posterior most part of the mesotympanum, which are divided by certain prominences from the styloid complex, dividing into different areas. The superior one, just below the oval window, is the sinus tympani. Sometimes it is subdivided, and that is below the level of the ponticulus. Then below is the subiculum, separating below from the round window. Then below is the funiculus. All these are the linear bony projections coming from the posterior wall, that is styloid prominence, and then dividing in the retrotympanum in the different areas. Now the clinical value is sinus tympani is by and large, you see from here, it is hidden from here deep to the facial now. And sometime if you have a disease, particularly like cholesteatoma, extensive one, the posterior cholesteatoma, the pars tensa cholesteatoma invading the sinus tympani, you may not be able to clear it effectively, or you may not be, even if you have cleared, you may not be able to ensure it that you have cleared completely. So first of all, your pre-op radiology can tell you whether there is a, how deep is the sinus tympani, number one. Number two, you can come from anteriorly to access is better in difficult situations. And number two, if it is over pneumatized, then you can go by the retrofacial route. That is much better, and you can marsupialize the entire sinus tympani clearly. In this particular case, I will show you what is retrofacial route. Probably this is a pneumatized bone, and we'll be having a good retrofacial access. That
And
I
when
will
you
tell
do
you.
the retrofacial approach, you keep the bony canal of the fallopian canal intact.
Yes.
That's important. So that there's no injury to the
Badi-
fallopian
badi
canal
dona.
or patient now.
Medium size cutting. So let me tell you at this point of time, once you have asked what is retrofacial and what is the clinical implication, what are the limits. Retrofacial, as the name implies, is medial to the facial now. And that approach is passing through some air cells. So it is a very small space limited by certain, I would say, important anatomical structure that need to be preserved, that has to be ensured. So this is facial now, you can see the vertical segment of the facial now. This is your sigmoid sinus which goes down, which goes deeper.
Study there a centering cut. Again microscope. Sort of centering cut. That's better.
Yeah. So this sigmoid sinus goes deeper down here. Buddy, why is it getting clogged again and again? Taking so much of time now.
So again,
See this.
now he's using a cutting burr because there are cells. Wherever there are cells, you can use a cutting burr.
Yes. Just to expedite the process, because there is no critical structures at this point of time, what I am doing is excentrating all these cells in this region. The region is deep to the vertical portion of the facial. Now see the big cell coming? And see what are the limits for the safe retrofacial approach. My limit number one laterally is the facial, now you can see in the view. Now medial to it, this is retrofacial area. The inferior limit is going to be the jugular bulb. So why I am drilling this region to show you how this sigmoid sinus becoming the jugular bulb.
And superior limit posteriorly is a posterior semicircular canal.
Yes.
And inside is cochlea. From the meridian side is a cochlea, superior limit. So it is known as infracochlear or infralabyrinthine approach or combined approach.
See this? This is the area deep to the facial now which I am drilling through these cells. What I have to stay careful is this here, this one, this area is the posterior semicircular canal. You can see this thick bone. I am not supposed to injure this canal while enlarging this superiorly. This is very, very important to prevent the complication. That's a disaster if you injure that. Number two, see how cellular it is. The base and the inferior part is bounded by the jugular bulb. See how extensive cellularity it is, and this is one of the ways we call it as the infralabyrinthine route to the petrous apex. Through this region we can go to the infracochlear area, and from that region, from infracochlear, you can go to the petrous apex. So for addressing the petrous apex lesion, this is one of the approach. And nowadays with the advancement in the endoscopic technology, many a time we address the petrous apex lesion through the nose. So depending upon the favorable anatomy, you have to take a call whether to go by the nose or the ear. You cannot be dogmatic. According to the best anatomy and the indications, we have to choose the approach. See this? This is the retrofacial axis, and this way I can enter as I keep on drilling between these limits into the mesotympanum. So this way
use boss for the glomus jugulates. Glomus, the type B glomus, which is going in the retrofacial cells.
Yeah.
I've seen you doing it, and then I learned, and I have done in a couple of cases, keeping the facial bridge intact.
Yes.
Yeah. So we
yes,
can also.
Many a time you can remove keeping the facial ridge intact without damaging it. Yes. See now my superior limit is this thick bone. That is the posterior semicircular canal.
So for their cells, he can use the cutting bar. Moment the cells disappear, he has to come down to diamond bar.
Yes.
Sir, Satish sir.
Yes, please.
So more than 5,000 viewers are watching you right now, and I think most of them are the postgraduates and juniors who are watching you.
Oh,
there are very
lovely
questions that they are also asking.
Amazed.
So step by step, you teach us all the dissection, and then we will come with the discussion, and I'll ask relevant questions when it is required.
Okay.
Like,
that will be great.
Yes, sir.
Yeah.
And
See,
so,
Paramita, you were asking about the sinus tympani. See my region of the sinus tympani from here, and if I keep going through the retrofacial area, keeping my limits in view, I can easily reach the sinus tympani from behind. And that, believe me, in the pneumatized situation, favorable situation, is one of the best approach to, address the sinus tympani. See this?
yes, sir.
You can reach with your landmarks, keeping your landmarks in view to the sinus tympani. That will come back to it later. Just to answer your question, it was.
So
Now,
when you tell us more in detail, you also show us the bony ridges of subiculum and ponticular space.
yes, yes, I will tell you again. Once I take this canal down, I will show you the anatomy of the retrotympanum. Later on again, I will use the endoscope also that in that region to clarify. You will never forget in life.
Sir, some juniors are also asking what is facial ridge and what do you mean by bridge?
Yes, so ridge, bridge, all this terminology. Okay, now see this. This is the facial now. That's the vertical segment. That is chorda tympani. In between, this is facial recess. Now, if I want to enlarge this facial recess, in case I want to address some pathology in the hypotympanum, for which the regular facial recess is a narrow axis, what I can do? I can do something like extended facial recess at the expense of chorda tympani. Can you see?
Yes.
This is what we do for C-external canal.
Yes.
And we extend the whole canal.
Yes, that is at the expense of chorda tympani. I can see this, and I can expose the hypotympanic region much better. Now see, I will be right into the hypotympanum in no time. See this? Many a times for a limited glomus jugulate tumors, we have done this approach, extended facial recess and retrofacial combination to address the limited glomus jugulate tumor. And many of the hypotympanic lesions.
Most of our neuromas.
Most of a neuroma for non-vascular tumor, even for the jugular also.
Yeah, but limited, as you said very clearly, C1 and limited C2. Partly
Yes,
C2.
not invading extensively the carotid artery.
Carotid, again, carotid canal. I won't say artery, carotid canal.
Find out. See this hypotympanum. Now, why I am showing you this? Because this is the direct access to the hypotympanum. Now, from here, just for the sake of demonstration for the junior colleagues, this is atic. As I go anteriorly would be the anterior atic and other ossicles. if I extend this approach, this is one of the very important surgery for malignancies of the temporal bone. For limited external artery canal malignancy, there is a radical procedure known as lateral temporal bone resection. And how to do that? What I have already done is, you can do this part and then by extending the facial recess inferiorly towards the hypotympanum and this atic towards the anterior atic till the anterior part, and through this the medial resection would be just above the Eustachian tube. You can remove this entire thing en bloc. That includes the entire oxygenatory canal, the tympanomeatal flap, the malleus, incus, you disarticulate at the level of the incudostapedial joint, and this entire thing coming en bloc is a lateral temporal bone resection. And that is a radical procedure, curative procedure. Along with, obviously, we almost always do a superficial parotidectomy along with, and sometimes the level 2, 3. But this primary procedure of a lateral temporal bone resection is the curative process for the external artery canal malignancy, and believe me, it is not difficult. Any regular otologist, as you said, Paramita, there are a lot of junior colleagues. Believe me, you can all do it. What I have done until now, what all you have to do is a facial recess, the same posterior tympanotomy, extend it at the expense of chorda tympani inferiorly, and then this circumferentially remove this bone, keeping the canal intact all over. The last final medial cut would be medial to the tympanic membrane, above the level, lateral to the Eustachian tube, and this entire thing will come out en bloc, that is lateral temporal bone resection. I hope it is clear to everybody.
Satish, I just want to clarify one thing.
Yeah?
Satish, I want to clarify one thing.
Yes.
If I have a tumor in the posterior canal wall, I don't have to do parotidectomy at all. I have done cases where the tumor is limited to the posterior canal wall.
Yes.
When the tumor goes to the anterior canal wall, the story is different.
Yes.
Most often in India, you get extensive CA external canal. You know what I mean? You don't get limited.
Yes.
And if you're lucky to get a limited one, you can do without doing anything to parotid, because this is on the posterior canal wall, not on the anterior canal.
Yes. So, the limited lesions, this is the answer. For any malignancy of the temporal bone invading the middle ear or the petrous bone below, then the procedure of choice is a subtotal temporal bone resection. And nowadays, the standard of care which we have been doing now is the en bloc subtotal resection of the temporal bone, leaving the area of the petrous apex to preserve the cranial nerves and the carotid artery there, close to the cavernous sinus. Rest entire temporal bone has to go en bloc as a standard of care, and that is the most major procedure in the skull-base surgery, where you need all around the craniotomy and the intact temporal bone coming out, leaving all the critical structures in the medial aspect, that is carotid artery, jugular vein, everything leaving behind in the medial aspect, and you remove everything en bloc. You have to sacrifice the facial now, you have to sacrifice the nerves from the intra-artery canal, and the entire temporal bone is taken out en bloc. That is for the other malignancies invading deeper. So these are two procedures.
More of middle ear rather than external canal.
Yes, yes, for the middle ear. That's what.
Canal one video I had made in 1903, and I had distributed to a lot of medical college, 1993.
Yes. Now see, focus something in the atic anteriorly. Can you see the other bone coming into the picture? See, this is incus. Can you see? Hello?
Yeah. Dislocated incus, I can see.
Yeah, I will, let me remove it. I have already, it is coming out. Yes. This is malleus, and see a ligament which is still very clear. Can you see the superior malleolar ligament?
Yes.
Yeah, very clear. You know.
See, this theory of middle ear folds was described in '63 by Bruce Proctor. He published in JLO and revolutionized the concept of aeration. There are a number of folds making the diaphragm in the atic, diverting the aeration from the Eustachian tube to middle ear to the atic and then to the antrum, have a significant impact on the pathophysiology of chronic suppurative otitis media. And every one of us must go through that Bruce Proctor article to understand each and every aspect of middle ear folds. So there are a number of middle ear folds forming the diaphragm and leaving the sites of aeration to the atic and the adductors through the various tympanic isthmus, the posterior and the anterior isthmus. Here I am not going in detail, but this ligament, that is the superior malleolar ligament, that is classically visible, attached to the superior wall, that is tegmen over here. Now anterior to this is the anterior atic, and that again for the aeration, that is an important fold anterior to the tensor. This is the tensor tympani fold, which is important for the aeration of the anterior atic. I will show as I remove this atic wall, where is the tensor fold and all this for the aeration. So, like for example, even if the Eustachian tube is good, functioning normal, good aeration of the middle ear, if the aeration of atic is not good, giving rise to retraction and cholecystoma, you can't blame the Eustachian tube. So, the aeration pathway through the anterior and posterior isthmus, through the pouch of ventrals, are important to understand in understanding the pathophysiology of these chronic inflammatory diseases of the middle ear and the mastoid. So this is what here.
Can I interfere for a minute, Satish? Can I interfere for here for a minute?
Yeah.
What Satish has done just now, removing the ankles. This is what you have to do if you want to decompress the horizontal portion of facial nerve in case of trauma. I can remove the ankles and I can do the decompression just up to the first genu, not the complete genu, up to the first genu, and I will reposition the ankles in same anatomical position without remolding it. I can reposition the ankles with the incuriomalleolar joint and incurostapedial joint.
Now see what I am doing. Just to show you, I told you this course today is for anatomy. Removing this wall to show you some more anatomy in the depth. Anatomy of the middle ear and anterior aspect. What I have done, I have removed this part of the canal wall with the bone nibbler. I have already told you the process of lateral temporal bone dissection. You can do that. So now I am removing all this skin of the extraocular canal to show you the anatomy in detail. The malleus is still there in place. That is the fibrous annulus, and that is the part of the middle ear. The middle ear, what you see through your endoscope or otoscope, is the mesotympanum. Then there are certain extensions of the middle ear which are beyond your visibility. That is the inferior extension. Below the inferior annulus is the hypotympanum. Above the level of the superior canal wall, that is epitympanum. Behind the level of the posterior canal wall is the retrotympanum. These are all parts of the middle ear we need to understand. Now, if I drill this region more, little bigger, you will have a better picture of this area. As we go deeper, we will move on to the inner ear. Now, the most important structure we need to discuss here is the facial nerve. We will have a separate webinar later on the facial nerve, completely dedicated to the facial nerve, right from the cadaver dissection to the live surgery for various indications of facial nerve repair, traumatic tumors and other things. We will do a separate dedicated webinar for the facial nerve later. We will have a separate dedicated webinar on the stapes, absolutely dedicated full day stapes session discussing intricacies. So here, today is only anatomy. Now see the malleus. Why I kept this malleus intact? To show you something at this point of time, why it is important. See, this malleus has various parts. This is the head, this is the neck, this is the lateral process, this is the long process of the malleus that is merging into the tympanic membrane at the level of the umbo. And see this, there is one tendon which is inserting on the medial aspect of the neck of the malleus. Can you see that tendon?
Tensor tympani.
That is the tendon of the muscle that is known as tensor tympani. I have separated. See this. That tendon is tendon of the tensor tympani here, and it is coming out from a muscle. So here, be careful. This is the horizontal part of the fallopian canal. Immediately below it is a bony prominence through which this tendon is coming out. That is known as processus cochleariformis, and that is continuation of anteriorly from a canal. See this canal? This bulbous canal coming from anterior just above the Eustachian tube, which is ending into this bony process, and from where this tendon is coming out, that is tensor tympani.
Tensor tympanic canal.
Yes, that is canal for tensor tympani. It is a very useful anatomical landmark for the lateral skull-base surgeon. As I go more anteriorly to the infratemporal fossa, this is one of the most important landmarks for the eustachian tube and other critical structures, including carotid artery, the petrous carotid artery there. So this is canal for tensor tympani. Now, once I have removed this part of the bony canal wall and the tympanic membrane, lot of other landmarks are coming into the picture. Panidal. So let me show you the quickly what are the landmarks I can see at this point of time from here. See now, this is the prominence of the lateral semicircular canal. You can see here that is the facial nerve in the antero-inferior in the circumference of the lateral canal. That is the second genu of the facial nerve, that is horizontal part, second genu, and the vertical part. Now there are three semicircular canals connected to the vestibule in the depth here. We don't see all the three canals at this point of time. We'll uncover them. What I see, the other canal here, that is posterior canal, this is lateral canal, and above is the superior canal, forming the labyrinthine block. And this is what the area of interest today. Now, to understand this facial nerve, right arising from the brainstem, I'll show you today, forming the cisternal component before ascending to the intra-artery meatus. It has a meatal component of a centimeter or so once it comes laterally from the intra-artery meatus like this. Here was the extra-artery meatus, in the same line is the intra-artery meatus, almost same. Not 180 degree, but around 156 degree. So
no,
the facial,
168 degrees, 168.
Yes. So it comes out of the intra-artery meatus, then it has an intratemporal segment. I will show that later, the labyrinthine segment and its relationship. So the labyrinthine segment come anterolateral like this. At one point, that is known as the first genu. That is the first genu which I am going to show you very soon now. And from here it has a retrograde course, that is the horizontal segment. Then is the second genu and then the vertical segment. What I am trying to show here, every segment of the facial nerve has a different reliable landmark for us. For labyrinthine segment, I will show how the superior semicircular canal is a reliable landmark. For the horizontal segment, this one, how this processes cochleary formation is a reliable landmark. Even in the extensive cholesteatomas, this process is rarely destroyed. And you find the facial nerve is coursing just superior to the processes cochleary formation. Can you see that? So this is one of the most reliable landmark for the horizontal segment. For the second genu is the lateral canal. For the vertical segment is the posterior canal. Every semicircular canal has relationship with a different part of the facial nerve. Again, for the vertical segment, immediately medial to it, within half centimeter, is this posterior canal. For the second genu, lateral canal. For the labyrinthine segment, superior canal, which I am going to uncover. And this is how this horizontal canal is leading to the first genu, and then it is reverting back as a this patli dena. Cutting the patli cutting.
Juniors, Satish sir?
Yes?
For the juniors in all the ear cholesteatoma cases, can you tell us how much the facial ridge has to be lowered? What is the landmark?
Until you find the facial nerve, until you reach the facial nerve ideally. See, like I have lowered the facial ridge like this. It should be completely lowered till the facial nerve. Leave the thin bone over the facial nerve to prevent the damage to it. But anything lateral to it has to go. That is the classical lowering the facial ridge.
You can lower up to that, but it is not necessary in most of the cases to lower up to that, okay? You have disease, you can lower up to the fallopian canal. Satish keeps on calling facial nerve, I always call it fallopian canal. Yes. Once you expose the canal, then you see the facial nerve. You're not supposed to be exposing the nerve.
Yeah, we are not exploring it. Once you are doing a canal down surgery,
so
you have to exenterate, yes, to prevent the area behind to be self-draining. Now what I am trying to do, see, all these are perilabyrinthine cells. I am removing all these cells quickly to uncover the labyrinthine block better. Can you see better now?
Yes, sir.
So
The
wherever
other-
there's cells,
other-
there's a cutting bird. Wherever cells, there's a cutting bird.
Yeah, see this? The labyrinthine block, which is conspicuous, a color change as compared to rest of the cellularity of the temporal bone, as this is the hardest bone in the body. This is
And it's
labyrinthine.
ivory, more ivory.
Yes, in the live surgical situation, you can find it as an ivory bone. Now, I can see, by and large, all the three canals in view. Let me show you in a minute. And all these are perilabyrinthine cells around the semicircular canals. And see this space, that is very important. That is a very important space behind the labyrinthine block.
Retrolabyrinthine dural plate.
Yes, see this retrolabyrinthine space, or if I take into consideration certain landmarks, this is known as a very, very important area to the lending to the CP angle to the cerebellum, and that is the area behind. And if you have gone through a presentation from Movani sir about his single stage transmastoid drainage of the autogenic abscess, this is the area where you need to go to the cerebellum. See this? See, I have excentrated all air cells here. So my limits here, here is the superior petrosal sinus below. Here is the sigmoid sinus. This is pre-sigmoid plate. And here is the labyrinth. And this entire triangular area, this is the area landmark leading to the cerebellum.
And sir, what will be the landmark for the emissary vein?
For the?
Under the dura.
Pardon?
Superior, no, emissary vein is superficial.
Emissary vein is behind.
That is superficial.
See, emissary vein, yeah, your point is valid. Emissary vein is going to be behind. See, I am behind the sigmoid sinus, okay? Okay, to answer your question about the emissary vein.
Yes, sir.
Emissary veins are what? Emissary veins God has given to control the pressures in the dural venous sinuses. They have some outside connections. These dural venous sinuses have to the scalp veins, veins in the scalp and the neck. And this mastoid emissary vein is one of the most prominent one. Here, that communicates with the outside scalp vein to release the pressure of the blood in case rises in the dural venous sinuses. So emissary vein, see here, it is behind and deeper.
This is mastoid emissary vein.
Yeah, this is the
emissary vein.
Yeah, this is the mastoid emissary vein here. So it is behind the sigmoid sinus. They act as a pressure wall to release the pressure of the dural venous circulation. Okay? And
As a regular ENT surgeon, they are used to only this emissary vein. They are not seen or heard other emissary veins.
yes. And it sometimes in the procedure you work behind the sigmoid sinus, it bleeds a lot. And what you need to use is either bone wax, Surgicel, and sometimes bipolar cautery, and you can easily control in that situation. See now what still I am doing is the perilabyrinthine drilling. See that?
Still cutting bird.
Still with a cutting burr.
Sir, now since you're in this area, can you tell us about the cog?
Cog is too anterior. It's not in this area.
Cog,
It's too
Anterior.
cog is a projection of the bone in the attic.
Yes.
Projecting towards the malleus head, dividing the attic practically into anterior and posterior compartment. Now see, by and large, we have a labyrinthine block coming into the picture, much better, Panida. See this? The labyrinthine block coming into the picture. So what is this? It has three canals. This is the superior canal, the top of the all. This is the lateral canal and the posterior canal, and once I open them, you will find all these canals are perpendicular to each other. Nowadays, the surgery for vertigo is picking up. A lot of new procedures are coming in. We know there are certain pathologies which are treatable as far as vertigo is considered surgically. Like BPPV, majority of the time, BPPV is what? It is because of the autoconia release from the macula of the utricle. And those autoconia, once they are released from the utricle, where is utricle for that matter? All these three canals, they open through their opening into the utricle. deep to them in the vestibule. We don't see the vestibule here. So vestibule is deep to the canals. Vestibule is a big cavity medial to which is the intra-auditory meatus. So once I drill away the canal, you will find the vestibule. I will show the relationship. So all these 3 canals open through 5 openings into the vestibule. So like for, as I was mentioning for the BPPV, all these otoconia are released from the macula of the utricle in the vestibule. They settle down by the gravitational region. Because of the gravity, they settle down in the most dependent part, and the most dependent of all canals is posterior semicircular canal. That's why leading to vertigo, and we need to treat this. And nowadays the standard treatment is removal of the otoconia by certain maneuver, that is Appley's maneuver. Okay? Now in the resistant cases of BPPV,
not removal, displacement. I'll call it displacement of otoconia.
Yes, getting out of the canal.
Yeah, displacement.
Now in the resistant cases, you have to treat surgically. So what surgery you can do? You can plug the posterior semicircular canal to prevent the circulation of the endolymphatic fluid in that, to prevent the acceleration and vertigo. In resistant cases, you may have to do some sort of neurectomy also. And the neurectomy for this particular BPPV, you know, it was popularized earlier by Gesek. Gesek has a biggest series of the singular neurectomy supplying the posterior semicircular canal. He has a series of hundreds of cases of singular neurectomy. I will tell you the landmark.
No more popular surgery. No more popular surgery.
No more, because it was difficult to find out the singular nerve. And I will tell you today, I will show you singular nerve, and I will tell you today the simplest way to find out the singular nerve, and you can do that singular neurectomy even transcanal. Transcanal is the most direct method. Under local anesthesia, you just have to raise the posterior part of the tympanomeatal flap, and you are right in the vicinity of the singular nerve. You need to drill a millimeter or 2. I will tell you the area, and you will be right on the singular nerve. Why? The singular nerve is a branch of inferior vestibular nerve. So H, this is a sensory nerve arising from the macula of the posterior canal. This posterior semicircular canal, once I drill this posterior semicircular canal, I will tell you exactly where the macula is, and from there this nerve goes deeper to the intra-auditory meatus to join the saccular nerve to form the inferior vestibular nerve. In that course, it passes deep to the round window, and there you can pick up this nerve. So like if I turn my head of this cadaver here, then a patli diamond. If I drill, I will tell you the particular region. In a minute's time, you will come across the singular nerve. It's not a big deal. There are certain variations sometimes in anatomy, but still in that vicinity of few millimeters, patli denai suction tip, you can do a singular neurectomy, and believe me, that is the final answer to the BPPV. So the first answer is Appley's. Second answer, if it is still not going, then you can do a isolated posterior canal plugging. That is a simple procedure. What you have to do is go by the posterior approach, mastectomy approach, do mastectomy, go to the posterior canal, uncover the posterior canal, make it papery thin, remove the final bone, don't disturb the endosteum, and then plug the endosteum with the bone dust and fascia to prevent the endolymphatic circulation in the posterior canal. That is posterior canal plugging.
Once you put a bone dust, to keep the bone dust in position, put a bone wax also.
Yes, bone wax. You can put a fibrin glue. You can put a...
it has to be kept in the position.
Yes, just to reinforce that. Now, just for the matter this topic has come up, let me tell you in a minute's time the site for the singular neurectomy. This is known as Gesek's procedure. Gesek has revolutionized this singular neurectomy in the 70s, you know, when we didn't have even the good microscope that period of time. So I am going to demonstrate you in a minute's time the singular neurectomy, and the landmark is the round window. Simple. See, chota this. This is the round window. You see the inferior edge of the round window. Let me show you. Put up. Can you see the round window better now?
Yeah, very clear.
This is the round window. I am going at the inferior edge of the anterior. This is the anterior edge, inferior edge of the round window. Just going 2 millimeter deep to the inferior edge of the round window. You know, the movement, just a second. Just at the inferior edge of the round window, if I use this drill, diamond drill here, see no time at this point of time in this area conglomerata. See, this area is conglomerate area, and what you see below, that is the nerve, that is the singular nerve. Give me a smaller point. Can you see the white structure there?
Yeah, very clearly.
Very small nerve. Patla de yaar, 20 number. And that is singular nerve. That is the answer to the BPPV as far as the surgical treatment of the BPPV is concerned. See this in the depth. That is singular nerve. Can you see that?
Yeah, but important thing is you must excise few millimeter of the nerve so it doesn't regenerate.
Yeah, what you can do, you can take your right angle hook underneath the nerve and divide it and cauterize it for that matter so it doesn't regenerate again.
Yeah, seal that area so it doesn't regenerate.
This is the external camera. This is the answer to the BPPV of the interacted BPPV. Now, the audience, I will take your 2 minutes. I will take your 2 minutes to introduce someone who is the man behind this where we are working. So let me introduce to someone, he is already our dear friend, Mr. Entrepreneur, Mr. Sandeep Bakshi, who is the chairman of this phenomenal institution. Dr. Sandeep Bakshi.
Satish, को बम्बई में लाया था तू?
हाँ?
बम्बई में आया था ये?
Pardon?
तू कुछ लोगों को लाया था?
नहीं. No. So he is Dr. Sandeep Bakshi, who is the chairman behind this entire setup. मेरा phone लाना. WhatsApp. Jaipur National University. And you know how big this university is. It is unbelievable in the 4 years time, the way it has grown. This is the biggest of the universities in this area, wherein 150 students are taking admission every year. This is the 4th year. This is the beginning of the institution and has a strong tie-up with the Harvard University for more and more academic activities in the future. And this particular hospital in the 4 years' time has organized more than 200 academic workshops. Unbelievable. And you see this setup. This is the dissection hall, the state-of-the-art dissection hall you will rarely find in a medical college like this, in a private medical college. With no prohibition to approach the cadavers to improve your teaching skills. This is the institution, I believe. And I am really thankful to him for giving this opportunity and association here to this institute. And I am so blessed and grateful to this man for all this. And they have a vision to go much beyond, to start many postgraduate courses in the future to make this university the #1 in the country in times to come. Thank you.
Thank you,
and
Dr. Satish.
Few words.
Thank you, Dr. Satish. I am grateful. We all know that Dr. Satish is a world authority, and whenever we get a call saying that we would love to do something on the cadavers, we just have nothing more to say than say, please do it so, because it's a learning process for all of us. And Dr. Bafna, our founder principal, current Dr. Mishra, Ms. Bafna, we all realize that academic is more of sharing and doing. And Dr. Satish has been a legacy in this matter. And all people across, whoever are there on the web today, I must compliment him for being one of the first people to do this. And not only that, the improvement in understanding and the improvement in doing processes is going to improve the way he goes on. I wish him all the best, and thank you for making JNU a part of the system. Thank you, Dr. Jain.
Thank you, sir. Thank you for being here. And this is a message to the junior colleagues to improve your skills. Like Movani sir has said, he has organized over 100 workshops. Work more and more on the cadaver to get used to anatomy, to get used to instrumentation, to get used to identify the difficult structures. And that is the way you can improve your surgical skills. There is no match to it by any means. Thank you, sir, once again. Thank you.
Dr. Satish. Yeah. Dr. Satish.
Yeah. Yes, boss.
Yeah. Two good questions. One from Dr. Rajeev Jain.
Yes, please.
While doing singular neurect, one from Dr. Rajeev Jain. While doing singular neurectomy, chances of SN loss is there?
Yes, if you injure the round window, certainly. That's why I mentioned in the beginning, you have to be careful, close to the round window, deep to it, but not damaging the round window at all.
Okay, second question is, just people are asking just to show us the tympanic neurectomy for the parotid fistula, etc. And so many questions, so many people are asking this point because they want to the exact location of
neurectomy.
Yeah, because there are many people are looking for this.
We will come to tympanic neurectomy as I go to the promontory. I will definitely come to this. That's a very important procedure.
Yeah,
it's a very simple procedure.
Preserve that before identifying the middle turn anterior to the oval window. So he would be preserving first. Then later on he will be doing that.
Yeah. But some people sometimes
it is a landmark for your middle turn of cochlear dissection.
So, this was something for the BPPV we can do in our practice. There are number of surgeries nowadays you can use judiciously for the treatment of vertigo. And one of the prominent conditions we all know in our practice is the Meniere's disease. Now, it has changed with the advancement in the understanding of the activity of the gentamicin, and its widespread use has given us a very important tool to handle the Meniere's disease. So by and large, for any given Meniere's disease nowadays, the first line treatment is gentamicin if used judiciously. Why I mean to say judiciously and why I am mentioning this at this point of time, because then we have number of surgical options there to deal with the Meniere's disease, which I can show here. So if you are using gentamicin, gentamicin is, we all know, is selective vestibulotoxic, but it has a ototoxic property also. So there are a lot of fluorescein labeled gentamicin studies done, injected into the scala tympani, and it has been observed that the gentamicin, those fluorescein labeled, stay in the inner ear for almost 3 weeks. So in order to prevent the toxicity, if we give gentamicin as an intratympanic injection every 3 weeks, we can almost certainly prevent the hearing loss as a complication. At the same time, we can give vestibular toxicity, which we require as an end organ toxicity to relieve vertigo. Yes, sir.
Satish, if patient has a hearing close to normal, I will still do endolymphatic sac decompression.
Yes, that is another option, sir.
How many people in India do neurectomy?
Yes,
sir.
Yes, you are right. But now it has changed.
Because you do not know the anatomy, you do not do the surgery. I did more than 400 cases of endolymphatic sac decompression.
Sac decompression, I am coming to it, is a useful procedure. But now in the times...
SN loss in 0.1% of cases, whereas gentamicin can give you SN loss in 5 to 10% of cases.
Sir, there is a divided opinion in the literature regarding the long-term efficacy. I will come to it. But for that matter, in the present time, still, even in the patient having good hearing, the first line treatment in an established diagnosis of Meniere's, still I would go for gentamicin in a proper way every 3 weeks. Every time we'll get audiogram done.
No.
Every
For
time
example, this what you are emphasizing every 3 weeks.
Yes.
Every center does it differently. कोई alternate देता है, कोई हफ्ते में एक बार देता है.
That's why.
What have you seen?
That's why I have already mentioned. I have already mentioned that it should be given judiciously to prevent complication. At the same time, getting audiogram done every time. In case you find any 5 to 10 degree dip in the hearing, you should stop giving gentamicin. Number one. Number two, coming to your point, the physiological answer to the Meniere's disease is sac decompression. No doubt about it. That is the only physiological answer to Meniere's disease. That is pressure in the endolymphatic system. To relieve the pressure in the...
I can see the sac in your specimen.
Yes.
Sac दिखा तेरे specimen में दिख रहा है.
Yes, I will show that, sir. I will show that to properly. So that is the physiological answer. But in the situation now with intractable Meniere's, now we divide into two groups with a good hearing and poor hearing. Good hearing, intractable Meniere's, the surgical answer of choice in case the sac decompression fails, is the vestibular neurectomy. A properly done vestibular neurectomy can certainly give differentiation to the level that can relieve from vertigo. At the same time, that is a too invasive a procedure, you have to go intracranial. But for those who have unilateral Meniere's disease, completely hearing loss already happened to occur, the best answer forever is a labyrinthectomy. Labyrinthectomy will again give a complete differentiation when you remove the entire, the neuroepithelium of the vestibular system. You can do through the mastoid from behind, or you can do transcanal, but still going from behind is a more complete procedure than transcanal. The only thing, drawback of these procedures, these ablative procedures, is their success depends upon the compensation. So young patient, these are amazing procedure. For elderly, I will think twice. Because it is not the vestibular neurectomy or the labyrinthectomy which will relieve the vertigo. It is the compensation from the opposite side, ultimately, which will relieve vertigo. And that is unlikely to happen to a good level in the elderly people and patient with neurological diseases. So you have to think twice before doing all this, and you have to choose a particular alternative for particular group of patients. So the selecting a particular approach for Meniere's nowadays is complex. It's not that one answer for every patient. You have to choose a particular answer for the particular situation. I hope you got what I'm trying to say. Now coming to the dissection back to the cutting middle side.
Dr. Sandeep Karmarkar.
Yes.
Yeah, Dr. Sandeep Karmarkar is asking, at this point, please can you comment on the effect of the post-canal wall occlusion as it blocks the ampulopetal and the ampulocecal flow of otolith. Was not very effective initially. However, with onset of better vestibular test, the results might be better. Yes, exactly. Agreed. So now, coming to the anatomy further, we have already exposed 3 canals. And I am going to show the relationship of the facial nerve to all 3 canals. So you will never forget in life at which point of time or which particular area of the facial nerve is related to which anatomical structure, and what should be the best landmark for particular segment of the facial nerve. So I am working in the anterior atic, drilling away some bones, some cells above the facial nerve. I have drilled away already the processus cochleariformis, and this is the superior canal wall. Now, these 3 canals, as I mentioned, they open in the vestibule, which is not visible from here. And these inner ear structures are important in the cochlear implantation as well. Malformation of these structures is not uncommon in cochlear malformations as well. And many a times, we have seen the implant which is misplaced into one of the semicircular canal or vestibule, which is not going to give any result as we desire from cochlear implant. So we need to understand the anatomy. Number 1, this is the lateral canal. See what? I am drilling away the lateral canal in its length, in the length of the direction, and what I am finding here, I am using the cutting burr. See now, the opening. There are 2 openings which I am going to show you. See now the 2 different openings, can you appreciate?
Yes.
Yeah, very well.
Pick. See now the bigger one, anterior one. This bigger one, anterior one, is the ampulated end of the lateral canal. Can you see this? And the little smaller one behind is the non-ampullary end of the canal. Now, why it is called lateral canal? Because it is lateral of all. And it opens in the lateral wall of the vestibule. Vestibule has 6 walls. It's like a rectangle pyramid. So, this lateral wall opens in the lateral wall of the vestibule, lateral canal. The ampulated end opens in the lateral wall anteriorly, anterosuperiorly, whereas the non-ampullary end opens in the lateral wall posterior-inferiorly. Okay? Number 1,
yes,
in the lateral wall. Out of all 3 canals, this is the widest of all canals, for that matter. The next canal, see now, close to the... Yeah.
Satish, one from Dr. Deepak Dalmia, and when you're asking, you forgot about Trotman's triangle and its applied anatomy.
Yeah, this was Trotman's triangle.
Okay, applied anatomy.
Yeah, this is, I've already mentioned, Deepak Dalmia is an amazing otologist. He's an all-rounder, doing everything.
Yeah, he's doing everything.
See this? This is the labyrinthine block. This is sigmoid sinus, and this is dural region above. In between these three, when we excentrate the bone, and this is the bony plate, this triangular area is Trotman's triangle. And if I drill this, I'll be right on the cerebellum. And that is how you can drain the cerebellar abscess through this region, one stage. Movani sir has a series of cases where he drained the cerebellar abscess one stage with the mastoidectomy, and this is the site through which the cerebellar abscess can be drained, and this is the Trotman's triangle. Okay? Now, coming to the superior canal here. Boss, feel free to interrupt me for the questions.
Yes. Question, Paramita, ask many questions.
Solid angle?
Solid angle is the angle between the semicircular canals. I will tell you once I drill this, and there is an important anatomy, a vessel coming there, the subarcuate artery, at the level of the solid angle once I drill all these three canals. So now, coming to the other canal, see this opening in this canal? Can you?
Yes. Superior.
Yeah, very clear.
See this anteriorly, the ampullary end is close to the ampullary end of the lateral canal. And this is the non-ampullary end, which is a bigger one, and it is going to go behind and join the non-ampullary end of the posterior canal, which in the distal part will form, join together and form the crus commune. Now, why this is superior canal? Because it opens in the superior wall of the vestibule. Still we have not seen the vestibule, which I am going to show you. And it has a significant implication as far as the anatomy is concerned. So this is ampullary end of the superior canal, and this is the non-ampullary end of the superior canal. And this canal, if I go here anteriorly, just anterior to the ampullary end in the superior canal, what I will find in the depth here is the labyrinthine segment of the facial nerve. See this? Here is going to the labyrinthine segment of the facial nerve. Now sometimes you have to work to the labyrinthine segment for decompression. Suppose here, many a time the attic is not so wide to find the labyrinthine segment through the mastoid area to find the labyrinthine segment. Yes, you can predict by a pre-operative CT scan whether you will be able to see the labyrinthine segment by means of drilling through the attic. There are certain parameters on the CT scan by finding the level of the lateral canal to the labyrinthine segment, whether you will be able to access through the mastoid or not. Otherwise, you have to go by the middle fossa approach from above. Adding on to this, Dr. Madhuri Mehta has released a video, very, very interesting and informative, to address this labyrinthine segment from a very safe zone, preserving or preventing the injury to the superior semicircular canal. Why I am saying so? That is the anterior approach, that is the zygomatic approach. Let me explain you what exactly that in brief. If I go on from here to find the labyrinthine segment, what I can do? I can end up injuring the dome of the superior canal here. So what I can do? I can come from anteriorly from the zygomatic route here. If I come from here by drilling the zygomatic route from anterior to posterior, my drilling direction will not involve the superior canal in view, and we can safeguard the superior canal, and yet we can reach the labyrinthine segment in case it is accessible. That you have to find out from the pre-op radiology. What my point? So that is transzygomatic access to the labyrinthine segment of the facial nerve for any reason you are doing, for decompression, tumor, whatever. So in favorable situation, if you really want to go to protect the dome of the superior canal, protect from injuring this canal, because this is very, very close to it and prominent. The facial nerve is deeper and this is quite lateral. You can easily injure the superior canal, and then that approach is really good. That is something adorable, that approach actually is. So now the third canal here. This is the third canal. See, right angle to it. See, this canal is right angle to this, and this canal is right angle to this. Now the third canal is the posterior canal, which is again a millimeter below the facial nerve. That is vertical segment. So all three canals have relationship with the different segments of the facial nerve. I hope it is very, very clear.
Yes.
Yeah, very clear, very clear.
See now, this canal is absolutely perpendicular to the above canal. Can you see?
Satish boss?
Yes?
You can show them Donaldson's line over there.
Yes, dear. The right time you have asked, I'm going to show you. So this is the ampullary end of the posterior canal, and this is the non-ampullary end of the posterior canal. So these three canals They open in the vestibule with multiple openings. The vestibule is still deeper, I have not uncovered yet. So how come this lateral canal opens through one opening, the ampullary end, one opening through the non-ampullary end in the vestibule. There are two openings in the vestibule. Third opening in the vestibule is through the ampullary end of the superior canal. Fourth opening in the vestibule is the ampullary end of the posterior canal. And fifth opening is by joining these two canals together, they form the crus commune here and they open in the vestibule. So that's how the three canals, they open in the vestibule by means of 5 openings, and that is how the anatomy is. Let me uncover the non-ampullary end of the superior canal here. See how it joins. See this non-ampullary end of the superior canal I am following, and this is the non-ampullary end of the posterior canal here if I am following. See this, it is going. Are you able to appreciate this?
Yeah, very clear.
And you see they join together here to form the crus commune. See, they are coming close to each other now. And that's how they form the crus commune. Can you see those two ends coming close to each other?
Yeah.
And out of all the opening, the deepest is the crus commune here. See this? That's a single opening they are going to open here into the vestibule. Now first coming to the Dr. Paramita's question. Solid angle. Solid angle is what? The angle between all the three canals here. That is solid angle, and that is pierced by a structure, vascular structure. Yes, sorry. So that is pierced by a vascular structure here. That is subarcuate vessel. See, this vessel is very important, and I cannot forget an incident in a child, 2-year-old child, who developed meningitis with a small episode of otitis media. So this canal through which this subarcuate vessel communicates to the posterior cranial fossa. If this canal persists wide, which generally closes at the time of before the time of birth, if it persists as a big canal, can be a source of infection to the cranial cavity from the middle ear. And that was we had a child a few years back with a single episode of otitis media, was given amoxicillin all, and third day he presented with meningitis. Ultimately he was treated on that line. The scan showed a huge patent petromastoid canal. So this is petromastoid canal, which is in communication from the mastoid to the posterior cranial fossa. See this? That contains an artery known as subarcuate artery, and this angle between the three canals is known as a solid angle. Now the next is to answer Pawan's question about the Donaldson line. See this? This is the lateral canal, the posterior canal. We have seen this is the posterior canal.
Yes.
Now, if we draw a line in plane with the lateral canal here, crossing the posterior canal here, the area inferior to it, to this line which is crossing, is the best area for finding the endolymphatic sac. Can you see the endolymphatic sac coming into picture?
Yeah, it is.
Yeah, very clear.
This is endolymphatic sac. See this whitish. So this is Donaldson described this line in the axis of the lateral canal bisecting the posterior canal, and immediately inferior to that line, that is the area of the endolymphatic sac. And this is a dual fold of dura containing the prolongation of the endolymphatic duct, which is known as a vestibular aqueduct containing the endolymph. There is another communication of the inner ear to the posterior cranial fossa through a duct, that is the perilymphatic duct, that is cochlear aqueduct, which I am going to show you later, but that contains perilymph. See this endolymphatic sac, whitish sac. Can you see very clear?
Yeah, very clear.
This whitish sac. So now, so far we have seen all the three canals and where the vestibule is. The question still persists where the vestibule is. So vestibule is deep to it. And why vestibule is important? Because vestibule contains the perilymph, it contains the vestibular end organs, the utricle and saccule, and that area is important for many of our surgeries related to the vestibule. When we do stepidotomy, we put a piston in the vestibule. We have to be careful our piston should not damage the vestibular end organ in the depth of the vestibule, so that's why I keep the length of the piston not very deep. Is the Ashish gone?
Yeah, go.
No, I'm there, but I'm not talking. I'm not talking at the request of the organizers. So you carry on.
Yeah. Ashish, we need you.
No, I'm there. I'm watching.
As we come to the vestibule, we'll need your comments. What you are doing these days? Something new onto the vestibule. We would like to know. So now these are the semicircular canals together. So what I'm trying to say, the vestibule is a deeper structure, deep to which is intra-aortic canal, and vestibule is deep to certain structures. Now, number one, from below upwards, the structures lateral to the vestibule. Number one, the inferior most is the oval window. See this stapes? Stapes, I am removing this bone. Can you see the cavity below?
Yeah.
That is vestibule, but this is not the small cavity, what vestibule is. This oval window covers only the anterior-inferior part of the vestibule, not the entire vestibule. So this is the sixth opening to the vestibule. 5 we have already seen, semicircular canals. The sixth opening of the vestibule is the lateral one that is covered by oval window. And that is antero-inferiorly covering the vestibule, not the entire vestibule. Now what is covering the vestibule above that? This facial nerve. See this? This horizontal segment of the facial nerve covers the vestibule. So, in order to uncover the vestibule, just here for the sake of demonstrating anatomy today, I will remove the facial nerve from here, so that I can drill this fallopian canal to reach to the vestibule. So that is the middle part of the vestibule, which is covered laterally by the fallopian canal. See, the facial nerve, we know, as I told, we'll do a dedicated workshop on that, is a very important structure in the temporal bone. All the pathology, the treatment of all the pathology is dictated by the facial nerve and carotid artery. There are two structures in the temporal bone.
Can you hear me now?
Pardon?
Satish, you can hear me now?
Pardon?
Satish, Dr. Morwani, can you hear me? In between you could not hear me.
Yes, I can.
No, in between you could not hear me. Anyway, okay, thanks.
So I am removing the facial nerve from here. Just we are showing the anatomy, so I am removing it from here. Now before I remove, let me tell you about the importance of the course of the facial nerve here in the temporal bone. The one structure in the temporal bone, see, it is entering from the stylomastoid foramen, genu, anterior genu, then anteriorly. Another structure parallel to it and deeper, here in the floor of the Eustachian tube is the carotid artery. That enters from below, parallel to the Eustachian tube as a vertical petrous carotid here, then a genu, and then run anteriorly as a horizontal segment. These are the two important structures running to the temporal bone, which dictates every major surgical procedures in the lateral skull base. That's why in the past, many of the lateral skull base pathologies were considered to be inoperable because of these two structures coming in the way. But now with the advancement in surgical technology, there are a number of procedures described which we are now using in our practice to address even the tumors deep to these structures by doing certain maneuvers. So there is one maneuver known as the anterior transposition of the facial nerve. What is that? What is anterior transposition? This vertical course of the facial nerve is crossing the jugular bulb here and then coming out in the parotid. Now in tumors, particularly vascular tumors of the jugular foramen here, if this facial nerve is there laterally and you are dealing with a vascular tumor deep to it, you can certainly cannot access the tumor so efficiently, and at the same time you can end up injuring the nerve as well, and with inadequate access to tumors like glomus invading the carotid artery, you lose the control over the carotid and end up injuring the carotid as well. So in that situation, the procedure what we do is, we elevate this entire facial nerve right till into the parotid, beyond the bifurcation, this entire thing up to the first genu, and lift this anterior, everything anterior to it, so that this anterior area is now free for work to go deeper, that is anterior transposition. And this gives some sort of, obviously paralysis because the blood supply, the facial nerve is taken off to some extent, but it recovers to grade in most of the cases. We have a live demonstration probably on Thursday, glomus jugular case, and then we'll show how to do this transposition and the fine points of the transposition. Now, as I mentioned, takes of the blood supply. To give a insight about the blood supply at this point of time on the facial nerve. This facial nerve has a unique blood supply. The one vessel entering the facial nerve from above is the descending petrosal artery, which is a branch of middle meningeal artery. Okay? Other vessel ascending the stylomastoid foramen from below is a branch of occipital artery and sometimes posterior auricular artery, known as stylomastoid artery. These two vessels, throughout the course of the facial nerve, circumferentially in the subperiosteal plane, form an arcade of vessels around the facial nerve. So when you lift off the facial nerve for transposition, you take away the blood supply to a certain extent, though it recovers and acquires from the bed, the new bed, but it gives to some sort of facial paralysis or facial palsy, which recovers most of the time. Now, another transposition of the facial nerve, before I remove the facial nerve, another transposition of the facial nerve is, why transposition? Because you have a tumor deep to facial nerve and the facial nerve is coming in the way. So another transposition happens to occur in the deep tumor invading the clivus and you are going by the transcochlear approach. Mario Sana, the phenomenal Mario Sana, I call him phenomena, who's revolutionized the lateral skull base surgery and what Movani sir has done in our country. Mario Sana described the modified transcochlear approaches by means of which we can address every single area of the lateral skull base. In type A, B, C, D, various modified transcochlear approaches. Like transcochlear approach A, you can address the petroclival region, you can address the clivus very well without retracting the brain, without retracting the cerebellum. What you need to go through the petrous bone. So inherently that sacrifices the hearing. At the same time the facial nerve comes in the way. So in that situation you need to transpose the facial nerve behind, which I am going to show you. So in that situation, at the first genu here, there is a branch for facial nerve going anteriorly, which I will show you, GSPN. You cut the GSPN and follow this entire facial nerve right from the stylomastoid foramen to first genu to the labyrinthine segment to the canalicular segment and push everything behind on the sigmoid sinus. So you can put the entire facial nerve behind and this area can be free for drilling of the entire cochlea and everything to reach to the clivus and the petroclival region. That is modified transcochlear approach A. What all it requires is facial nerve transposition. And for that it requires a transection of the GSPN, and you can place the entire facial nerve right from the porus acousticus to the stylomastoid foramen behind. The facial nerve will be completely free. That is posterior transposition, and that gives the widest access. See this entire wide access to the lateral skull base. Ask me, believe me, single approach giving widest possible exposure in the lateral skull base to address any given lesion in the lateral skull base anywhere with a modified transcochlear approach. What all it involves? It inherently sacrifices the hearing. It results in some sort of facial paralysis. So for that reason, how to choose this approach? Any lesion which has already sacrificed the hearing, where the patient has already lost the hearing and developed some sort of facial palsy, that is the ideal approach to address. At least you get a widest possible access without brain retraction. Two-handed approach under microscope and you can remove the tumor in the best way, I would say. So that is posterior transposition, and what all you need to do here is, let me show you. See this, I am going to the first genu here. Go to the first genu, find that is the facial nerve, that is the facial nerve, and go to the first genu, choti diamond hai na. Find the GSPN and transect the GSPN anteriorly and lift the entire facial nerve behind. That is posterior transposition of the facial nerve, quick. So after this I am going to sacrifice this facial nerve here so that I can go deeper to the labyrinth, which is our area of interest today, the cochlea and the vestibule and the intra-auditory meatus. For this, see now, I am going to the first genu of the facial nerve by drilling this bone above. This is in close proximity to the superior semicircular canal. Side knife. See this, superior canal is in close proximity. Side knife. And see now, I have thinned out this bone. I can remove this bone, thin bone over it. Thin bone over it. See the facial nerve? And here at this point, at the genu is the dilatation of the facial nerve here, and that contains the cell bodies of the sensory component of the facial nerve. Facial nerve has two components, the motor and sensory. The sensory component is contributed by the nerve of Rissberg. Nerve of Rissberg, and that is the sensory nerve of the facial nerve, which joins the facial nerve in the intra-auditory meatus. It arises separately from the brainstem and enters the intra-auditory canal separately, joins the facial nerve in the intra-auditory canal, and then here it gives branches at this point of time. It's a choti de number. See this is the dilatation of the facial nerve here, and here the facial nerve will take a steep, deeper and posterior curve to continue as a labyrinthine segment. So from here, the sensory part will continue anteriorly as a greater superficial petrosal nerve. That will contain the fibers of nervus intermedius or the nerve of Rissberg, not the motor fibers. And that contains the secretomotor fibers also to the palatine and the lacrimal glands. I will show that. And here is the course of the geniculate ganglion. See, quite deeper, and if I am working from here, if the space is narrow, I can easily damage the superior canal with my instrument. So here the nerve goes deeper and deeper and turns posterior as a labyrinthine segment. This labyrinthine segment, I will show exactly how it comes in contact with the ascending turn of the basal turn of the cochlea, where it gives a problem of stimulation during cochlear implantation. So that is the closest proximity, I would say, of the labyrinthine segment to the cochlea. I will show that later. So here, if I continue this anteriorly, you will find the GSPN. So GSPN is an important nerve for that matter. Why? This GSPN here is a peculiar anatomy. This is a very good landmark in cases of middle fossa approach, where we take into consideration GSPN as a landmark. See now, this is the horizontal facial nerve going anteriorly, and this is the canal for tensor tympani containing the tensor tympani muscle, which I am removing here. So the facial nerve is above, canal for tensor tympani is below. This is the bone over the facial nerve which I am removing. See this? After thinning out this bone over the facial nerve, and that here anteriorly it continues as a GSPN. That probably is the GSPN. Can you see that? The anterior continuation here? Hello?
Yes.
That is how the GSPN. So you have to cut this GSPN to turn around the facial nerve. That is for posterior rerouting. Now the GSPN is a very useful anatomy for the middle cranial fossa approach. I tell you, middle cranial fossa approach is a versatile approach for many indications. You have to come from above. So in that case, to identify the landmarks, the labyrinthine portion, the intra-auditory meatus, one of the best landmark is the GSPN. So this GSPN is actually the sensory and the secretomotor component of the facial nerve. It goes anteriorly from here. See, like this. Absolutely anteriorly, far anteriorly. And what is the structure run below it anteriorly? The horizontal petrous carotid. See, in the floor of the Eustachian tube is the carotid artery here. That takes a turn anteriorly, horizontal petrous. And just parallel and above that runs the GSPN. The only difference is the horizontal petrous run extracranially and GSPN runs intracranially. They run anteriorly up to the level of the foramen lacerum. And there is a crossover there at the level of the foramen lacerum, where the horizontal petrous carotid becomes intracranial and the GSPN become extracranial. That is crossover. So that is how this anatomy is important, and that time the GSPN which become extracranial at the level of the foramen lacerum. It joins a deep petrosal, which is sympathetic from the carotid to form the median nerve, and then continues in the median canal that appears in the pterygopalatine fossa. So to give the secretomotor fibers to the nasopalatine glands and then to the lacrimal gland to the zygomatic nerve. So this is how the anatomy of the branches of the facial nerve is, how important it is. So this is the facial nerve. Let me show you the labyrinthine segment. See this facial nerve? I hope it is clear to everybody.
Can you increase the magnification?
Okay, let me increase the magnification and show you. See, this is the anterior segment going GSPN, and this is the medial segment going as a labyrinthine segment. Can you see clearly?
Yes, yes.
This V-shaped structure, this is the labyrinthine coming, then horizontal. Let me remove this bone little bit. I have a fear of injuring the nerve, that's why. Let me. See this, how the labyrinthine segment is going deeper and behind. So this angle of bone, this angle here between the two parts of the facial nerve, let me remove this. This angle between the two parts of the facial nerve, see the facial nerve labyrinthine segment, everybody. Can you see the labyrinthine segment here? And that is the GSPN. Paramita, am I clear? See, for everyone, this is GSPN which I have cut anteriorly. This is the rest of the facial nerve which is cut here. And this is the labyrinthine segment which is left behind. See the labyrinthine segment. I hope it is very clear. Am I clear?
Yeah, you're clear, very clear.
This is labyrinthine segment. Now, from this point of view, having seen the facial nerve, having elevated the facial nerve in the fallopian canal, now I can go deeper. I haven't mentioned anything about the cochlea so far, because the time for the cochlea I will mention is where I will show from the beginning how the cochlear duct forms, how the cochlear terms are made. That is, I am going to show from beginning.
Satish?
Yes, sir.
Why don't you show them a neurectomy, tympanic neurectomy before you do the cochlear work?
Yes. Okay. Yes, sir. This is the right point of time for Pawan asked, the tympanic neurectomy. See, this is the promontory, which is basically the basal turn of the cochlea. This is crossed by a nerve. Can you see this nerve here? Can you see this nerve? Making an impression on the promontory. Let me increase the magnification. Yes. Can you see this nerve coming from below? Yes, vertically up.
Yes.
See this nerve coming from below, vertically up. Can you see this all the way?
Yes.
Going deep to the processus cochleariformis. That is the tympanic branch of the glossopharyngeal. See, I have elevated this now all the way. Can you see?
Yes, boss.
Yes.
This is the tympanic branch of the glossopharyngeal. It is coming from below. See here where, if I drill this bone, it is coming from the area known as crotch. The bone between the carotid artery anteriorly and the jugular bulb behind, and in between them is a branch of the glossopharyngeal coming here right on the promontory to go deep to the the processus cochleariformis. And this here, this now along with the caroticotympanic nerves forms the tympanic plexus, which is an important plexus for innervation of the parotid gland, the postganglionic fibers to the parotid, as well as this is responsible for neuralgia and any pain in this region as well. So, this Jacobson's nerve, pardon?
This Jacobson's nerve can also be taken as a landmark for apical turn, no?
Yes. Not only apical turn, sometime in difficult situation for the round window also.
Yes, boss.
Because see, this Jacobson's nerve is running, see this antero-inferior to the round window. So this can be taken as a landmark sometime. Now, this is coming out of here from the jugular foramen. For that matter, here two nerves come out of the jugular foramen here. The one is the Jacobson, which comes between the jugular and the carotid to run on the promontory. The other one comes lateral to the jugular bulb, here lateral to the jugular bulb, and coming posteriorly crossing the facial nerve here, crossing the facial nerve here, and then coming to the posterior canal wall. That is known as the Arnold's nerve, is a branch of 10th nerve. The auricular branch of the vagus nerve, that again comes from the jugular bulb from its anterolateral wall. Now this Jacobson's nerve, what does it do? We have seen the course of the GSPN just now. Now what is the course of the Jacobson further? This Jacobson nerve is the principal component of the lesser superficial petrosal nerve. Lesser superficial petrosal nerve has been extensively studied by none other than the maestro Albert Roten. Albert Roten is considered as the father of skull base anatomy. No other person has worked so extensively in the skull base anatomy anywhere close to Albert Roten. He is unfortunately no more. Last year he expired. So he wrote a book, Roten's book on the skull base anatomy. He has produced number of hundreds of videos, mind-blowing, simply mind-blowing. No one can do that kind of dissection. He did more than 3,000 dissections on the fresh cadaver heads. In his laboratory, he had more than 15 navigation systems, caliper systems. Was a committed person for anatomy, and what not he has done for anatomy. So he thoroughly, extensively studied the lesser petrosal nerve. Let me tell you in brief how the lesser petrosal nerve forms. So lesser petrosal nerve has the biggest component, comes from the tympanic plexus, and that is to the glossopharyngeal and the caroticotympanic nerves. As this nerve ascends deep to the processus cochleariformis, it runs anteriorly below the greater petrosal nerve, and here it gets a twig. It gets a twig from two more nerves. It gets a twig from the facial nerve just at the level of the anterior genu. That is a small twig from the facial nerve to the lesser petrosal nerve, number one. Number two, I mentioned about the Arnold's nerve coming to the posterior canal wall. This Arnold's nerve coming to the skin of the posterior canal wall through the tympanomastoid suture line. This nerve run anteromedially and run in the fallopian canal, inside the fallopian canal. Some fibers of the Arnold's nerve run in the fallopian canal anteriorly, not in the facial nerve sheath. Outside the facial nerve sheath in the fallopian canal, go towards the anterior genu and leave and join the lesser petrosal nerve. So the lesser petrosal nerve again is formed of twigs from so many nerves. The tympanic branch of the Jacobson's nerve, caroticotympanic, from the facial nerve, and then from the auricular branch of the vagus nerve to complete as a lesser superficial petrosal nerve, which goes anteriorly and come down in the infratemporal fossa through a foramen, and then through the auricular temporal nerve supply the postganglionic fibers to the parotid gland through the otic ganglion. So that's how these nerves have postganglionic fibers, how they are connected with the facial nerve. Facial nerve has an extensive network of nerves supplying various parts, various glands in the head and neck, and supply more than 50 muscles of expression of face is supplied by the facial nerve. How complex the facial nerve is. That's why dealing with the facial nerve injuries required a separate discussion, is a huge subject, and it's a complete subject. When you talk of the facial nerve, I am not covering it here. We'll do in a separate workshop later on in the webinar. So here now I have removed the facial nerve, and now I will move on to the deeper part of the dissection of the inner ear. Sandeep. So now what I am going to do, the cutting there, I am going to tell thodi badi.
सतीश
हाँ सर
सतीश इधर इनको मास्टर टिप कैसे एक्सरसाइज करने का दिखा दे तेरा मास्टर टिप बहुत अच्छी तरह खुला है बच्चों को मालूम नहीं मास्टर टिप कैसे निकालने का
okay let me show here first
you have very good dissection that area
yeah so what I am doing now once you have seen the mastoid tip I have already hollowed it out, it is mobilized. What all you need to do in a live surgical situation, see it is already hollowed out. You have to separate from the muscles outside. I told you in order from medial to lateral to medial, the muscle attached to it is the sternocleidomastoid, the splenius capitis, and the most medial aspect. This is digastric.
In practice, you do the cauteric. In practice, you do the cauteric.
And see this digastric, which was forming the ridge here, and this is the facial nerve anteriorly at the stylomastoid foramen. Give me the artery forceps here. So you have to be careful while removing the tip so as to prevent injury to the facial nerve. Now, in the live surgical situation, like sir said, to remove the tip, it doesn't increase your size of the mastoid cavity. Believe me, as you open up the neck, all these muscles tend to fall inside the cavity to reduce the size of the tip. Now see, at this point of time, I am elevating the soft tissue. Let me open it and see the course of the facial nerve. See this. The moment the facial nerve comes out of the foramen, see the facial nerve. It becomes so lateral, steep, ascending like anything. See this? Can you see the nerve?
Yes, sir.
Very clear?
Yes, sir.
See it ascending and see what it is crossing. This vessel, that is the stylomastoid artery. Can you see this?
Yes.
See this artery? And that is a branch of occipital artery here. See that? And now, if I follow, see the nerve is ascending in the parotid. It is ascending steep. See how lateral it becomes here. Can you see this?
Yes.
And here it bifurcates into two divisions. The temporoparietal and the cervical facial. Can you see that? The simplest way of identifying the facial nerve. Can you appreciate this?
Yes.
Now, as it leaves the stylomastoid foramen, the facial nerve gives number of branches. The first branch, though it's not very consistent, the first branch goes down deeper, joining the glossopharyngeal and ansa of Heller. In 70% of the individual, it has a communication. All these communication helps in regenerating the facial nerve in cases of injury. Now see the second branch. See the nerve going to the digastric, everyone?
Yes. Posterior belly.
Can you see the nerve going to the posterior belly of digastric?
Yes, boss.
Very clear or not?
Yes, yes, it is seen.
Then the third branch, these are the nerves, the slender nerve, these are going to the stylohyoid. Styloid process is a deeper anatomy to the facial nerve. And all these slender nerves go deeper. Can you see the nerves there going deeper? Can you see these small branches going deeper?
Yes, yes.
This branch, this is now to stylohyoid. As stylohyoid is one of the muscle attached to the styloid process. One of the lateral muscle. See this now to digastric, now to stylohyoid, and then it bifurcates into two divisions. And these two divisions further bifurcate. And as they reach to the end point facial muscles, these nerves divide into hundreds of ramiz, hundreds of small interconnecting branches. That's why in the parotid surgery we always emphasize. Parotid surgery, you'll see the head and neck surgeons, they will preserve 5 branches of the facial nerve. Believe me, that is not the ideal preservation of facial nerve.
Yes.
You have to preserve all interconnecting branches. That is possible only once you do with microscope. If you do the parotidectomy with microscope, you can preserve all interconnecting branches, and those are most important for regeneration of facial nerve in case one of the branch goes weak by means of handling or anything, by damage. It can result into almost complete recovery if you have a interconnecting branches preserved. But that science of microscopic parotidectomy is not growing because the most of the so-called head and neck surgeons are general surgeons, or they are not used to microscope. So they will never propagate this microscopic parotidectomy, which is, I believe, is the gold standard for parotidectomy to preserve.
But Satish, a lot of them have started using loop. Not everybody, but a lot of them.
Loop cannot match a microscope.
It's not a replacement where magnification is only 4.
Yeah, but that cannot match the microscope.
Satish boss, there is nothing better than microscope. There is nothing better than microscope in parotid surgery. Because you want to save each and every interneural ramification which is joining.
Yes, yes, exactly.
Satish,
yes.
Senior most ENT surgeon alive is watching your dissection. His name is Dr. Majumdar from Pondicherry.
Oh, I am so grateful
87
to
years
him.
old. He called me to say what a fantastic dissection you are doing.
Oh, thank
For
you.
your information,
Convey my regards to sir. He called me day before.
ENT surgeon in India to do a temporal bone excision in 1970. 1970, Dr. Majumdar had done a temporal bone dissection. He had done about 55, 60 cases. Okay. He just called me to say, wish you well and
thank you,
take
sir.
congratulations to you.
Thank you, sir. Now coming to the coming to the vestibule now. Now we have kept the facial nerve away. We had a little bit discussion about the facial nerve because we kept this nerve away, so we need to know about it. Now I am drilling away all these canals. See this? And see all these openings, how and where they open in the vestibule. How they open into various walls of the vestibule. See how big the vestibule deeper down.
Yes.
See how big. It is deep to the oval window, it is deep to the facial nerve, and it is deep to the canals. The horizontal, all the three canals. See this, how the openings, they open into the, all the canals open into it. Can you see very clear?
Yes.
See how big the opening of the vestibule is. So this is roughly 5 to 6 millimeter dimension in this. Superior, inferior, anterior, posterior, and the depth is over 2 millimeter. So this was the opening of the ampulated end of the superior. Here was the ampulated end of the lateral. This is the non-ampulated end of the lateral. Let me show you other two openings. See, this is the posterior one. Let me show you the ampulated end of the posterior canal, how it opens in the posterior inferior wall of the vestibule. Because anterior inferior wall of the vestibule is related to the cochlea. I will show you the beginning of the cochlear duct. And this is how the crus commune opening. See this ridge of the bone, the thick bone, I am drilling away with a cutting bar, and that shows, see this bridge of the bone through which the crus commune is opening inside the bridge of the bone. See the crus commune. See that? That is, see the opening of the posterior canal. See all this, and this is the neuroepithelium of the, see this is neuroepithelium of the vestibular end organs. Very clear? Now there are certain impressions. Are you getting a good picture?
Yes, yes.
See the vestibule now completely uncovered. So how deep the vestibule is, that is what I wanted to show. Now I am coming to the vestibule and then the cochlea.
Satish, can I bother you?
Yes.
First, you show them infracochlear dissection up to petrous apex before you go on to the cochlea.
I will show, sir.
Yeah, infracochlear approach.
Yes,
show them a jugular bulb. Show them a carotid artery in that.
Yes. I will go later, sir. Not now. The
Cochlea
reason is
ke pehle. Let the cochlea be intact before you show infracochlear dissection.
so that I think we should go in advanced part after the cochlea.
Because
This is not a bone. This is the body where everything is intact. We can show all deeper structures later. I will come to it definitely, sir.
Okay, do it.
So people will otherwise lose orientation about this inner ear. So now we have reached one aspect of the inner ear by drilling all the semicircular canals. See the circumference of all these canals. See, this is the crus commune, how it is forming. And see the posterior canal, how it is opening. And this is the entire vestibule. Now, at this point of time, I want to draw your attention for certain things. How the cochlea starts. Let me show you. And what is the significance in cochlear implantation of understanding this anatomy? If you follow this, believe me, you can carry out the cochlear implantation almost atraumatic by understanding this. See, I am removing gently this bone. This is the round window you have already seen. Can you see this?
Yes, boss.
Hello?
Yes, boss. We can see that.
Yeah. Now, the diamond enough, patli. The cochlea we know has three ducts. The scala tympani, scala vestibuli, and the scala media that we should know. Before that, the last part, let me finish off. That you were asking in the beginning, sir was asking, cutting the medium size. That is the vestibular aqueduct and the endolymphatic sac. And then I'll go to cochlea. So, we have seen how many openings of the vestibule? 5 are the canals, 6 were the stapes, and see 7th there in the floor of the vestibule anteriorly here. Can you see here? I will show this later.
Microscope, आगे कर microscope.
Yeah.
Moving microscope in front.
Yes, that is the opening which I am going to show you later for the cochlea. That is beginning of the cochlear duct here. So that is the 7th opening of the vestibule, okay? Can you see here?
Yes.
And the 8th one is in the medial wall. That is the smallest of all, like so small that you can barely pass a hair. See this opening here in the medial wall?
Yes.
Can you see this? This is the opening of the vestibular aqueduct. Can you see this?
Yes.
Let me drill away and show this J-shaped vestibular aqueduct. This is absolutely J-shaped in the medial wall. See this white structure in the medial wall?
Yeah, it is coming.
See, you need to know this anatomy, where the intra-auditory meatus should come, where are the cochlea, vestibule, when you deal with the inner ear lesions. Petrous bone cholesteatomas, tumors of the petrous bone, so many things beside cochlear implant, that everything is so important. Now see, can you see the course of this duct?
Yes.
See this duct, this is vestibular aqueduct.
Yes. So this is a bony aqueduct which harbors the endolymphatic sac.
Yes.
Endolymphatic duct, not a sac. Sac is the
Sac is the end.
Sac later on.
Sac is where it ends here.
Yeah.
See, this is the two layer of the dura. See my instrument between the 2 layers of the dura. Can you see?
Yes.
So that is a sac.
That is the endolymphatic sac. See, let me show you. These are the 2 folds of the dura. You can see now better. Can you see the interior of the sac?
Yeah.
Yes, yes. Interior sac is like mucus layer.
Yeah.
Exterior like a fibrous layer.
And this is the endolymphatic duct, beginning in the medial wall of the vestibule here. So that's how vestibule has 8 openings. So the 8th one is the most important now I am coming to for the cochlear implant surgeons. So now my focus would be on the anatomy of the cochlea. That is the most important of all. That is Pandal. Give me a smaller one. Choti the diamond. So cochlea, as I said, are 3 parts. The cochlear duct. Human cochlea has 2.5 or 2 3/4 tons. Out of that, the basal ton is the biggest one. From superior to inferior, in all dimension on CT scan, whatever cochlea you see, it's always basal ton. The rest of the 2 tons are in the lap of the basal ton. Okay? So I will show you in every ton there are 3 ducts running parallel. The scala tympani, scala vestibuli, and the scala media. And this has a strong bearing on the cochlear implantation so that you don't traumatize the residual hearing. You give the minimal intracochlear trauma and come out with the cochlear implantation. And that's what I'm going to show you now, to give you a 3D picture how these canals are going to be in relationship in all the 3 tons all the way. The same configuration remains in all the 3 tons. I will make it very, very crystal clear. It is otherwise difficult to understand by reading book or anything. So let me show you how the 3 ducts are there. अरे यार इतनी छोटी नहीं यार, इससे थोड़ी बड़ी देना. I am waiting for the burr point. So now what I am trying to say here, let me give you a magnification. See this. Concentrate what I am trying to say. This is the basal ton of the cochlea. This basal ton is a scala tympani. Scala tympani is covered on side by a, can you see this window?
Yeah, round window membrane.
I am removing this round window. Can you see this?
Yes.
That is covering the scala tympani from side. Can you see this entry?
Yes.
Patla dissection. See this entry. Now if I am doing an implant from this side, see this in the regular position. If I place my implant through the round window, this looks quite favorable. Otherwise, see this, and this is what in the medial wall is modulus. See where my instrument is. Modulus. Modulus is what? Is the central core of the cochlea around which all the three turns with three ducts together. Okay? So this is the modulus inside, and this inferior cavity, inferior one, is the scala tympani. Can you see this? Now, once you are doing the implant, once you are doing the implant, suppose I am doing the implant from here. This is my regular position through the posterior tympanotomy. And if I remove the round window, this round window looks me quite favorable. You won't find every time like this. If I pass my implant like this, the first structure my implant will go and touch is the modulus. Can you see here? Okay. If I pass my implant straight like this, it will go and touch the modulus. And once it touches the modulus, it will then go here and there without your being in your control. So now, first of all, our aim is to pass the implant in the scala tympani lumen without touching here and there. It is like a three-dimensional tunnel. So what I will do now, the simplest manner what I can do here, I can remove this inferior wall. See this?
Yeah.
Just inferior. I will tell you the reason why not inferior, why not cochleostomy, why inferior. Now the moment I remove the inferior wall, what I have got now? See this. I have a straight away three-dimensional tunnel. Can you see now?
Yes.
If I pass my implant, it will go unobstructed now. Agreed or not?
Agreed.
Now why at this place? Now we have to understand anatomy. Had I done my antero-inferior cochleostomy here,
yes,
I will show what is there antero-inferiorly. Once I drill the cochlea, I will show how the basement membrane is running. The cochlear duct is running on the lateral most aspect of the cochlea, antero-inferior to the round window. If I make an antero-inferior cochleostomy, it's a disaster. The first thing it will hit is the basement membrane and the cochlear duct, scala media. Okay? And how will you believe? Once I show this. Okay?
Even boss, it can injure the stria vascularis and the spiral ligament.
Everything. See, I will tell you how the basilar membrane is fitting to the outer wall of the cochlea through a specialized endosteum that is known as spiral ligament. That specialized endosteum close to the basilar membrane is very vascular, known as stria vascularis, which is responsible for the ionic balance and so many other things, vascularity to the basement membrane. So now what I have done, I just remove the inferior lip of the round window. Can you see this?
Yes, boss.
And now you have a straight tunnel for the implant to insert. Now see, at this point, if I insert my implant, where my implant will go? Straight in the lumen. Can you see now?
Yeah.
Without hitting anything.
Yes.
If I did not remove, had I not removed this, my implant would go and first hit where? See, if I go like this. First go to the modulus.
Or the osseous spiral lamina.
I am going to show you.
Yeah.
That's what the anatomy I am going to show you. So my implant otherwise would go and hit this area, that is modulus.
Yes.
What I have done, I removed the inferior bone. I made a straight tunnel for the implant to go. See that?
Yes, boss.
This is the straight tunnel. Give me the implant. I will just put a dummy implant.
But Dr. Satish,
Yeah.
Dr. Satish,
Can you use the xyloendoscope to show the interest?
Yes, I am going to show you.
Dr. Satish.
Yeah.
Yeah, since we have started this part, cochlear part, one leading cochlear implant surgeon from India, Dr. Salab Sharma.
Salab is there?
I think he just joined. I think that will give
great to have him.
more discussion about.
Yes.
Because he is
That will be great to have him. Shalab, good afternoon. Pani dena mere ko. Cold drink la.
Put your video on, yeah.
Good afternoon. I'll just come online and I will be just with you in a minute. You just continue.
So what I am doing here, I am attaching my xyloendoscope first. The finer one, the xyloendoscope I am attaching is 1.3 millimeter to show you the interior of the scala tympani. And see, in the roof of the scala tympani is the osseous spiral lamella medially and the basement membrane laterally. They are arising from the modulus, separating this inferior tunnel scala tympani from the superior tunnel, that is scala vestibuli. Again and again, I will show you this 10 times until it is very clear to everyone. Now, isko clear karna. Light.
This would be the best part of the dissection, I think. Cylindroscope used as a...
वो focus कर. Focus कर.
Yeah, focus.
कैमरा फोकस करना है यार, गधा है तू. अबे कैमरा फोकस कर. सेवलोन दे. So what I am trying to show, this tunnel, see this tunnel? Can you?
Yeah.
Focusing.
And I am going inside the tunnel. Let me give me a section, fine section. Why I am showing this? This is the inferior tunnel, scala tympani, into which our implant should go. That will give maximum stimulation of the spiral ganglion cells. I will show you where are the spiral ganglion. Can you see the scala?
Yes,
Yeah, very clearly.
इसको उल्टा कर, कैमरा उल्टा कर, कैमरा उल्टा कर.
It's moving upside down. Yeah.
Yeah.
Yes. Now we can see osseous spiral lamina there.
Can you see this in the roof? Can you
Yes.
see in the roof medially a prominent bone?
Yeah.
Hello?
Yes, boss.
Yeah, we can see.
See how it is turning inferiorly, then anteriorly like this.
Yes,
Now
boss.
in the roof, towards the modulus on the left side of your screen, there is a thick bone, whitish bone. That is the bone coming from the modulus. Okay?
Yes.
That is osseous spiral lamella, very thin, fragile bone. Now this bone is going towards the outer wall of the cochlea.
Yes.
See that? But before the outer wall, it is ending. Can you see that?
Yes, we can see it there.
Before the outer wall, it is ending. And from that end of the bone, before the outer wall, there is a membranous duct. That is the basilar membrane. Can you see that?
Yes.
Let me again repeat it. I will repeat it 10 times. Medially here is the osseous the modulus. From modulus is this bone extending towards the outer wall, this prominence. That is osseous spiral lamella towards the outer wall of the cochlea. And before the outer wall it is ending, and it is filled up by a membrane, that is basilar membrane. That is closest to the outer wall, and both these structures are in the roof of this tunnel. That is scala tympani. Got my point?
Yes.
Is that clear?
Yeah.
Now let me come through the roof of this tunnel. Now this was the tunnel which we saw. Okay? Now I am coming from the other side. Let me come from the other side.
Dr. Sunil Dutt is asking, just ask Satish to drill and show the cochlear cecum and the ductus reunions under the subsubiculum between the vestibules and cochlea.
Pardon?
Dr. Sunil Dutt is asking,
yeah,
just ask Satish to drill, just to show the cochlear cecum and the ductus reunions under the subsubiculum between the vestibules.
I am coming to, sir. I am coming to, sir. I am coming to. This anatomy is complex. I am taking everything slowly, and I will repeat again and again until you grasp this. I will not leave it until I achieve that. So I showed you one tunnel. Could you see this tunnel? Now through the microscope.
Out of focus.
Yeah, I am focusing, boss.
Dr. Salva is with us now.
Shalab has joined?
Yeah,
Yeah, I
so
joined.
first you can comment.
Okay.
I'm here.
So Shalab, welcome.
Thank you.
So this is the scala tympani, what I am trying to say. I think it is very clear. And I had shown from inside with a silo endoscope that how the modulus was giving a lamella and was arching in the roof. See, again, this medial wall is the modulus, okay? And from here the spiral lamella was arching towards the roof here, towards the outer wall, okay? Enclosing it as a separate cavity. So this osseous spiral lamella was running towards the outer wall, and before outer wall it was ending. And from there till the outer wall was a membrane, that is basilar membrane. Okay? This is on one side. One side is the scala tympani side of the cochlear duct. Let me go to the other side of the cochlear duct, which is starting from the
Oval window.
From the vestibule. Let me drill this. See, I am drilling this outer wall of the cochlea a bit to show you this membrane. Yes, now. Now at this point, give me the pick. See the scala tympani very clear again and again. Now on the other side, अबे right angle देना यार. मौके पे कैसे बीट कर देता है? Right angle देना pick. See this. This is the modulus again. This is scala tympani. Now above that is a second tunnel. See carefully. Let me show from this side. Can you see a second tunnel?
Yes.
Wait.
Can you see a second tunnel? Can you see a second tunnel or not?
Yes, it is seen.
The smaller one.
Now we can see. Now we can see.
Let me remove the bone. That is scala vestibuli arising from the floor of the vestibule. This is vestibule. This is the spherical recess for the saccule. This is the elliptical recess for the utricle. At just floor of the vestibule anteriorly, a small duct is going. Let me uncover it completely. Yeah. Can you see the duct now?
Yes.
Can you see the second duct very clear? Now see the beauty how God has created this cochlea. Can you see the second duct very clear?
Seen, boss.
Shalab.
Yeah, I can see it. Very beautiful.
So now, see now what is this? This is modulus. This is scala tympani. This is scala vestibuli. And from the modulus, this bony lamella. Can you see this thin lamella?
Yes.
This is going towards the outer wall, this outer wall. And just before the outer wall it ends, and from there where it ends to the outer wall is a membrane. See this membrane. Can you see this membrane?
Yeah.
This is basilar membrane. See now? So on the osseous spiral lamella, which is arising from the modulus, this inner wall is modulus, this outer wall is the outer wall of the cochlea. Okay? From the modulus, the spiral lamella is arising towards the outer wall, dividing it into two halves. And before the outer wall, it ends and then a membrane closes till the outer wall. That's how separating into two cavities, the smaller one above the scala vestibuli and the lower one below the scala tympani. Is that clear, very clear or not?
Yeah, very clear.
Now let me draw a diagram to show you. External camera lana. Here is the time to show you on a diagram what I am exactly trying to say इधर on this paper. इधर आओ मेरे पीछे आओ इस पेपर पे फोकस करो मेरे पीछे से हाँ या इधर आओ यार थोड़ा ऊपर कर लो इसको now focus here. Are you seeing the paper?
Yes.
Hello?
Yes, boss. Carry on.
Okay. Now see what I am trying to see. Show. This is the outer wall of the cochlea. अरे यार इधर focus करो ना यार. क्या आदमी है यार.
पेपर पे नहीं कर रहा focus.
Can you see now?
No. Yes.
This is the outer wall of the cochlea. Okay.
Okay.
Now in the inner side of the cochlea is a central core of bone. This is a porous bone known as modulus. Okay.
Okay. Okay.
Now from modulus, this is the cochlear tunnel around the modulus. From modulus, a bony spiral lamella projects towards the outer wall. Can you see like this?
Yes.
And it ends over here. It ends over here. Now from here to the outer wall, is a membrane. From here to the outer wall, this gap is filled by a membrane. See this thin membrane?
Yes.
This is basilar membrane. Okay?
Okay.
Is that clear?
Yes.
Yeah. Now, what it has done, it has divided the cavity into two halves, the cochlear tunnel. The upper one, the smaller one, and the lower one, a bigger one. Okay?
Yes.
Which you have seen. Now, from here, where the basilar membrane filling the gap between the end of the osseous spiral lamella to the outer wall, This basilar membrane is. Okay?
Yeah.
From here, another membrane from the outer edge of the osseous spiral lamella superiorly arises to go to the outer wall. Another membrane.
Reasoners.
Can you see? From the edge of the spiral lamella, there are two membranes going to the outer wall. What we see from below, what you have seen, is the basilar membrane. Okay?
Yes.
And that above is the Reisner's membrane. Okay?
Yes.
And they are enclosing a very small space close to the outer wall of the cochlea. What we see from the middle layer, the outer wall of the promontory, here runs this tube. So all the way in the cochlea, there are three ducts running. The inferior one is the scala tympani, the superior one is the scala vestibuli, and in the middle, close to the outer wall, enclosed between two membranes, a very small duct going on, that is scala media. Is that clear or not?
Yes.
Yes, very good.
Very clear?
Very
Now,
good. Yes.
now, where is the spiral ganglion? Where is the canal of Rosenthal's carrying the spiral ganglion? So how does it work? See, on the basilar membrane are the hair cells. The inner hair cell single row and outer hair cell 3-4 rows like this. Can you see this?
Yeah.
On the basilar membrane, this is inner hair cell and those are outer hair cell. Can you see this?
Yes.
Now, the fiber of this hair cell pass through this canal in the osseous spiral lamella. See this?
Yeah.
There is a canal in the osseous spiral lamella through which this inner hair cell fiber pass to the modulus. See like this?
Okay.
Is that clear?
Yes.
And in the peripheral wall of the modulus, periphery, most peripheral part of the modulus, is a canal all around the modulus. In the peripheral part is a canal, the spiral canal of Rosenthal, which contains the cell body of the ganglion.
Yes.
Okay? So this is the cell body of the ganglion. The peripheral process is the inner hair cell fiber. Okay?
Yes. Yes.
Arising from the organ of Corti here in the scala media. It runs through an opening in the osseous spiral lamella to the modulus. And in the periphery of the modulus is the cell body of the ganglion. The central process of which continue in the modulus. Got my point?
Yes.
As a nerve fiber going to the nucleus in the brain. Cochlear nucleus. Now imagine this 35 centimeter of the length of the cochlear duct, length of the cochlea, making 2.5 or 2, 3, 4 tons. All the way, the laterally is the cochlear duct with the hair cell fibers, the osseous spiral lamella all the way this osseous spiral lamella have going fibers through it. Then in the periphery all the way is the ganglion in this tube, that is the spiral canal of Rosenthal, and the inner fiber of the spiral canal, the ganglion, is the nerve fiber that is known as the cochlear nerve fiber.
Yes.
That goes to the cochlear nucleus. So this is how the cochlea is made up of. Is that clear or not?
Yes, it is clear.
I would like to hear this from Paramita, if she has got.
Paramita?
Paramita.
Yes, sir.
I assume if you have got, everyone has got now. This is just an indication so that you can explain to everyone. That means everyone has got. So tell me how this cochlear tube is formed, the scala tympana, media, modulus, how they are divided. In brief, quickly. Hello.
ट्राई को किसको कठिनाई में डाल रहा है यार?
Hello.
Hello.
What is this for anybody? What is this? Modulus. Okay? What is this outer wall of the cochlea? From modulus, what is this going? Osseous spiral lamella. It is giving rise to two membranes before ending to the outer wall. The lower membrane towards the scala tympani architecture of the cochlea, because I am going now drilling out the entire cochlea. Anybody has doubt can ask question here at this point of time.
I think this last 20-minute discussion is what I think there's worth for all the PG students, those who are starting practice, and all the ENTs, those who want to exactly know the anatomy of inner ear. I think this
more than that, Rajiv boss, this is very important for all people who are doing cochlear implants.
Yes.
Because now what I am trying to show, where to put the implant. Now I am putting the dummy implant. How you can preferentially put the implant in the scala tympani without damaging the osseous lamella, without damaging the basement membrane. It should not go into scala vestibuli, and that will be optimum stimulation by implant of the spiral ganglion cell population without giving intracochlear trauma or minimal intracochlear trauma. And that is the need of the time. If you don't understand this anatomy, for all those who are doing implant, for them, if implant is like opening the round window or pushing something in, is a joke. It's a big joke. They're playing with the patient's life if this anatomy is not understood properly.
If any questions from the audience, please put forward. Any confusion about anatomy, please ask now.
Where is Paramita?
He's there.
Slept?
No. Actually, because of the video quality, we are putting down our videos and this thing.
Sir.
Yes.
Sir, I'm here, sir. People are asking you to repeat once again.
Okay. That I would love it again and again. I want everybody to understand it right now. All your future cochlear implant surgeons, and you will benefit every patient. Try to understand this fact. This is most important.
And Dr. Amit Kishore is also joined us. I think we will take his comments first. Dr. Amit Kishore, one more cochlear implant surgeon from Delhi.
He joined?
Also joining us. I think he's joining us.
Oh, welcome, sir. Now again, for the anatomy, I am showing on the paper and then I will go back to the place and show again on the cadaver. Because this duct, entire duct, I will now dissect. If you have shown one place, and in the entire course of the 35 millimeter, we have almost 35,000 fibers from the inner hair cells, inner hair cell, and those 35 fibers giving to 35,000 cell bodies in the spiral canal of rosenthals. And efferent fibers of those 35,000 cell bodies are forming the cochlear nerve. Is that clear? So now, this is the promontory, outer wall of the cochlea. This is promontory what you are seeing. Inside the cavity of the cochlea, in the inner core is the modulus. That is a porous bone containing fibers. Okay? Now, from modulus, a septum, the osseous lamella, is a thin bone. Again is a porous bone which is going towards the outer wall like this. And that ends before the outer wall. It ends here. And it leads to a membrane in relation to the cavity below scala tympani, completing this cavity to the outer wall. So this small area completing to the outer wall, this membrane is basilar membrane. Same from the spiral lamella, another membrane going superiorly towards the outer wall, that is Reisner's membrane, enclosing this scala media. Okay? And this cavity above is the scala vestibuli, which I had shown you, the smaller one. This is the larger one below cavity is the scala tympani, you have seen, which I had shown with the silo-endoscope. And in between a very small area, close to the outer wall, close to the promontory, all the way in the entire duct is the scala media that contains the organ of corti. So that contains the organ of corti, and from here the inner hair cell in the organ of corti giving rise to the fiber is going to the modulus, and in the outer wall of the modulus all around is a small cavity, outer wall, the small canal in the periphery of the modulus containing the cell body of this fiber, of this ganglion, that is known as the spiral canal of Rosenthal. So in the circumference all the way, there are almost 35,000 cell bodies of this ganglion containing this fiber from the inner air cell, and the fiber arising from the cell body that continues in the modulus and then through the cribriform plate into the intra-auditory canal as a cochlear nerve to the cochlear nucleus. I hope it is very clear.
Yes, sir.
Yes.
Okay, now let me show you some more facts. Let's get back to the dissection. Now, why we intend to put, just a minute, again show here. Why we intend to put our electrode in the scala tympani, here. Because if our electrode goes in the scala tympani like this, that is closest to the spiral ganglion cell population to stimulate, number one. Okay?
Yeah.
If we are using a lateral wall electrode, that is closest to the organ of corti to stimulate. If your electrode, if you are not knowing this fact and just pushing the implant, believe me, it is never something remaining in the scala tympani. There are so many retrospective studies done in the previously implanted patients everywhere, and a chunk of patients having implant lying in the scala vestibuli. Obviously, it will give hearing. As some sort of hearing you are giving, but that is not optimized one, and it is time to want to avoid that trauma. So your implant should lie here, not in the scala vestibuli. If your implant lies in the scala vestibuli, that is far off from the spiral ganglion cell population, number one. Number two, this will require more current to stimulate the spiral ganglion cell, and the patient battery will drain like anything, very quickly. And that intracochlear trauma, how will the implant reach in the scala vestibuli? From the scala tympani, it will damage the basilar membrane, it will damage the osseous spiral lamella, and then the implant will go in the scala tympani or scala vestibuli. And in order to do that, the endolymph in the scala media will come in contact with the perilymph of the scala tympani. Both fluids have different ionic composition for their optimum functioning of the hair cells, and that mix-up of fluid will result in significant amount of intracochlear trauma. So the bottom line is, when we are implanting, whatever technique you are using, I am not a dogmatic approach, having that I will do varia, I will do posterior tympanoidal, I will do whatsoever. There is no point in this fight. This is pure monkey fight if you are still fighting whether varia is good or posterior tympanoidal. The issue is, whatever technique you are doing, you should be able to insert the implant in the scala tympani. That is the bottom line. If you are able to insert your implant under vision in the scala tympani by any technique, it's by and large good. There is no question which technique is good or bad. If your technique is not able to push your implant in the scala tympani, that is something not acceptable. So there is no question of fighting. Altogether, the goal is to push the implant in the inferior cavity, that is scala tympani. Now, out of this discussion, I will show you inside the whole scala all the way in all the 3 tons. I will put a dummy implant and let's see how the implant goes. These inner dimensions of the scala are not constant. See, these dimensions vary. As you start from the round window, the scala tympani is so big. You have seen. Let me show you again. Amit sir, welcome.
Amit was is there. Dr. Amit Kishore is there.
Yeah, Amit Kishore sir, you are welcome. He is a very senior cochlear implant surgeon.
Great demonstration, Satish. Wonderful.
Thank you, Patlade. Thank you. We need your input. You have been mentored to so many institutions, sir, including our SMS. See now, again, those who have not seen before. See, this is the vestibule. I have opened the vestibule. This is the anterior part of the floor of the vestibule, which is the spherical recess harboring the saccule. And this is the elliptical recess harboring the utricle. And these are the semicircular canals we drilled off. Now, see now 2 openings. Here we remove the round window and the inferior bone to it. And see the straight short trajectory to the basal turn of the cochlea in the scala tympani. Now the other opening above, see that? That is scala vestibuli. Can you see?
Yeah, yeah. Yeah, yeah.
In between, this is the modulus in the inner wall, and this is osseous spiral lamella. See this?
Centralize, please.
Centralize, boss.
Oh, sorry. Sorry, I will repeat.
Yeah.
Yeah. Is the picture good?
Yes.
No, yeah, yeah.
Let me
now
focus.
okay.
Focus. You want
In
focus?
focus.
Now?
In focus.
That's good.
Now better?
Yeah.
Now see the two openings. The one lower one which was closed by the round window here. That is the dead end, which we opened and drilled the inferior wall of the round window to make it a straight shot insertion. Okay? The other opening is starting from the vestibular floor. That is a smaller one. That is scala vestibuli. In the medial wall, this is modulus. From the modulus, this osseous spiral lamella. See such a thin bone. See this?
Yes.
It is going towards the outer wall. This is promontory. And here, see this enclosed between at the end, close to the, see the cochlear duct.
Yes, sir.
Can you see the small duct? Close to the outer wall? Having two membranes, the inferior membrane, the basilar one, and the superior one is the Reasoner's one. And this is where starting where the osseous spiral lamella ends, just before the outer wall. I hope it is crystal clear to everyone.
Yeah, yeah, yeah.
See this? The 2 tons. Now the dimensions, they are equally important in implantation. See why we are all discussing all this. You could open the round window, push the implant and come out. That is also cochlear implantation. But without looking at the work you have done, the kind of intracochlear trauma you are given, the whole exercise is to minimize the intracochlear trauma. And that can be understood by understanding this anatomy of the inside of the cochlea. So,
there is a compliment from Dr. Sumit Mrik. He is saying since starting, today you have made the concept of anatomy crystal clear. Comments from Dr. Sumit Mrik.
Oh, thank you. Sumit knows everything I know. He is a very accomplished cochlear implant surgeon. He is being modest. I know Sumit is amazing. And he is also mentored so many people in cochlear implant. So, thank you, Sumit, anyway. So now, again, this is the osseous spiral lamella. Can you see?
Yeah.
Very thin lamella. And see at the end, before the outer wall, this is basilar membrane. And this is the scala media. Very narrow tube. Okay? I hope it is clear and we move forward.
Yes.
Now.
Yeah, go ahead.
Now, this scala has a different dimension as you go along towards the apical turn. As a basal turn, the dimension of the scala tympani is bigger one, and here the scala vestibuli is a smaller one. Okay? Now, as you go further anteriorly, I will drill away the cochlea completely. As you drill away, the cochlear tube is turning anteriorly, and here at the anterior end, it turns superiorly. Now, at the anterior end superiorly, the scala tympani starts constricting. Differently, it's not same in all patients, differently, but it definitely starts a constriction. And the way forward, the scala tympani becomes smaller and smaller and smaller. On the contrary, the scala vestibuli after that gains some dimension and becomes bigger than what it is at the beginning of the tube. So, the both tube are inversely expanding. The scala tympani is narrowing and the scala vestibuli is expanding. More than that, the inner dimension and configuration of the scala are changing. And that is very important. It's not that the inner dimension is spherical. It's not that it is rectangular. The vertical dimension of the scala keep changing. The moment you go beyond 180 degree anteriorly, the vertical height becomes down, and if your implant is not going in the floor, it may hit the outer wall and then the implant can go anywhere. So our goal is to push the implant in the lower a dummy implant. It is from the Advanced Bionics. Mostly I use Advanced Bionic implants. I don't know.
I've seen your love that.
Pardon?
Your love for that. I have seen you always operating with the AB.
AB, I love AB implants. So now I will show you the dummy implant and why I am showing you. So once I drill this all the way in the cochlea, we'll see where the implant has gone. Okay? So see, this is the electrode array.
Yes.
This is the electrode array inside this tube. What I am doing first of all, I am getting this electrode array out. अरे इसको हटा ना, इसको हटा यार.
Amit sir, your comments about the cochleostomy, which one you prefer?
Pardon?
I think,
your comments about cochleostomy, which one you prefer?
yeah, I think Satish has very nicely demonstrated the whole concept of what is called the extended round window. So by extending, by removing drilling a very little sliver of bone inferior to the round window membrane, you create
See, I am loading the implant. Yes.
Create an extended round window approach, and that, I mean, is now the preferred technique, Rajeev. I mean, when I started 20 years ago, we were doing separate cochleostomies, anterior, then anterior-inferior. So the safest and the straightest is if the electrode allows rise either through the round window itself or just by drilling the lip inferior to the round window membrane and then getting your straight trajectory, as Satish has very nicely shown. That is now the preferred
See
technique
now,
for implants.
Boss.
Yes.
Yeah, we are with you, sir.
See now my implant which I have loaded in this and pushing this all the way. To show you something, this was not loaded properly. Give me. So one thing I answer forever, boss. This question doesn't last anymore after that. Number one, what technique is best? Any technique which allows you to insert in the scalar tympani under vision is the best technique. There is no fight whether the varia is good or posterior tympanotomy. If you are able to do that with the varia, it's good. It should not be a blind insertion. Number one, for whatever technique you use. So that answers forever. Number two, whether to use round window, pale round window, scalar, or sorry, cochleostomy, this question should stop forever. Whatever you use, you should be able to do a straight shot insertion under vision in the inferior compartment, that is scalar tympani. If you are able to do through the round window, fine. If you are able to do through the peri-round window, if you are able to do the cochleostomy, whatever, the end result should be to place the implant in the proper area. Okay?
Yes, yes.
Yeah. Should leave it. That is the goal. Okay? Now what I am trying to say, my implant should go in the inferior compartment. Good enough.
Yeah.
Joseph. Now I will drill the cochlea and show you some important facts. There are certain myths I will tell you. The depth of insertion. See, all these fibers I have shown you, they run from the outer wall, the basilar membrane, towards the osseous spiral lamella and the modulus. Okay? So in the basal turn, all the fibers run horizontally in the modulus. In the middle turn, they will come obliquely, little obliquely in the modulus, in the lower down in the modulus. In the apical turn, they will come steep down into the modulus. So, another question is how deep should be the insertion? Again, there are certain, I have no words for those discussions and explanation. The cochlear duct length, yes, you can measure. It's good to know how long is the cochlear duct.
Yeah, Monish is asking the same question. Monish is asking.
Yes, Monish had a paper on the measurement of the cochlear duct length. That is good. But that is for the theoretical reason it is good. It doesn't mean that how long the duct is, you insert the implant into the same length. The reason is, like the medal has an implant which is 35 millimeter long. If you see the scala, I am dissecting this, see the dimension of the scala, see the spiral ganglion cell population. This, this cochlear duct, this is organ of Corti, this is extending right till 35 millimeter till helicotrema, right?
Yes.
But the spiral ganglion cell population is not extending. The spiral canal of Rosenthal is not extending to 35 millimeter. You don't have to go beyond 1.75 ton. You are unnecessarily giving more trauma than a benefit. Now, once you are not supposed to go beyond 1.75 ton, number one, what is the fun in making implants 35 millimeter? What is the fun in full insertion? What is the fun in, for the matter, measuring the duct length and finding the implant for that? No way. We have to understand this fact. We should not enforce the implant beyond 1.75 ton. That is maximum. For me, 360 degrees 1 ton, 450 degrees the last beyond which I will never go. Beyond that, I will give more trauma than any single benefit, number one. Number two, in that insertion, I will be able to stimulate the entire spiral ganglion cell population, which we need for that matter. It's not that we are missing any population for that. And third is very important. We are using the implant from the companies. We should know the companies what they are providing. The processor they are providing has a limited ability to stimulate certain frequency range. They do not stimulate the entire 20,000 hertz spectrum of hearing of a human ear. Human ear has a spectrum of hearing from 0 hertz to 20,000 hertz. From the apex to the end of the basal turn is 20,000. But all these cochlear implants, they stimulate a certain range of frequency that is from 70 hertz to 11,750. No cochlear implant, commercially available cochlear implants, stimulate a frequency range below 11,750. Mind it. So, the area of the frequency beyond 11,750 is useless to be stimulated for that matter. Be practical. So, the initial 4 millimeter up to 4 millimeter from round window, even if you are putting your electrode, it is not working. It is as good as useless. This is something we need to understand. All these are myth. Because the commercially available, all these processors, they do not stimulate a frequency range above 11,750. So the second thing now what I am showing is the depth of insertion. Depth of insertion should not be too much to give trauma, rather than should be adequate to cover the spiral ganglion population, rather than giving trauma. So let me drill away. I will show you the dimension of it.
Satish boss, can I make a comment here?
Yes, please.
Satish boss, you are absolutely right. Even Boyd and Buckner has got the largest series working on the depth of insertion. They have found that more than 360 degree insertion is useless.
Yes.
They compared it.
Absolutely.
And so on the other hand, you are going till the tip of the duct, like up to the.
Nobody is doing now. Nobody is doing now.
You are destroying the residual fibers, the residual hearing, which is there in the apical train of the low frequencies. So I think depth of insertion should not go up to the apical train.
Depth of insertion is very important. Now, I am drilling out the cochlea, the outer wall, and you will see all the way. See how it is turning and the important relationship. The most important thing which is related to the cochlea, anteriorly as the cochlea turns, is the internal carotid artery. See that? So once I tell you, I give you an example here. We are in the next webinar, we'll be doing a live case for CSOM, as I told you, subtotal petrosectomy and cochlear implant, same stage. We have done over 45 cases now. That is the same stage cochlear implantation, subtotal petrosectomy for many indications. Not only CSOM, for any difficult implant. If I am doing a tumor surgery.
पापा को ईमेल डालने को बोल रहा है, मैंने डाला ईमेल. You forgot your password करके मैं बोला.
Satish, we are doing on Thursday 4 p.m. onward. We are doing live surgery.
Yes.
And advanced live surgery, and it will last for 5 hours. Last like.
Yes, probably we'll be doing a glomus jugular and a subtotal petrosectomy with implantation.
Yeah, with implant.
Probably we'll announce tomorrow.
Yeah.
Yes.
नीचे साइन अप और लेकर बैक पैक करो कि ये bottom में left से back लिखा है.
Can you make his audio mute?
अभी आए जो.
Dinesh. So now what I'm trying to say here, what I'm trying to mention here, in cases,
join meeting का Zoom लगा पड़ा है.
Dinesh, can you make his audio mute? Dinesh sleeping.
Rajiv boss, you can do it.
मैंने जो
No, I cannot do it.
जो picture है ना उसके
Cannot do it.
Is Dinesh sleeping?
करके आया.
Dr. Hetal from Mumbai.
Boss, I can't hear. Movani sir is talking to somebody. Movani sir is talking to somebody. I can't hear you.
Sorry. There was some problem. I could not see the pictures. I was talking to.
Can you make your audio mute, sir? You can talk.
हो गया काम हो गया.
Yes, boss. Pachauri boss. What is the Hetal asking?
Yeah, Miss is asking Miss like wonderful demonstration, and Rajiv Kapila, and they're asking how you stimulate the modulus fibers, neural fibers with 360-degree only insertion. Right.
Yeah, I will come to it. Let me show them what is 360-degree, where the second turn starting, and for how depth we need to go. So I will, there's a good question from Rajiv Kapila, is from Ludhiana, and Hetal obviously. Both are amazing surgeons. So the question is valid and very important for everyone. So now what I was telling here about the subtotal petrojectomy at this point, why? I am drilling out the cochlea. In any given indication when you need a complete cochlear drill out, I would go for a subtotal petrojectomy. For reasons I'll tell you. I would never advocate through a posterior tympanotomy, narrow access, a complete drill out. You cannot control the carotid artery. You will end up doing a subnormal job and you can end up injuring a carotid artery. Number one, subtotal petrojectomy gives you the widest exposure to control the carotid and you can do a complete drill out, number one. Secondly, after the drill out, you have to stabilize the arrays, electrode arrays in the cochlear length, and that can be best achieved when you do an obliteration of the cavity. So, drill out procedure, if you ask me, I would never advocate without a subtotal petrojectomy. Subtotal petrojectomy is a procedure need of the choice, which has number of indications which can bring you out from the several problems. If any cochlear implant situation giving me a gusher, perilimb gusher, I would go preferentially with a subtotal petrojectomy and cavity obliteration to prevent future source of CSF leak and infection. Believe me, I give an example. IP1 is an anomaly. Obviously, a lot of people are doing IP1, and you can control the gusher by packing the cochleostomy or round window opening, whatever, by tight packing, whatever. But still, you cannot 100% ensure preventing a CSF leak, number one. Number two, all these IP1 anomalies have a defect in the foot plate. Majority of them have an endosteal anomaly of the foot plate, which gives rise to CSF leak. So even if you control the CSF through the posterior tympanotomy from the cochleostomy or round window, you cannot control from the foot plate. And that is the reason subtotal petrojectomy and obliteration of cavity is the answer. Unfortunately, in our country, I don't know why people are not doing.
Satish, you remember last workshop we did IP2?
Yes, that's what the example I would give. In Morwani sir's workshop last year, he had a case of a 3-year-old child with a CSF leak.
Meningitis, repeated meningitis.
Repeated meningitis, CSF. I was there for the workshop. The day before he showed me the case that we have to do this transmastoid closure of the CSF. When I looked at the CT scan, it was IP1. I told sir, the child has a profound deafness. I said, sir, this is IP1. He has a CSF leak from the foot plate. And why don't you counsel the attendant to get an implant done at the same time? The child had sensorineural hearing loss profound. He said he is not affording right now.
The funny part of this was, Satish, I'll tell you the history. This patient got CSF leak after head injury.
Yes.
So neurosurgeon went and did surgery in Pune.
Sir, that can
then
provoke.
he had come to us.
Yes, that was a provoking thing. Something which has provoked. But you go to the Senaroglu's classification. I strongly believe that guy who did years and years of study in the pathological lab, before devising the classification. It's not that you sit in the room and overnight you devise a new classification. Overnight you'll see hundreds of classification in ENT specialty. That was a real classification pathologically. He reached to the level, going to the pathology lab for 3 years together to understand the histopathology of cochlear malformation and devised. And in his classification you go, what he published in 2017, there is a strong incidence of a foot plate defect in IP1, which need to be considered and is a strong indication for subtotal petrojectomy in all IP1 patients. Otherwise, you are not avoiding, you are not preventing the possibility of CSF leak in the future, and that is a disaster. So, what I was saying here, in all the cochlear drill outs, I would recommend a subtotal petrojectomy.
In those cases, you are not doing only obliteration, you are doing cul-de-sac, obliteration with cul-de-sac closure.
Yes, obviously. See, once you have implanted, now you have given a different route of hearing. Your middle ear is not being utilized for hearing at all. There is no harm in doing subtotal petrojectomy. It's not taking away anything. That is a different pathway of hearing. Electrical hearing you are giving and middle ear system is not being utilized. So why to leave a possibility of complication in the future? Same thing in the CSOM also. If patient has a CSOM, you did a mastectomy, tympanoplasty, whatsoever, and after 6 months, 1 year, you implant on that. What will happen if the CSOM comes back with the implant in place? It will be a disaster. We never know. There is no 100% control over the incidence of CSOM. You never know why that patient earlier had CSOM, for what reason. You know the long-term success of CSOM surgery. Even the tympanoplasty, you go to the best series in the world, the primary tympanoplasty has over 90% success rate. But what happens 10 years down the line? You pick up all the series, long-term success of tympanoplasty 10 years down the line, less than 70%. You don't have a control of the physiology which is given to the CSOM. So in such patients, if you have implanted, what will happen? If the patient develops CSOM now with the implant in place, it's a disaster. Either, first of all, the infection is not going to come under control. That's a foreign body in place. That will attract biofilms. Whatever antibiotic you give is wastage. Number two, that becomes the source of spread to the inner, CSF space then, because you have already opened the avenues to the inner ear. So that can be detrimental to the patient's life as well. So in all CSOM, our approach is one stage, subtotal petrojectomy implantation. So here for all obliterations.
Second approach is, Satish, some people do middle cranial fossa approach implant.
Yes, that is one approach divided by quality. He devised that approach of middle fossa. We did in cadaver several times, though we didn't in live because of the other approach we have with advantages, that is subtotal petrojectomy. I would love to do middle fossa approach otherwise.
This is theoretical. People should know what are the other approaches for that. You know?
Yes, but middle fossa, that's why it's not popular, because subtotal petrojectomy is all advantages beyond that. It treats the primary pathology also, CSOM. Now, see now, I am drilling away all the way and see anteriorly the carotid. Sometimes this partition with the carotid is dehiscent. See this? Sometimes this partition is dehiscent, and there are reports even when this partition is dehiscent and people have implanted into the carotid canal. So we have to be careful, we have to be good at understanding the radiology. Elevator. We have to be good at understanding the radiology to know this fact, that what kind of anatomical abnormality is there. See, my implant is going there below this lamella. Can you see this?
Yes.
Let me remove this osseous spiral lamella all the way. Let me remove this. See, my implant is lying in the inferior part of the cavity. Can you see?
Yeah, very clear, very clear, very clear.
This is the carotid canal here. This is the cochlea. Sometimes this thickness is even less than a millimeter. Sometimes it is dehiscent. Now, see, everywhere. Guru.
Paramita, good questions are there. Any questions?
Yes, yes, please.
Paramita.
Sir, you can hear me?
Yeah, we can hear you.
Yes, please.
Okay, so there was some problem, sir, with the voice. We couldn't hear. I couldn't hear you, and you couldn't
No, no,
hear me.
we could hear you.
But Rajiv, Kapila wants to know that generally cochlear implants
That question is
stimulate
done.
fibers in the spiral lamina.
Pardon?
So how do electrode directly stimulate fibers in modulus from the apical turn? Like how it will be?
Can you repeat? Can you repeat, please?
That is Rajiv Kapila's question.
Yeah, what? Paramita, can you repeat?
Yeah. So generally, cochlear implant stimulates fibers in the spiral lamina. So how will electrode directly stimulate fibers in the modulus?
In the modulus? If your implant goes in the scala tympani, that is closest to the wall of the spiral ganglion population, that is spiral canal of Rosenthal, which lies in the outer wall of the modulus. And that is how that is closest to stimulate. That's why we want to put our implant, push our implant in the scala tympani. Now I tell you one thing. Earlier, at times, a perimodular implant became very popular. It was so impressive to put your implant close to the modulus all around. It was so appealing. Then what happened? They gone to disrepute. For the reason, those implants were very stiff because of the stylet inside. And that stylet, when you start withdrawing, you need to be very experienced to withdraw at the right time, just before 180 degree of the insertion, so that it turns. And this is quite big, quite tough. The content of the iridium content of the perimodular implant is highest. You know, you go to the making of the implant, what do the implants contain? How many wires, how many iridium, how many Teflon, how many? The iridium implant of those implants, iridium content was biggest, made them very, very tough implants. So once you implant, they become in a position of the modulus tightly, and many of those implants had result in leaking of the CSF through the modulus because of close opposition to the modulus where the spiral ganglion population is. And secondly, more than that, once you start removing the implant, in case you need to explant, it will traumatize anything rather than removing the other implant. So, you need to put in the scala tympani because you are closest to the spiral ganglion population, number one. Even if you are using a lateral wall electrode stimulating the organ of corti, it works very well. More than that, coming to the ideal one in the present situation, I would prefer to use the mid-scala electrode. And I love this advanced bionic mid-scala for that matter.
Okay, sir. Okay.
To me, that is the single best electrode in the present conditions. And that is a preference may be different for different people. See now, I am drilling all the way and see the cavities. Can you see the spiral lamella?
Yeah, very clear.
See now the spiral lamella all the way.
Yes, sir.
My implant is deep to it. See this in the lower part. And this is the osseous spiral lamella in the upper part. Can you see this?
Yeah, very clear.
Upper cavity, very clear. And my implant is lying in the lower cavity. Just for this, I can give you magnification for this point of time. See this. This is the lower compartment. Can you see? Let me remove this. Can you see the lower compartment separately?
Yeah, very clear.
And this is the upper compartment, and this is the osseous spiral lamella. And at the periphery here, close to the outer wall, this is your scala media. This one. A very, very small tunnel, that is scala media. So now this is 180 degree here. See now how the scala has gone so deep. The cochlea is oriented anterosuperiorly, and as you go down further, it goes more and more deeper. So now the scala has gone so deep. Now this will ascend, again ascend like this and come into the second turn. Now what does it mean? Why I am telling you this ascends highest? Anywhere in the CT scan, if you see in the axial sections, from above downwards, when the first picture of the cochlea appears, from above downwards, it is basal turn.
Yes.
From superiorly.
Yes.
And till the end, inferiorly, the last picture is basal turn. Because basal turn is the biggest of all turns, going all around, and the rest of the turn I will show there are in the lap of the basal turn. So this configuration of scala tympani below, scala vestibuli above, and between lateral scala vestibuli, that is maintained in all the way in all three turns. Why this drilling is required some time? Mostly for few indications, let me tell you at this point of time. Mostly in post-meningitis cochlear obliterans, particularly post-pneumococcal infection, the cochlea gets obliterated and you need to do a drill out. Most of the time it starts at the basal turn because the communication of the cochlear aqueduct is supposed to transmit infection at the basal turn. And in that situation, you can drill out the basal turn only and your implant can go rest of the turn normal. If the basal turn is completely blocked, what you can do, now you understand the anatomy, where the scala vestibuli starts from the vestibular floor. If the basal turn is fully obliterated, what you can do a drill out, open up the vestibule and go from the vestibule in the scala vestibuli and put an implant in the scala vestibuli. At least it will give reasonably good hearing. If the complete basal turn is gone now, and the middle turn is patent, there are a lot of spinal ganglion population still exists in the middle turn, you can do a separate middle turn cochleostomy. Sometime, different compartments, some electrodes, you can put 2 or 3 electrodes arrays. The divided electrode arrays you can use. So, we need to understand the anatomy of the other turns as well. So now, this basal turn is so deep and going to come, and here it will become a second turn. So where exactly it becomes the second turn? Show you this. You know, we have removed the processus cochleariformis here. Processus cochleariformis is a good landmark. So the middle turn, see, another landmark I have is, see this spherical recess in the vestibule?
Yeah.
And this was covered by the oval window above, the stapes above. This was the processus cochleariformis here. 1 to 1.5 millimeter below the processus cochleariformis.
Centralized, please, Satish.
Okay, and 1 millimeter anterior to the foot plate. Roughly, if I drill this, I will be coming to the descending basal turn and the rising second turn here. And still I can catch the second turn and put my implant. So, again for this exposure, your posterior tympanotomy is not enough. Best to do a subtotal petrosectomy. Now, let me follow this what I have said. I will follow this basal turn also going up and there, but let me show you what I said here. Where is the second turn here?
Sir, Dr. Rajeev Kapila says that good cortical mastorectomy with incus removal with cartilage tympanoplasty, can we do this instead of subtotal petrosectomy in selected cases?
You can do, but why want to invite problems with a narrow access? Why you want to get away from a proper approach? Once you have an ideal solution, you can do anything, no issues.
So Dr. Neha Shakrawal from Jodhpur says that why did lateral wall implants come into existence then, if it is of...
What is?
The lateral wall hugging implants. What is the role then? What is, why is there existence?
For IP2 single
cavity. 1 minute, there is a lot of noise here. Can you repeat, Paramita? Sorry.
Yes, sir. So I'm saying that Dr. Neha from Jodhpur is asking why is the lateral wall hugging implants have come into existence then, if it is of...
Yeah, it's good. Lateral wall electrodes are good. In turn, they are away from the modulus. Okay, no problem. But they stimulate the organ of corti. They are close to it. There's no issues. If they're properly inserted, even the lateral array implant, they work very well. No issues.
Boss, like any congenital anomaly in which you prefer lateral wall hugging implants?
Yes, there are many anomalies. The reason is in those situations, like common cavity, if you are doing,
yes,
the neural population is at the periphery.
Yes,
I'll send you a video of a common cavity we did. We used the endoscope, the same thing.
Okay.
Made 2 openings, one to push the implant, and through that the endoscope also.
Yeah.
And through other opening to the micro forceps, we brought the implant out.
Okay.
So now you got a U-turn of the implant that by means of a hook you can push to the periphery.
Okay.
So the implant will not go in the internal auditory meatus, because that is a big problem in the common cavity, which is directly there in communication with the internal auditory meatus. So in those situations, you need to push your implant to the periphery. IP1 also, the neural population is at the periphery. There is no internal architecture of the cochlea in the center. So you need to push the implant in the periphery where the neural population is.
And boss, Dr. Kirtane sir has also given one method about that. He makes a semilunar opening about that.
Yes.
Which is,
I heard from him.
Curved electrode tip inside.
Yes, he is master. He can do anything. We all learn through him. Yeah. So now, can you see this? Can you see this opening in the second turn here? We can see. Let me communicate first for your orientation.
So what if the bone between the cochlea and the carotid canal is absent?
What if the bone is between the cochlea and the carotid canal is absent? First of all, it comes in the category of third window phenomena. Because your sound from the inner ear is leaking through a defect in the vestibular wall, in the cochlear wall or labyrinthine wall, you can say. But when you are doing implant, you have to be ultra careful that not pushing the implant in the carotid canal. So first of all, if you do a proper inferior extension of the round window and a straight shot insertion with the inferior placement of the implant, still you can go along the lumen of the scala. And if you want to stay more careful, you can take the help of fluoroscopy. That will tell you live where implant is going in the scala or somewhere else.
Okay.
Now, see the second turn of the implant. See, in the center is the modulus. And now I will show you the ascending or the descending basal turn which is coming and forming the second turn. See, this basal turn is going up and coming like this. This is second turn we already opened. So how it has come? Let me show you. And the landmark here is for the apical turn and the descending basal turn is this part of the GSPN. You see what nerve I am elevating this. Can you see this?
Centralized, please.
Yeah. You remember earlier we cut this GSPN?
Yes.
See this GSPN?
Yes, yes.
Can you see this?
Yeah.
Yes,
I am going deep to the GSPN.
Yes, sir.
To show you the relationship.
Yes, sir. Sir, Dr. Chandrasekhar Tengli from Gulbarga and many other surgeons are writing that let sir know how we are feeling. We are feeling amazing right now that we are watching a lifetime demonstration with sir. And they all are very thankful.
I am thankful for their involvement. Everybody is so involved, so keen. I am amazed with the involvement. Now, here one more thing I would like to mention at this point of time. See this. I left the stump of the nerve over here. That was GSPN under which I am drilling this so that I can show the descending basal turn and the apical turn there. And number two, this nerve here which I cut was the labyrinthine portion of the facial nerve. Remember?
Yes, sir.
This descending basal turn is in close proximity to this is the labyrinthine portion of the facial nerve. Yes. This descending basal turn which is coming like here, this is second turn, is in closest proximity to the labyrinthine portion of the facial nerve. And sometimes this is the cause of problems, The reason is, if this wall between the descending basal turn and the labyrinthine portion of the facial nerve is dehiscent, if your implant passes through the lumen, the current may stimulate the facial nerve, And that facial stimulation is such a bothersome problem. That is the most, I would say, nuisance for a patient who is implanted. And in that situation, there are many ways to deal with that. That happens mostly with the otosclerosis patients, without even having dehiscence. If there is a dissection, you can get to know from the previous CT scan. But what happens when you implant in the otosclerotic patients? Otosclerotic patient, the bone becomes more conducive because the bone becomes more hypotense. So current leaks through the hypotense bone, and there are possibility of many kind of stimulation. So in otosclerotic patients where the bone has gone hypotense, the current is leaking, and the close proximity of this labyrinthine portion of the facial nerve can lead to facial stimulation very easily. And in a chunk of population of otosclerotic patients who are implanted, the facial stimulation is a big problem. And not only this, the entire labyrinthine capsule becomes hypodense in the otosclerotic patients. So other stimulation also can happen. Even the stimulation of the Jacobson nerve is reported giving pain in the ear in otosclerotic patients because the current is leaking. Even the stimulation of the vestibular system is reported because the current is leaking and giving vestibular stimulation by means of stimulating the vestibular end organ. So in that situation, the first way is to reprogramming. If doesn't work, shut off those electrodes close to the facial nerve. If still there are stimulation, then you have to explant. There is no way. Because that is the most troublesome, one of the most troublesome issues. So this is to understand that this is the descending basal turn.
Hello, Satish, just a question there.
Yes, please.
Now you say the patient gets a pain.
Yes.
That's why you want to take away the implant?
Yes, many a times.
Okay, why don't they do a neurectomy and get rid of the pain rather than take away the implant?
That is one of the options before doing that. That's why I told you there are many.
What is more important? Hearing is more important to me.
And tympanic neurectomy is one of the options in patients who experience this kind of pain. Not only after implantation, but many other regions. So that is the option taken before explanting. I am talking about otosclerotic facial stimulation in that situation.
I can't hear you.
In facial stimulation, even after shutting off those electrodes, it doesn't work, you may have to explant it. This is for otosclerosis. I am talking about the facial stimulation. So, I am drilling this descending basal portion and show you the close proximity to the labyrinthine segment of the facial nerve.
So Dr. Rajeev Kapila is again asking, when we drill out, what are the chances of putting electrodes in scala vestibule?
Yeah, when you are drilling out under vision, everything will be in front of you. You can place electrode wherever you want to. Number one, in drill out situation, what is the indication for drill out? Some obliteration. Once obliteration is the indication for drill out, wherever you get lumen, you have to push it, whether it is scala vestibuli or tympani. Then it is not the priority. The lumen is the priority to get the lumen. In unfortunate situation, in many of the ossification patients, you don't get any lumen, and ultimately you have to come out without putting anything, and those are the candidates for ABI. Left with ABI by default, there is no other option. So once you get the lumen, that is the priority. See, now I am just drilling out this outer wall here to complete the circumferential exposure of all turns.
Can you insert the cochlear implant and show us?
Yeah, I inserted earlier, but for the sake of demonstration, now let me show you something. See the middle turn properly.
Yeah, very clear.
See the middle turn properly. I will show you now. Yes. See now, this was the basal turn. Lower down.
Yeah.
It was coming like here as the second turn. In the center is the modulus here.
Yeah.
And now this is going in the second turn up there here. To go to the apical turn here. That is the apical turn. See the basal turn, middle turn and the apical turn. Now let me push the implant. Give me the implant. This is what Paramita is asking.
Yes.
Now coming to the Rajeev Kapila's question, how far do I implant? Let me load the implant. I am loading it first into the this.
So Dr. Vidyasagar from Vijayawada is just asking you to point the footplate area once again before you.
Sure, dear. Sure. I will show you the spherical recess. And then I got the call from Dr. Ashish Bhumkar also about the stapes area, promontory where you can drill to piston and all that. I am going to tell you.
Dr. Prakash Mukha is asking for 360-degree insertion, how much should be length of the electrode, ideal length of the electrode?
See now, I am pushing the implant there. See now, implant is coming there. Can you see?
Yeah, centralize please, centralize.
Can you see here?
Yes, boss.
Now, beautiful.
And push it in the apical turn.
Can you see where the implant is coming from?
Yeah, middle turn.
Middle turn. See this. I injected the implant in the basal turn. It has come out here.
Centrifocus. Yeah.
Yes. Yeah. See, I inserted the implant here in the basal turn.
Yes.
And it has come out of the basal turn here. This is the descending basal turn. See this? That is the facial nerve here. That is the labyrinthine facial nerve. And now from here onwards it becomes the second turn. Okay?
Yes, sir.
Now let me withdraw it little bit. See this? See this?
Beautiful, beautiful.
Now let me push it into the, do the forceps. Push it into the ascending basal turn, ascending second turn. Now if I push my implant here, because I have to do it manually because now I have opened the basal turn now.
Yes, sir.
It cannot go automatically. Push करने का दे.
So Satish, for your, so what is the ideal length of the electrode should be for 360-degree insertion, as Dr. Prakash Mukha is asking?
Not more than 24 millimeter. I use AB ideally because it is not beyond 22. And I told you initially, the first 4 millimeter around the, close to the round window are useless.
Yeah.
Don't count that. See now, I am pushing it towards the apical turn. Can you see now?
Yes.
Yeah.
Because I have to do it manually, I have opened the basal turn walls. So it cannot go on its own.
Yes. But the concept is well clear there, how it is going. Satish boss, I think later on you can also show the direction of implantation, because the way people implant, sometimes they are going inferiorly, superiorly, anteriorly. What should be the angle, something like that, so that prevent the injury inside.
Yes. See now, my implant I am pushing, see where it is going to the basal turn up? Can you see automatically?
Yeah.
And this is now the ascending basal turn from where it is going to go in the apical turn.
Yeah.
An apical turn being so narrow to accommodate this implant. See now it has come out through the apical turn?
Yeah.
See this, it is coming out through the apical turn.
Yes, sir.
See this is coming out up.
Yes, sir.
Beautiful, beautiful.
Yes,
here through the apical turn. Here.
Yes. Yes, sir.
Here through. But we are not supposed to. I tell you the reason now. This is the time to show you how this modulus is. अरे बहुत सीधा आना. इस माइक्रोस्कोप सीधा करना. ओए वीरू, सोए मत. ओए सो गया.
Satish.
सो सही करना. हाँ, हाँ boss.
Today's the record is broken now. Right now there are more than 6,000 people around.
Oh really? So crazy.
At present.
Oh great.
A lot of people will curse me for spoiling their Sunday.
Yeah, their Sunday.
Are you spoiling them by making them utilize their Sunday?
And
people
right
who think
now,
they are spoiling, they should not be around anyway.
Dr. Madhuri Mehta has also joined us, and she
great.
is watching since starting.
Hello, madam.
अरे माधुरी, ए माधुरी, सतीश जन ने आगे बोला कि ट्रांसडायगोमेट्रिक approach is described by you, not by me.
My God.
गाली दे सतीश को, तेरा वीडियो देखा कुछ बोला, of course your videos are much beautiful, you do much more cases now, more than me. But Satish, for your information, transdiagrammatic approach was designed by me in 1991.
She explained me, she gave me the video.
Yeah, she
and more than that, you have grown older, forget about it.
So, she has much more work than me these days, you know.
Now what I want to say here, for everyone we were talking about the modulus so far. Can you see the modulus in the center? See this grayish bone, this is modulus. Can you see this?
Yeah, very clear.
See, all my implant is wrapping around the modulus all the way. This is the modulus in the center. Now, the spiral ganglion fibers from the periphery through the spiral lamella, they come horizontally from the basal turn, obliquely from the middle turn, and they come steep from the upper turn like this. So all these steep fibers coming from the upper turn are well stimulated by the implant in the middle turn. You don't need to go to the apical turn and stimulate and try to damage whatever the residual hearing is. That is the bottom line. So, for the Kapila who was asking how much to penetrate, see, I have gone beyond 500 degrees here. My 360 stops here. See my implant here? See my implant here? This is 450 degree to cover each and every aspect of the spiral ganglion population. So I will never go beyond 450. That is the last limit. That will cover the spiral ganglion. Spiral ganglion is something not extending to the 35 millimeter length. A spiral ganglion is 15 millimeter in length only. That's it. That starts from 4 mm for us to stimulate 4 mm from round window to 15 millimeter further. There is no point in inserting implant beyond that. There is no spiral ganglion population. Rather, you are trying to push in the narrow scala to damage. Now, at this point, now I am removing the implant. See this?
Yeah, beautiful.
Now I am removing this entire scalar septa to see how this implant in the modulus, how this nerve endings in the modulus are forming the cochlear nerve. Because these 35,000, almost 35,000 in the modulus, they take a spiral turn and pass medially through a cribriform plate, like cribriform plate in the roof of the nose, to pass through in the intra-auditory meatus, and that is known as a cochlear aperture. We always mention in radiology to see the cochlear aperture, the dimension of the cochlear aperture. If the cochlear aperture is narrow, means there could be hypoplastic cochlear nerve. If cochlear aperture is bigger, that means there could be abnormal communication with the intra-auditory canal. Let us see directly now what is cochlear aperture. Give me the drill. So now I am uncovering the cochlear aperture here. So today's dissection, we are not going anywhere to the skull base. That will cover later on some in other dissection. This was to understand the basics of the middle ear and the cochlear implant. See, I am removing these scalar participations. These are partitions to uncover the modulus from all around. See now. See this. See the modulus in the middle?
Yes, boss. It is seen, well seen.
This is modulus. This porous bone is modulus. This is a very thin bone, and there are certain malformations where the modulus is deficient. That is IP3. Yeah. IP3 is X-linked syndrome, wherein the modulus is deficient and there is a direct communication from the intra-auditory meatus to the inner ear. Lot of people link, we have seen the vestibular aqueduct as a cause of gusher. Lot of people link the cochlear aqueduct as a cause of gusher. Believe me, till date, not a single case of cochlear aqueduct enlargement in cochlear implantation resulted in gusher. This is all theoretical. Not a single case reported, and the most extensively, this subject is studied and analyzed none other by Robert Jackler from Stanford. He's a good friend of Ashish Bhumkar. We had a discussion. Not a single patient so far in the world put a large cochlear aqueduct, reported as a gusher during cochlear implantation. This is all theoretical. So it is always the abnormal communication of the intra-auditory meatus to the inner ear which results in gusher. Simple. No need to go into all those myths. See now.
Yeah.
See, this is the basal tongue. This was coming up from here. Now it is clear.
Centralize, please centralize, Satish. Very.
Now it is clear now.
Yeah.
See this. See, this is the central modulus.
Yes.
I am removing part of it. See now. I am removing the part of the second turn as well. Partition. See this now.
Yeah.
Very clearly.
Just to completely drill out to finish it off. Now, अब मेरे को implant दे वापस. Give me the implant again. If you want, I can show. See this, if I put my implant from here where this probe is going, it will come out of here. Can you see?
Yeah.
And then in the second turn, if I push here, it will come out from here. Can you see the second turn?
Yes.
Hello? And a small apical turn over there. So all these turns are around this central core. This is modulus. Is modulus clear to everyone?
Perfect.
This is around 4 to 5 millimeter in length, broader at the basal turn and more smaller towards the apical turn. And this is not a very thick bone, it is porous bone. And this is deficient in IP3, and where the chances of gusher are almost always there. So now, I will uncover this modulus from the base and see how the cochlear nerve forms.
Hello.
Yes, madam.
Hello, Satish. How are you?
Oh, good to see you.
You are doing wonderful job. Good. And sir is also there. Hello, sir.
Sir is here.
I'm having my lunch.
Oh, you are. So Satish को कोई lunch दिया क्या किसी ने?
सतीश को खाने की क्या जरूरत है?
उसको खाने की जीवन में तो जरूरत नहीं है सर, है ना?
हाँ, उसका डिसेक्शन उसका खाना है, उसका ऑपरेशन उसका खाना है.
Yes, Satish.
Yes,
hello.
Madam.
Satish, we miss coming over to your place.
Give me a smaller one.
Satish, lockdown खत्म करवाओ जल्दी.
So, Satish, you are going to insert the electrode now. Again, just show us.
See now the beginning of the cochlear nerve for everyone. Cochlear nerve is much wider than other cranial nerves. Can you see the beginning of the intra-auditory canal?
Yes.
Yeah.
Very clear or not?
Yes. Very clear.
This is the fundus of the intra-auditory canal, the lateral end.
Yes.
See that?
Yes.
Very clear, Pavan?
No, sir.
Yeah, very clear.
See this nerve. What was this nerve we kept from the beginning? The labyrinthine portion of the facial nerve. See that?
Yeah, very.
And see, if I elevate this in the intra-auditory meatus, this is facial nerve.
Yes.
Can you see very clear?
Clear.
Facial nerve and the superior vestibular nerve. Very clear.
Yeah.
Very clear?
Yeah, very clear.
Just for information.
This is inferior vestibular nerve here. Behind the cochlear nerve, this is inferior vestibular nerve.
Yes.
Okay?
Yes.
And this is cochlear nerve. And see the base of the modulus. This is modulus.
Yes.
Yeah.
From here, these fibers turn like a spiral. And see this bone which I am removing in the pick. See this bone.
Yes.
Yeah.
This is cribriform area. See this. See this. And all these fibers of the inner hair cell, all these are 35,000 fibers passing from each and every inner hair cell through the osseous spiral lamella, then through the cell bodies of the ganglion in the canal of Rosenthal, and then in the cavity of the modulus, and then they are passing through this spiral canal of, through this porous bone here, the cribriform area, and now forming the white cochlear nerve. See this?
Beautiful.
Can you see the nerve fibers?
Very
How
clear.
the cochlear nerve is formed.
Satish,
Yes, sir.
just for information, now people are talking about transcanal endoscopic approach for removal of small tumor of the internal auditory meatus, acoustic neuroma. What you showed just now.
Yes.
You can do this transcanal with the endoscope. These people are talking about it.
There are a lot of reports
Yeah.
There are a lot of reports. Even I went through the Precious articles. Precious was the one who described this extensively on the cadavers and in live surgery. And he has been considered as one of the pioneers in endoscopic ear surgery and then now endoscopic skull base surgery, lateral skull base. And he demonstrated the endoscopic schwannoma excision from the lateral part of the intra-aortic canal, endoscopic. But see, what ultimately you are gaining. First of all, it sacrifices the hearing. If hearing is gone, then why not translab? Number one. Because you are...
Just information. Just information.
Yeah, I know.
Yeah.
But that is something... I am not criticizing him. I am not criticizing. He is a wonderful endoscopic lateral skull base surgeon. And I am learning a lot through his publication. It's amazing. But the thing is, that is not a standard of care. That is not going to be widely accepted as a standard protocol. Because the advantage what you get with the translab once the hearing is gone, no other approach can give you. And in one of the next webinar, probably next week, we'll keep a case of translabyrinthine acoustic neuroma excision. We'll discuss all the advantages and disadvantages. Now see the cochlea now how it forms. So the whole game of this implant was to see this go through all the turns, go around the modulus to stimulate the spiral ganglion cell population to transmit those electrical signals through the nerve. Is that clear?
Yeah.
And that is the basic prerequisite for a cochlear implant. The minimal functioning unit to make the patient indication for a cochlear implant is a fluid-filled cochlea through which you can pass the implant and an intact cochlear nerve. That is the basic functioning unit required for cochlear implantation. Whatsoever the other anatomy or pathology, it doesn't make any difference for that matter. The basic functioning unit required is a fluid-filled cochlea and an intact cochlear nerve. Now, if the cochlear nerve is hyperplastic, aplastic, there are so many indications that the implant doesn't work and you have to think of other options like ABI or other. That is beyond the scope of discussion here. We'll discuss during implant. But this is about the anatomy for the cochlear implant. Every cochlear implant surgeon, I believe, should understand this fact to optimize the result. People considering implant that I have done 10 implants, knowing that posterior tympanotomy and just open the round window and push the implant, believe me, it's a joke. It's not implantation. You cannot optimize the result without understanding the three-dimensional anatomy of the cochlea, the implication of this anatomy, the advantages and disadvantages and the various approaches one can use in difficult situations. Now coming to Dr. Vidyasagar's question. Paramita, we can take all questions. We can take all questions, no issues. About the Vidyasagar, I was asking about the this thing, the oval window. Oval window was here. This spherical area was belonging to the saccule. We removed the neuroepithelium and see in the depth here. See in the depth here is the intra-aortic meatus. So, in the vestibule, if you pass a probe through the saccule, it will go straight in the intra-aortic meatus. That's such a straight relationship in the depth. You pass a probe through the saccule and it will go in the intra-aortic meatus. Another was a question very important. We'll discuss later, although in detail in our Stapes event with Dr. Ashim Desai and Ashish Bhumkar. Pardon?
There's a question from UAE. Dr. Sangeet Poddar is asking, please orient and explain the slant of the modulus. What angle to the horizontal?
Convey my regards to him. Poddar sir. I remove the modulus from here. See this. The entire dimension, entire architecture of the cochlea, the way it points, the same is the modulus. It points anteriorly, superiorly and laterally. So is the cochlea and so is the modulus. Anteriorly, superiorly and laterally from basal to apical turn.
Boss, Satish boss.
Yes, dear.
Can I just show 2 minutes my model? I made a clay model of cochlea for 3D orientation.
For?
3D orientation.
Ah, yeah, sure, dear. That will be
I've
useful.
just shared it for my daughters. Yeah,
Yes.
this is something like a cochlea there.
Sure.
And this would be your facial nerve. Okay. So the cochlea is like, these are, can you make out the openings down there? You are seeing the right.
Dinesh, just a minute. Dinesh, can you make his window bigger?
Yeah.
Dinesh, can you make his window bigger?
One single window bigger.
Yes, he's showing something.
In fact, it was bigger just now. I don't know. Pawan single का window बड़ा करो बेटा.
Yes. Now. Yes, dear.
They're not made it.
Yeah,
They're not made it bigger.
Is it? Yeah.
Now.
I just wanted to show you like the cochlea. If you are seeing the right here, this is how the cochlea is oriented, you know, like this. Okay.
Yes.
So this is your round window. That is your oval window sitting. So when you talk about, sir, Satish boss told a very important point which people don't understand, that this basal turn, it goes superior till here. That's why when you come on axial sections, the basal turn comes first. Okay. So if you take facial nerve into consideration, the facial nerve would be somewhere like this. Okay. And the interlocular canal would be coming deep to it over here. So that this genu would be coming and it will be going like this. And the nerve fibers he was talking about the modulus, he was such a good way he has shown us that this is how the modulus, it gives this cochlear nerve. And this is the direction where cochlea is situated. So when you make out, you drill the second turn in front of this oval window, and you drill the apical turn just below the processus cochlear entry to that, and it is pointed by the Jacobson's nerve up there. This is how it is like.
That's good. What you can add on to it, give it to some engineer to show the inside as well. They can do 3D from inside as well. It can open up and show the inside as well. There are a lot of people do it.
We'll do that.
Yeah, it can be done.
Yes,
so, Paramita, questions?
Yes, sir. Someone, Dr. S.P. Pukan from Guwahati wants to know the concept of pyramid, fundus and porous. Can you just explain again?
Pyramid? What?
Hello?
What? Can you repeat?
So the concept of fundus and porous.
Fundus and porous?
Must talk about internal matters.
Okay, fundus is what and porous is what? This is intra-auditory meatus. See this? This straight going medially. At the brainstem level, the medial end, where these nerves ascend in the canal, where the canal starts, that end is known as the porous. And where it ends at the medial aspect of the inner ear is the fundus. At fundus, there are 6 nerves you can see. 4 you see by and large. The 5th is the facial nerve, which is the nervous intermedius, which is incorporated in this. And the 6th is the inferior vestibular, divides into 2 parts. That is the saccular nerve, which is the continuation of the inferior vestibular, and the nerve to the posterior canal, that is left early 2 millimeter below the fundus. So 6 nerves at the fundus, and at the porous where these nerves enter, where are only 1 or 2 nerves, because all these nerves are fused at the level of the porous. And in the intra-auditory meatus, they differentiate into various nerves. Secondly, the orientation of these nerves from porous to fundus changes by almost 90 degrees. The cochlear nerve, what you see, and the vestibular nerve, what you see, they change from the fundus to porous. And what we observe in the vestibular nerectomy, the superior nerve is the vestibular nerve by and large, and the cochlear nerve goes down. So this is a different anatomy of the nerves by means of rotation in the canal. but porous and fundus, porous medial end, fundus lateral end.
Okay, sir. So Dr. Nageshwarao from Vizag wants to know what is retrograde insertion of implants.
What is? Retrograde?
Yeah.
What insertion?
Retrograde.
या चुप रहना यार, बोलो दोबारा क्या है?
Retrograde insertion.
Retrograde insertion when you pass from the apical to basal turn. And it was initially described in the middle cranial fossa approach, because in that, just underneath the GSPN, the first turn of the cochlea you encounter is the apical turn. And in that situation, when you insert it is retrograde insertion, and the entire programming of the implant post-op is retrograde. Well, all those electrodes which are supposed to be in the basal are now in the apical turn. But here in the regular implantation, we don't do retrograde insertion.
Okay. So there's a question from Indonesia. Dr. Anton wants to know that where is the location access to go to the CP angle tumor or the vestibular sonoma from labyrinth?
What is the voice is not clear?
No. See, he's asking you translab approach in short.
Translab approach, actually.
Yeah, in short, he's asking
see, I told you today this was the basic dissection.
Well,
And in the further webinar, I'll give you an outline.
Yeah.
We will show one by one all approaches for the audience. Like, for example, we will show translabyrinthine approach. We'll show infratemporal fossa approach, A, B, C, D. And I told you when Thursday most likely we'll keep a case of glomus jugulare of the infratemporal fossa approach. I can give you a small outline by drilling the jugular foramen right now. Then we will be showing the middle fossa approach in a separate webinar along with the transcochlear approaches. I told you which are the biggest exposure we get to the lateral skull base by means of transcochlear approaches. So like cutting drill. Like Pawan asked in the beginning, or Movani sir asked about drilling for the jugular foramen. So what I can do here quickly, because we have a case for Thursday, so I'll give you an outline.
No, show them infracochlear approach to petrous apex.
Okay,
infracochlear.
Infracochlear approach. Okay,
yeah,
I will show. See now, infracochlear is now very obvious. We have seen the cochlea, complete drill out of the cochlea. This is cochlea. Now what is below the cochlea? You have to uncover two important structures.
Microscope agile.
Centralize, please centralize.
There are two important structures below in the hypotympanic area. Anteriorly, the carotid artery. Let me show you the carotid. I have already seen the carotid here anteriorly. See, this is carotid artery.
Yeah.
And posteriorly, here is the jugular bulb.
Hello.
This is the area of the jugular bulb. Now you can see it is coming in the picture.
Yes.
Now these cells, see this group of cells in between the jugular bulb, below and behind the carotid artery anteriorly and superiorly this cochlea, this infracochlear recess, if I follow these air cells, that will lead to petrous apex. So that is the infracochlear axis, and one can do in a favorable anatomy even transcanal under local anesthesia.
Satish, I had done about 15 years back in your place.
Yeah, I remember you did in Jaipur.
Patient came at 5:30 and 7:30 we operated under local anesthesia.
Yes, exactly. See, now my trajectory where it is going to petrous apex. See this, sir?
Yeah.
That is the infracochlear access to the petrous apex. Now, where I am going? I am going deep to carotid artery.
Yeah.
I am going to the cells of the petrous apex, deep to the carotid. Now see, this is carotid artery above, and I have reached the petrous apex. See this. Can you see the petrous apex?
Yes.
That is the marrow of the petrous apex. I could identify the marrow. See this marrow bone?
Yes, sir.
That is the marrow bone of the petrous apex.
In practice, you are going to use a diamond burr in that area, not a cutting burr.
Yeah, not the cutting burr in the live situation. That is the final limit of the petrous apex. You can see the depth where you can go to the petrous apex.
And you do this
subtotal petrosectomy.
That patient had come with such a severe headache. headache. You remember? Next day morning, she ran away from your hospital because she had no headache.
Yes. So that is very rewarding approach. The same thing, this is infracochlear. And I've been following it from the infralabyrinthine. The infralabyrinthine approach is go from behind the labyrinth, below the labyrinth, through the retrofacial route, and then follow the infracochlear route to the petrous apex. So this is infralabyrinthine route, that is infracochlear route to the petrous apex, and another is supralabyrinthine cells and the route to the petrous apex. So there are various cell tracts. In the subtotal petrosectomy approach, like we have a case probably on Thursday, in subtotal petrosectomy, it is imperative to drill away, excentrate all cell tracts in the temporal bone to prevent future mucocele mucositis infection. And that is the bottom line of subtotal petrosectomy. You have to sometimes drill for hours and hours to excentrate each and every cellular possible cell to prevent future problem, and then you get a sterile cavity wherein you can implant and obliterate and do a cul-de-sac closure, close the use-taken tube, you block off all connections from outside and give a sterile zone in which the implant is lying to prevent future possibility of any infection.
On Thursday, we will try to cover basic surgeries also. We will show that how to take the graft, etc.
Yeah, we'll do later, boss. We will take later that also. We'll take all.
That you can show while live surgery, na graft होगा live surgery में दिखा दो ना.
Yeah. We'll show all approaches in live surgery also. All this transcochlear, middle fossa, infratemporal fossa, translabyrinthine, all approaches will show in live surgery as well.
टिम्पेनोप्लास्टी सीखा, मास्टर्ड सीखा, फिर जो सिखाना है सीखा.
वो आती है सबको सर.
हाँ सबको आती है. इसीलिए तेरे को what is the percentage of recurrence?
We'll keep that also, sir. We'll keep that also.
See, if you ask more than 50% people want to see basic surgeries also.
Yes, we'll definitely give. That always we should keep the basic cases.
The 50% of cases they do is the second or third or fourth surgery of colostoma.
Now see what we were discussing about the facial nerve transposition in jugular foramen lesions. See this. Can you see the jugular bulb below the facial nerve?
Yeah, very clear.
Now if I am suppose removing or intend to remove the tumor from the jugular bulb with the facial nerve going above it, it cannot allow particularly a vascular tumor. I'll either end up giving some damage inside, carotid or anything, or I will end up injuring the facial nerve. So best is transpose this facial nerve from here, get this facial nerve away from this region, and now the jugular bulb is in front of you. So now what I can do, give me a knife, remove the facial nerve here quickly, and let me give you an overview of the infratemporal fossa approach, which probably we are doing on Thursday. See this. Now see the continuation of the sigmoid sinus and how it forms the jugular bulb. There are various bones involved in it, where it passes through. See, this is the sigmoid sinus.
Yeah.
I am following it to the depth. See, this is sigmoid sinus which I have opened here. Just to show you. This is sigmoid sinus. Can you see?
Yeah, very clearly.
Now I am passing through, and this is the part of the occipital bone. See this marrow bone behind?
Yes, sir.
This is jugular foramen. This marrow bone is what? The jugular process of the occipital bone.
Okay.
And then, if I follow this, see this sinus, let me open up the jugular bulb here. That is the interior of the jugular bulb. You see there.
Yes, sir.
See how big a cavity it is. Can you see?
And you will see a multiple opening on the medial aspect of inferior petrosal sinus.
There are lots of cranial nerves running in the medial wall of the jugular bulb underneath the periosteum, 9th, 10th, 11th. There are lots of venous openings like
inferior petrosal sinus.
Inferior petrosal sinus and the condylar veins posteriorly. See this? This is the huge cavity of the, see that is the opening for the condylar vein.
Yes,
and see anteriorly, those are the opening for the inferior petrosal. Can you see there?
Yes.
See there? See there? That's a huge one.
Yeah.
And this is the jugular process of the occipital bone. And there anteriorly, 9th, 10th, 11th. And if I go through that deep depth of the jugular foramen by means of drilling this occipital condyle here. This is occipital condyle in the depth. If I go drill through the occipital condyle, I will get the 12th nerve, the hypoglossal nerve there, through the hypoglossal canal. So this is just an outline we'll do so that you can grasp in the live surgery where we are working. Paramita, questions?
Sir, indication for tympanic neurectomy?
Tympanic neurectomy. See, I told you this tympanic plexus contributes to the postganglionic fibers to the parotid. So in any given situation you want to reduce the parotid secretions, tympanic neurectomy is the answer. Like Fraze syndrome, what happens? Because of aberrant innervation of the postganglionic fibers which are open up after parotidectomy to the subdermal vessels and nerve endings. So in order to prevent that, if the conservative measure fails, you can do a tympanic neurectomy to take away the postganglionic stimulation. In neuralgia of many regions, sometimes in neuralgia you have to do a tympanic neurectomy. Yes.
Other indication is parotid fistula.
Yes. Anyway, you want to reduce the secretions of parotid. For any indication you want to reduce the parotid secretions, this is one of a efficient way. Any more question, Paramita? You have many questions.
Alok Mondal from Kolkata wants to know, in sleeve resection for external canal, what will be the anterior incision?
You're going. Can you repeat, please? Oh, bhai, idhar chup raho. Can you repeat?
Sleeve resection of the...
In sleeve resection for the external canal, what will be the anterior incision?
Anterior extension
will depend on the extent of the tumor.
Depending on the extent, I tell you, I know not only the anterior extension, I tell you the funda behind this. All these tumors of the external auditory canal, even if they are not extending to the parotid, if they are attached to the or arising from the anterior wall, I would always do a superficial parotidectomy. Not only for the continuous tumor excision into the parotid, that is not my first region. If it is continuously extending, obviously you have to do that. Not only parotidectomy, wherever it is extending. But the reason behind that is the first echelon lymph nodes of the canal are in the parotid. So in order to give a primary...
Deeper to the superficial lobe. Nodes are deeper to the superficial lobe.
Yes. Superficial parotid gland has a lot of lymph nodes which are draining the external auditory canal, and that's why the superficial parotidectomy should be an integral part of this lateral temporal resection, unless it is a very small T1 lesion. More than that, if your superficial parotidectomy, what you have done, it should be sent for frozen section. If it turns out to be positive, any of the lymph nodes in the superficial lobe is a straight away indication for a total parotidectomy, because the lymph nodes in the superficial lobe are in continuity with the deep lobe lymph nodes as well. And is the indication for the level 2-3 dissection.
Neck clearance.
Yes. So this optimal treatment for the external auditory canal malignancy, you should not ignore the superficial parotid gland. Not for the direct extension, but to involve the first echelon lymph nodes. Questions fast.
Sir, many are requesting you to show the cochlear aqueduct again.
Cochlear aqueduct? Oh, cochlear aqueduct I didn't mention, sorry. This was asked by Dr. Alpesh Sudhar also. Just to mention it, because I have drilled this completely. That's a very important anatomy. There are 2-3 anatomies I forgot to mention. One is cochlear aqueduct, another is inferior cochlear vein.
Yes.
See, when we drill the inferior edge of the round window, just close to the inferior edge of the round window in the medial wall. In the medial wall, not in the inferior wall, mind it. Inferior wall you can drill towards the hypotympanum. What we drill to straighten the access to the scala tympani. In the medial wall are certain openings very close to the round window. The first one is the opening of the lateral opening of the cochlear aqueduct. That goes deeper down and open in the posterior canal fossa close to the glossopharyngeal nerve, where it enters the jugular foramen. So like your cochlear aqueduct, It is, you can say 5 to 6 millimeter below the intra-auditory meatus, and when you open it from below, the glossopharyngeal nerve is immediately inferior to it. You can damage glossopharyngeal if you are not careful. So that is about the cochlear aqueduct. I already told this is not responsible for any gusher. For that matter, the function of the cochlear aqueduct is different. Number one, it acts as a buffer to prevent the pressure transfer of the CSF to the inner ear fluids. That is more important, the role of the cochlear aqueduct acting as a buffer. And second important role is some sort of, maintaining balance in the ionic composition of the electrolytes in the CSF and the inner ear fluid. That is supposed to be having two roles of the cochlear aqueduct, nothing to do with the gusher.
Satish boss.
Yes.
But cochlear aqueduct is connected to subarachnoid space.
Yes, but it is generally closed with a fibro-meshy tissue. In live situation, it is closed with a fibrous mesh. It is not a through and through fluid channel. But
Yeah,
that is
that's
good
why-
enough. That is good enough to conduct infection from the cerebrospinal fluid. That's why in meningitis conveys infection to the inner ear. First to the basal ton, close to the round window. Second thing, I told you it is responsible for maintaining, supposed to be, for ionic balance between the inner ear fluid and the CSF. And third is to prevent the sudden pressure excursion in the CSF to the inner ear.
That's why, boss, when you do translabyrinthine acoustic neuroma,
we drain the fluid.
You open it.
Yes,
so that
we intentionally open it.
Yeah.
We intentionally open the cochlear aqueduct to drain the CSF.
Yes.
So that your the brain relaxes.
Yes, boss.
Second anatomy, close to the cochlear aqueduct, the next to it, in a some millimeter distance from that, are certain accessory canals known as corticonous canals containing the inferior cochlear veins and its channels.
Yes.
They were initially described by the corticonous as the corticonous canals, and that inferior cochlear vein actually is responsible for draining the blood from the modulus and the spiral ganglion regions. And if this vein is damaged, it's supposed to give neural damage or had an impact on the residual hearing. So these structures to be preserved, and the best way is, once you go inside the round window, never drill on the medial wall.
Yes.
In the first millimeter from the round window, that crista, in the first millimeter is the opening of the cochlear aqueduct. So never ever do that. And the inferior cochlear vein, what we did, what I showed, is the inferior extension towards the hypotympanum to widen and straighten the access to the scala tympani of the basal ton, not the medial wall. Medial wall should never be drilled. The moment you go inside the round window, you should not use the drill on the medial wall, otherwise you will end up injuring these structures, and that has a detrimental impact.
Satish boss.
Yes.
That's why when I saw you operating with the extended round body window cochlear implantation,
yeah,
I didn't have any problem regarding my insertion of the implants then. I just saw 2 cases of yours, and I think half a century I've done with that technique.
How they are working now?
Yeah, they are all working, boss.
Because of you, it is not a sort of 2-dimensional opening, it becomes a 3-dimensional tunnel. So you can pass through a tunnel under vision that your implant is lying inferiorly in the tunnel.
Yes.
You are not
And
damaging the osseous spiral, lamellar or basilar membrane.
And you bypass the crista.
Yes. But like we mentioned in the answer of this question, inferiorly, not in the medial wall.
Yes.
The moment you drill even the first millimeter medial wall after the round window attachment, that is the injury, I would say. That is never advocated. Paramita, questions? Fast.
Dr. Anjum from Karachi wants to know what is the best method for getting dural tear. What do you do for dural tear?
Your voice is breaking. I don't know the connection or what.
Yes.
Can somebody repeat the question?
Can you hear me now? Can you hear me now?
Yes, better.
Okay. So Dr. Anjum is asking from Karachi, what is your best method to repair a dural tear?
Dural tear.
Yes.
So dural tear, like anywhere CSF leak repair you do, so you have to reinforce first with a some live tissue like fat or something to provide fibroblast, and then you reinforce with the fascia. Or what happens in a tegment defect? Dural tear is different. Tegment defects, large tegment defects are different. In large tegment defects, we use the middle fossa approach.
Mini middle canal fossa approach.
Yes.
First time it was done by me in your clinic.
Yeah, now we have a huge series now. Mini middle canal fossa approach, you remove the bone piece of the middle canal fossa approach, and then you place the bone piece from above, beyond the margins of the defect. Okay?
Yes, sir. Okay,
And
so you
this
place
is under local anesthesia also. You are doing a master surgery under local anesthesia, and there's a big tegment defect. Don't worry about it. Same under local anesthesia, you continue to remove the bone piece. Madhuri does a lot of cases these days.
Yes.
A lot of extensive cases. We don't get so many extensive cases in Bombay.
We didn't answer one suggestion from Ashish Bhumkar about, because here I have drilled the oval window completely, and his question was, his question was in stapes, in difficult oval window when you need to drill the promontory, where should we drill? I should have done this earlier, because now I have completely, there is no oval window existing, no cochlea existing, no vestibule existing. We'll show some time, and in the live case as well. So inferior margin of the oval window has a very close relationship with the cochlear duct below. So the point at which we should drill, point at which we should not drill, and how thickness, how much we can drill is important to prevent sensory hearing loss. So ideally we should drill posteriorly for a depth of up to 1 millimeter, because that will uncover the foot plate completely, and beyond that we should not go beyond 0.3 millimeter, otherwise the endolymph will come. The cochlear duct will come. And that is important not to do anteriorly in the middle part, because that is the highest dome of the cochlear duct in relation to the foot plate. I should have shown that during I was showing the cochlear duct, the ascending basal turn.
Hello?
Yes.
Madhuri, can you show them your small case? There was a video of a small case you open kiya tha. Small
questions.
Just inferior to the foot plate.
Yes, sir. 3-4 cases I have.
Romita, we have been getting so many messages and emails in the past webinars. Some of the people expressed their version that they sent lot many questions we couldn't take up. So whatever time we have, please take up fast.
Yes, sir. Tell us something more about COG. No, sir. What is the importance of COG? Many have asked about.
Your voice is breaking. Something with your internet speed or something.
He's asking about COG and its importance, boss. COG.
COG?
And its importance.
Importance of the COG. COG I had shown you when I showed the superior malleolar ligament.
Yes.
The upper attachment to the tegmen is the region where a bony projection is there, that is COG. And that is something pointing below towards the processus cochleariformis, and could be a good landmark for the facial nerve. And it practically divides the atic into anterior and posterior atic. So when you are working in the atic, it could be a good landmark for your orientation.
And more than that, you can have a disease cholestoma going under the COG. So you have to remove the COG in cases when there is an anterior extension of cholestoma. That is important.
Yes. So when you want to clear the anterior atic, you have to drill away the COG so that you don't miss the disease anterior to it.
Under it, or deeper to it.
Hello, can I ask a question, Satish?
Yes, please, madam.
Okay, if there is a congenital absence of foot plate, many cases we get in, congenital stapes fixation or foot plate absence. We keep on discussing where to make a fenestra for, doing the stapedectomy or maliovestibulopexy technique. So where do you make the fenestra in those cases where the oval window is absent?
That's a brilliant question. And I would love it that you asked it that time when I was showing I was drilling the facial fallopian canal and the semicircular canal to expose the vestibule.
Okay,
see, why I am saying so.
Okay,
why I am saying so, I will show sometime your video as well. We have a series of cases wherein the facial nerve was prolapsing down. You know, if you go to the embryology, how the foot plate forms and when it forms in the fetus, the formation of the foot plate happens to occur on both sides. One side from inside the endosteal bone comes, on other side the stapes suprastructure come. At the same time is the development of the facial nerve canal. Many a times when the facial nerve is inferiorly displaced, many a times, this joining of the suprastructure of the stapes to the endosteal lever doesn't happen, and there remains an atretic foot plate. That is the embryology. Now the issue is, it gives conductive hearing loss and how to give hearing. 3 cases we have, I'll share the video, wherein we did the atretic foot plate and the lower down facial nerve. There is no possibility of any fenestra lower down.
Yes.
Almost to the promontory. And we did a fenestra above the facial nerve in the vestibule with good results. That's why the anatomy of understanding the facial vestibule is important. I demonstrated that time when I drilled the fallopian canal, I drilled the semicircular canal, and I showed that the lateral wall of the vestibule is covered inferiorly by the oval window. Only the anterior-inferior part. The rest of the oval window or the rest of the vestibule is covered laterally by the fallopian canal and the semicircular canal above. So what happens when the fallopian canal is gone displaced down and no oval window formed at the time of the embryo? What you can do, go above and make a fenestra in the vestibule, drill a fenestra in the vestibule, and still you can do a stepidotomy and works very well.
One minute, Padri.
Hello. Hello.
1 minute, Padri. Whenever you're creating fenestra in the vestibule, after fenestra inferior to the foot plate, please protect that with some perichondrium or vein graft.
Obviously, in difficult situation, always do that.
Sir,
but I
Satish,
tell you,
my question, Satish.
Yes.
Just a minute. We choose to do. I want to make it clear because I read it in Hugo Fish book also.
Yeah.
He says make a fenestra in the cochlea, 0.5 millimeter below the process, below and lateral to the cochlear processes cochleomics.
Not inside
so now
the
you choose. You're telling it to choose vestibule over cochlea.
Yes.
So what is your take for that? Why do you choose vestibule in place
yes, the
of
vestibule. Where are we supposed to do a fenestra in a normal situation of stepidotomy? Vestibule. Obviously. Okay. Now your foot plate, your facial nerve has gone down and made the oval window atretic. You can make a fenestra above and give a natural hearing the way you are giving otherwise. Number one.
So is it some specific place there you make up?
Yes,
because
yes.
you have to be very specific there. You cannot be...
Yes, I tell you. I tell you about... and you mentioned about the Hugo Fish. I will mention you, I will forward you an email. That was the article from Hugo Fish only, wherein they did 300, they dissected 300 odd temporal bones, and they discovered the distance of the vestibular end organs from the medial end of the foot plate. You know?
Okay.
From the medial end of the foot plate, how far is the saccule, how far is the utricle, anteriorly, posteriorly, superiorly, and they formulated guidelines that where one should put the piston. Where one should put the piston.
How much deeper?
Yes. So the inference was from their study, the best site for the fenestra to put a piston is in the central part of the foot plate inferiorly. In the central part of the foot plate inferiorly, if you put your piston, that is farthest from the vestibular end organs. So that was an amazing study from Hugo Fish. I will share email you today.
Superiorly, if we do it, if we have to do, if there is no place inferiorly, it is all atretic bone, then we go superiorly as you're telling that into the vestibule.
The problem is the inferior. I tell you, I got you what you're trying to say. Why not inferiorly onto the cochlea? The problem is inferiorly. How will you lengthen the incus? Number one. You don't get the length of the incus to put a piston onto the promontory. Number one. Number two.
Get titanium you can get now with all those angles.
No, see, for some millimeter length, what we have been doing now, we are using the bone cement to lengthen the tip of the incus. But for making a fenestra onto the promontory 3 millimeter down, you cannot lengthen the incus that much for that matter, number one. Number two, that has a possibility of a sensorineural hearing loss if you happen to injure the endosteum, cochlear endosteum. So in that situation, you have to be very careful. Just thin out the promontory bone of the promontory, thin out, and then flake off the last piece of the bone with the elevator. So you don't drill directly on the endosteum. Then put a fascia and put a piston onto the endosteum to prevent sensorineural hearing loss. That can be done for a little bit inferior from the whole window, but not far off, because lengthening the incus is a big issue. Any more? Paramita?
I think you will recommend vein graft or fascia over here.
Vein graft. Vein graft is ideal. See, so many studies done with the vein graft. When in stapes surgery, you know what God has given us a natural one, that is annular ligament. This tensile strength of the annular ligament is the biggest role in the impedance matching system of the entire ossicular chain. You know, yes. In terms of impedance matching, the annular ligament has the biggest role. So when you put there are studies done with the perichondrium, fascia, vein, and the histological architecture. When you put the vein, is almost, or I would say, out of all these structures, the vein has the closest tensile strength to the natural annular ligament. That's why vein is the preferred material.
So give us the clinical significance about the Mike's dot.
Paramita, I can't hear you. I don't know what is that.
Mike's dot, clinical significance.
What?
Mike's dot.
M-I-K-E.
Mike's dot.
What is that? What are you asking?
Mike's dot, superior ampullary nerve, related to the superior ampullary nerve.
Superior ampullary nerve.
Yeah.
The superior ampullary is a branch of superior vestibular.
Yeah, boss, they wanted to ask about that point. When you are sclerotinizing the semicircular canals, you leave a ledge of the superior ampullary nerve.
Yes, to protect the facial nerve.
Yes.
So that is to protect the facial nerve, and we'll discuss in the translabyrinthine approach in a tumor case when we'll go live, that how the superior ampullary nerve is the most important guide to identify the facial nerve.
Yes.
Okay. Sir, Dr. Sanjay Hellale is asking, what will be the cuts for subtotal temporal resection?
Pardon?
Annulus.
Pardon?
Dr. Sanjay Hellale is asking, what will be the cuts for subtotal temporal resection?
What will be the cuts? Yes. That is, I tell you, I already mentioned, that is the biggest procedure in the lateral skull base. So in that scenario, what you need to do, you have to do two craniotomies. One is the middle fossa craniotomy above, like we do for the middle fossa approach. And then one craniotomy behind to the occipital bone. And that way, that will separate, when you separate the dura after removing the bone piece, you have to transect every structure coming in the way, including intra-auditory meatus. Now you go inferiorly, like infratemporal fossa approach, and separate the vertebral artery, carotid artery, jugular vein, everything below. And then finally with the saw, you have to cut the jugular process of the occipital bone to separate the entire temporal bone in one piece. It's a supra major surgery in our live situation. In our hands, it takes almost 7 to 8 hours.
Satish, Dr. Murwani here.
Sir.
Can you hear me? Satish, can you hear me?
Yes, sir.
I told you about Dr. Majumdar. He used to do this, he has started doing this excision of temporal bone in 70s. There are 55, 60 cases.
They may be doing, I don't know what they were doing. But this technique, what I'm telling you.
That era was a crude era. You cannot see what instruments you have, what drill machines you have, what microscopes you have.
Better understanding of the anatomy today, and I know whom I am following is, this is a Japanese guy, Koyumo, who described in 2013. That publication was a landmark one, had the maximum citation ever in that year, in that 2013. That was the first live subtotal temporal resection, temporal bone resection and block. Mostly we do piecemeal, Any piecemeal surgery without any idea of the margin cannot be standard of care for that matter.
Malignancy.
Yeah, for malignancy. So in this subtotal, it is almost a total temporal bone resection except at the petrous apex, that you leave a small portion of the bone to protect the cavernous sinus and its nerves and the carotid artery. Third, fourth, sixth nerve, the carotid artery at the petrous apex, that is the final cut that you have to leave it, or for any tumor which invades the cavernous sinus, this is a contraindication. Otherwise, for any dural infiltration or any temporal bone tumor going in the neck, infratemporal fossa, anywhere, this is the technique for a radical resection like any other tumor, is subtotal temporal bone. And it is a Koyumo's research work in 2013 he published, was an amazing gateway he opened.
Sir, there are some few questions about cholesteatoma as well. Do you want to take up now or maybe the next time?
I think we should take question more towards the anatomy about the temporal bone we did today. Cholesteatoma will have a separate dedicated webinar.
Like microanatomy of the cochlea, if somebody has got some question, I think that is important. Microanatomy of the cochlea, if they ask, it is important.
Yes.
Yeah.
Anybody has any question regarding today's dissection?
So I think you've answered all of them. Only the juniors wanted to know initially more about the facial bridge, ridge, the anterior buttress, posterior buttress.
All those finished.
PG students
that will show in that next case, subtotal petrosectomy, we can rewind it again.
Yes, during petrosectomy we will discuss all cellular tracts, all anatomy cellular tracts.
Yeah. So I think
that while doing cholesteatoma surgery you can show.
Yeah.
Yes, but we'll do a separate dedicated session on cholesteatoma. Cholesteatoma, I tell you, out of all pathology in the temporal bone, there are thousands of varieties of pathology. The most mesmerizing, most appealing is the cholesteatoma management. Every case is different. And you have a target of achieving lot many things, not only hearing, but a dry ear and safety.
Satish, अक्खर जिसमें उल्टा-सुल्टा कुछ बोला नहीं है. Satish,
second in the
we'll follow your case also, sir, inside out.
So is there any safe distance between the vertical facial nerve and round window? There's a question from Lahore.
Yes. The normal distance, the safe distance means by means of radiology and gauging this distance, you can have a fairly good idea whether round window is rotated, unfavorable, medialized, difficult to access to the posterior tympanotomy. So if this distance is less than 4.5 millimeter or 4 millimeter, that means the round window is posterior-medially placed. So it may not be appreciable to the regular posterior tympanotomy. So that's a good idea you can have in the pre-op radiology.
Okay. Okay, sir. I think rest of the questions you have covered, sir.
We should not, because in last 3 webinars we had got lot many messages. People messaging that they put up their questions and we couldn't take up because of the time constraints. So we feel sorry about that. But still, if anybody has any question or suggestion, they can always text us and we'll definitely keep in touch.
Yes, sir.
One question from Dr. Sandeep Kumar. He's asking, in all the cases of cholesteatoma, you can just clear the sigmoid sinus area, take out the bone, or just expose the how you clean that area in cholesteatoma cases.
Which area?
Sigmoid sinus and dural plate.
Dural plate and sigmoid sinus, if there is cholesteatoma, a test to obviously it is difficult because you are on the verge of giving complication if you go beyond that. So sometimes we have a cholesteatoma attached, we mop with a wet cotton, sometimes we bipolarize, sometimes we use you know that that material, what you call that, mescaline, what do you call that exactly, we have in our theater. We pour that is a, you know, that divides the saccharide bonds in the cholesteatoma and dissolves it to certain extent to clear it from, that is mesna. You can use mesna, pour mesna for 5 minutes to loosen the cholesteatoma, to break the disulfide bonds, and you can use a wet cotton ball and mop it, blunt mopping, If you still have a doubt, you can bipolarize it to devitalize the epithelium. These are the various ways. And still, if you are not very sure, leave the open cavity rather than giving a closed cavity.
Satish, can I?
One point why Dr. Rajeev Jain, he's saying, Rajan from Lucknow, he's saying it is a hypothesis that when we disturb endolymph, chances of SN loss are there. But why it doesn't happen when you do the endolymphatic sac decompression?
Endolymphatic sac decompression?
Yes, yes.
Sac decompression is a hearing preserving surgery. We are not disturbing the sac at all. We are allowing it to expand. It is decompression. The pressure which has risen in the sac is to be reduced. So that is to remove the bone over it for the sac to expand. So that is a hearing preservation surgery.
Not only that, then we put a shunt also inside the sac.
Yes.
Just
to prevent, recurrence.
Yeah. Satish,
yes.
About the dura and sigmoid sinus, the important thing is they should decompress the dura further to find the plane between the healthy dura and the colostoma sac. Same thing on the sigmoid sinus, same thing on the facial nerve. If your sac is stuck to the facial nerve, dehiscent facial nerve that is, or dura or sigmoid sinus, you decompress further, find a plane of cleavage, and from there you can remove it easier.
Yes, sir. Mostly you get.
Yep, Satish, one good question from Dr. Prakash Monka.
Yes, sir.
Have you ever got a glomus tumor or any pathology while doing cadaver dissection? Because you have done more thousands of cadaver dissection.
In dissection, I got a tumor, huh?
Yeah.
You mean to say in dissection, I got a tumor?
Yeah, during this
yes,
cadaver dissection.
I was to get. The reason was somebody I think it was Murli who called me, that some patient who was, died of a tumor in the lateral skull base, and he donated the body and he wanted to dissect. It's already a tumor, though we didn't do.
Rajeev, once you showed a facial neuroma on a cadaver, a small facial neuroma you showed.
Yeah, that patient has a chance finding at a facial neuroma. Yes, boss, you're right. We had a patient once, cadaver.
Let me answer that question, Rajeev. Yes, more than 2,500 bones have been dissected in my lab by various
yes.
2,500 cases. What we have found is bifurcated facial nerve. We not found any tumor. Bifurcation of facial nerve is a different level. In a vertical course and things like that. But we not 2,500 temporal bone dissection been done in my lab. But everybody is not gone skull base. You know what I mean? When you're doing temporal bone dissection, everybody is not gone and open the jugular foramen completely. Most of the people, they're just a decomposition of facial nerve. So that is not a complete dissection of temporal bone.
Even right at present, we have
importance of vein of Lebe.
A vein of Lebe is an intracranial structure. That's the vein draining the temporal lobe of the brain.
Yeah, but there's a dangerous, if you damage that, they can get ischemia. That's a dangerous thing to touch.
Yes.
There's a dangerous
vein of Lebe is a very important vein in the neurosurgical procedures. And we should all make all efforts to preserve it. Vein of Lebe, vein of Dandy, are all intracranial veins.
Still at present, we have 6,100 plus people on board
there
right
was a
now.
question.
Sir, Dr. Manish Munjal.
Yes.
So Dr. Manish Munjal from Ludhiana is asking lateral semicircular canal cochlear implant experience and results similar to the round window one.
Lateral semicircular canal?
Implant.
Lateral semicircular implant for what?
Your experience.
I didn't get the implant going in the lateral semicircular canal. What?
So he's directly asking that you are not putting an implant in round window for any reason, maybe malformation and all. You are putting implant in the
lateral semicircular
canal.
No, it's not that. The round window or anything, I want the implant to go in a straight trajectory, in a tunnel, in the lumen of the scala tympani, so that it doesn't displace anywhere. And for that matter, convey my regards to him. Dr. Manish Munjal is one person who has been very, very committed and dedicated.
His birthday was a few days back, Satish. His birthday was a few days back.
He is also asking about the total and subtotal petrosectomy indication.
Yes, subtotal petrosectomy will show, I mentioned live. There we discuss, basically in subtotal petrosectomy, you exenterate all cell tracts of the temporal bone, leaving the labyrinth intact obliterating the eustachian tube to block off connections or source of infection from the nose, and a cul-de-sac closure to block off connection from outside, and then obliterate the cavity to create a sterile zone to prevent future infection. So you have to exenterate each and every cell, including mucosa, epithelium, everything.
Vinod Kandar.
I think Manish Manjal was asking about the vestibular implants.
Vestibular implant we have never done. Still the trials are going on. I heard Dr. Mohan Kameshwaran is doing a trial on vestibular implant.
It has got 3 electrodes going in the 3 canals.
Yes. The vestibular implant is still are not for the use in market.
Vinod Kandar is asking, what's your surgical experience with singular neurectomy in your
with what?
Experience with singular neurectomy results.
एक जना बोलो, voice is
singular
neurectomy is wonderful, though we don't have so many cases for that. Mostly cases settle down with the Apples. Mostly.
So
but
what
yes,
precautions?
We have done a couple of cases and amazing. Earlier we have done a canal plugging also. So this Apples is singular neurectomy is a very minor procedure, provided you keep the round window in view and intact.
Okay.
You can do transcanal under local anesthesia, and you get to know the point of success at the time of neurectomy only, as the patient develops a vertical downbeating nystagmus immediately after the nerve is sectioned. And that is a classical indication of the success, that you have separated the posterior canal sensations.
Kandel Wall has a good lab for vertigo investigation. He is very interested in treating the patient of vertigo. Kandel Wall.
Yeah. So Dr. Nageshwar Rao from Vizag is asking what precautions will be taken for a mal-rotated cochlea.
For the?
For the
mal-rotated cochlea.
Mal-rotated cochlea, yes. Mal-rotated cochlea is not a contraindication. First of all, we should be able to pick up during our pre-op radiology the malformation or the mal-rotation of the cochlea. Like you mentioned about the difficult round window, that is one of the indications that the cochlea is mal-rotated. There are many ways with a lot of angles are described, lot of distances described of the round window to the critical area, to the facial nerve, many things. So if cochlea is mal-rotated, you should be prepared to deal with that. Number one. Number two, like Pawan asked in the beginning, what to do if you are not able to expose the round window, you can mobilize the wall, or in the most extreme situation when nothing is working, do a subtotal petrojectomy. That gives you widest exposure to explore anything. It is the exposure you get with a subtotal petrojectomy is n number of times larger the exposure than a radical mastectomy or canal down mastectomy. What else you want for the landmarks to see? Subtotal petrojectomy gives you the best ability to identify the landmarks. So any difficult situation, subtotal petrojectomy.
Next time we have to cover radiology also for this temporal area.
According to the pathology, we will cover, boss.
But
in autosclerosis, we will cover the autosclerosis radiology. In the cochlear implant, we will cover the cochlear implant. In acoustic, we will cover the acoustic radiology.
Yes.
So there is one more question. Dr. Papalanyapan from Trichy is asking, can you demonstrate the landmarks for basal turn, second turn and apical turn approaches?
That's why I mentioned already. For basal turn, I showed the round window, inferior extension, and you are right in the basal turn. For the middle turn, I told you just anterior to the oval window and inferior to the processus cochleariformis. And for the apical turn, you have to go literally underneath the GSPN. I've already mentioned all three separately.
Any question left, because we don't want any complaint afterward. The last time so many questions were left.
No, complaint should be welcome.
Regarding questions,
we are so grateful. We are so grateful to Morwani sir for sparing his so valuable time.
His presence made ultimate.
He is our grand teacher. And still so actively involved. Whenever some academic activity is going on, he is always his heart out for everything. And thank you, Pawan, for being with us and your valuable inputs.
He's our evergreen hero. He's our evergreen hero.
Yes, ever energetic, fully energetic.
Will you tell us something about supratubal recess?
Yes, supratubal recess is a part of anterior atic, you can say. So I think we didn't cover the middle ear folds or the atic folds.
Yeah.
So there is a fold, tensor fold, once it is absent, just above the eustachian tube, the recess area which is communicated to the atic and the middle ear is the supratubal recess. So
lateral to your tensor tympani.
during the tympanoplasty case, we'll cover this aeration part properly in detail.
So people want middle
That's
ear
very important in the
ventilation
CSOM surgery.
So Sharkant Ghosh is, I think he's seen all the case, his webinars till now. Still he is there. He's saying thank you very much for ultimate demonstration. And something about cochlear implant gusher. So I think next time we will cover that part. And
yes, we'll keep.
About dissection, I think you've covered almost all the questions and you've answered almost all the questions. And
we'll
the rest
forward.
of the surgical related, the surgical related questions we can carry forward, sir. I'll select
And
we
we'll
can
carry
them
forward the dissection also sometime later to the advanced dissection of the lateral skull base approaches.
Okay, sir. So
Thank
Dr.
you.
Ashish Bhunkar is saying that 6,000 people attending this feat of superhuman excellence should each stand up where they are and give this great Satish Jain a standing ovation.
Oh, no needed.
Where is Dr. Bhunkar? I think he was here.
Ashish's ideas
You
always.
really deserve a standing
Excellent
ovation.
ideas.
So there are so many. So there are so many messages from all across that for the first time, the inner ear anatomy is the picture is clear for the first time.
Thank
Many
you.
of them.
Or anybody
today.
still has any doubt, you can text.
I will reply Dr. Bhunkar again, please. On the steppies panel, he has to be there.
Yes,
he should be there.
yes. That will be, I tell you, a mesmerizing session on stapes with Ashim and to the complications, the clinical conditions, the various surgical techniques, the diagnostics, and so many things.
And
all the best. Well done, Satish baby. Satish, very well done.
Thank you, sir. Thank you.
Thank you, sir. Thank you.
Miss, thanks to Paramita, our energy. Our energy of our team, Paramita.
Yes.
Yeah, thank you all.
sir.
Thank you.
Thank you.
अरे बुमकर झोपायला गेले का?
No. I'm scared of that girl. She's a taskmaster. So.
Where's your black t-shirt gone, Bumkar? कसली white t-shirt घालतो?
घरात आहे. Okay, great work, Satish. See you on Thursday.
Okay, bye. See you.
Thursday, what time it is?
4 p.m. sir. 4 p.m.
Okay, thank you.
Thank you, sir.